All right. Good morning, everyone. Welcome to the World TB Day 2024. My name is Payam Nahid. I'm a professor of medicine, and I serve as the director for the UCSF Center for Tuberculosis. I'm thrilled that you're all here to celebrate a couple of important events. One is the Curry Center's 30th anniversary, and the second is the commemoration of World TB Day, of course. So I welcome all of you in person and online. We have a terrific program for you. This program will show you some of the progress we've made, and at the same time, it acknowledges and recognizes some of the many challenges still that lie ahead. The principal challenge we had to overcome was that World TB Day is on Sunday, but we decided to spare you from having to come in on a Sunday, so we're having it today. But more seriously, you know, the TB rates, unfortunately, as many of you know, are having a resurgence, if you will. There's a sobering picture across California with a 15% increase from 2022 to 2023. In conjunction with that, there's an equally troubling uptick in mortality in California from TB, which is, again, sobering, from 8% in 2010 to 13% in 2020. These statistics really don't show the depth of the suffering of our TB survivors and those who die and the families that are impacted by this terrible disease. And that's why we're gathered here today to look at what achievements are behind us and what can we achieve going forward. What bolder, bigger ideas can we have to combat this scourge? Before we get into the program, I wanted to take a second to express my heartfelt gratitude to the planning committee members. Without them, there would be no World TB Day. So I want to say thank you. And if you could please stand up and you guys maybe let me finish the names and then you can do a round of applause for Paula Gongo, Sophie Huddart, Fatoumata Dabo, Chris Berger, Barbara Alonso, and Jenny Fong. Let's have a round of applause for them. Thank you. It's through their dedication and hard work for many, many, many months that we're able to have this event. We're also going to be recruiting 3 early stage investigators for those of you here are online. And you can define if you're early stage, maybe you're super excited about being on a planning committee, but not quite early stage. We might still consider you. It's a very elite group, but we are looking for 3 early stage investigators. Each year, it's the early stage investigators that bring their passion about TB and advancing the research and advocacy around it that build this program for World TB Day. Our early stage investigators here at UCSF are part of a growing training mentorship program called TB RAMP, TB Research and Mentoring Program. It's a program that's led by Dr. Elizabeth Fair, who's here with us in the audience. And this program is co-funded by the NIH-funded TB Research Advancement Centers. They're called TRACs, and you'll hear more about them today. And one of the exciting things about today's program is you'll be hearing from early stage investigators from the 6 TRACs that are around the US, from including UCSF, UC Berkeley, which is our partner TRAC. We've got an incredible program ahead for you today. It's really heartwarming to see so many faces in the audience. We're here to commemorate a special day in history on Sunday. But it's also quite humbling, the challenges that lie ahead. And I'm just so happy to see you all in the room. We can come together and work on this disease. And with that, I'm going to hand over to Lisa Chen.
Thank you. Well, I know it's just so wonderful to see all the faces that came in here. And I know people are still having a hard time finding the room because we had to cut off registration at 100. But, you know, you guys mean so much to us as the Curry Center. I am Lisa Chen, the director at the Curry International TB Center, a professor here in the Division of Pulmonary and Critical Care Medicine, and a proud member of the Center for TB. And I want to dive into the 30th step, but before that, I just need to put a plug in for an extremely exciting event that has just been announced in this last week, and that our very own Dr. Payam Nahid is now the director for the UCSF Institute for Global Health Sciences. So I know there'll be more said about this later on, but we are so thrilled and excited. It's a huge job, and it's an exciting job, and it's an exciting step for TB here at UCSF. So please, thank you. Tapping his bow and his turkey. Later on. But, congrats.
Thanks, Lisa.
All right. Well, so just to start off, a bit about our 30th anniversary. There's just been so much that's happened through these 30 years, and I wanted to make sure we really pay homage for a moment in time. This is the opening day of the Curry Center 30 years ago. Francis J. Curry, our namesake, is in the center. Phil Hopewell, Gisela Schechter, the co-founders. George Rutherford, he was here back then, you guys who are here in Global Health Sciences. He was at the State Health Department then. And Ken Castro was the leader of the Division for TB Elimination at CDC. And we are so honored and excited that he's here as our keynote speaker today. So 30 years ago, that was then. This is now. In that time period, the Curry Center domestically has trained over 60,000 TB providers, healthcare workers across the US. So I would say a huge percentage of the US-based healthcare workforce was part of our crew. Over 13,000 medical consultations fielded by our expert volunteers across the West Coast. There's over 80,000 hard copy. People still want books, you guys, of products having been distributed in the US and overseas. Our listserv, I know there's over 400 people registered right now for this event. It's because it's over 20,000 strong of the TB enthusiasts in the US consider themselves a part of Curry through our listserv. And then just our virtual presence, we can't even do 30 years worth, over 60,000 hits per year to our website. They're not just quick hits, they're at least 4.5 pages. So we feel good about being a resource for the country and for the Western region. But more than that as well, through Phil's work as a founder here, we've been able to do work across the globe. And I want to say, I'm so thankful in this room, we've got the next generation of young researchers. We've got leaders in research here, and that being a center for capacity building, we love the fact that we can then take research work, get it into true policy, international policy, local policy, global policy, and we can help bring it all the way to the front lines of practice. The implementation, the practice, down to the nurses at the front lines. So this represents just some of the work, and a lot of it is thanks to Phil and his outreach in there. But the International Standards for TB Care, that's the cover of the 3rd edition. The implementation for that, the seminal Patients Charter, first of its kind for TB work. The contact investigation work for the policies and the implementation guides for the WHO. Elizabeth Fair, take a bow. This is all stuff that under Phil's guidance as the Curry Center and with partners like the American Thoracic Society have been able to really touch policy around the globe. The pictures across the bottom just represent some of the technical assistance we've been able to do. Launching something really close to my heart, launching the first MDR program in this country of Tanzania. I remember when Gisela Schechter was there, in her head, she could calculate the predicted number of new cases that they were going to start on treatment in that year, the dosage, the number of bottles of medicine that they should be ordering from the World Drug Facility. She was calculating it right there on the spot. They were taking the numbers down. Lisa Chu is training the first set of nurses who took care of the first 7 patients. We were there when they were in the hospital, starting their MDR medications. And we've got the generations of leaders, even our PhD student here at UCSF, who is the WHO representative for the country of Tanzania, Johnson Limu, Riziki Kisonga. I remember on that first day, learning about MDR, treating those first patients. He is now the country director for TB in Tanzania. The same for Stavia Turabaya in Uganda. We've worked with Stavia when she was a junior person in the program. She is now the director of TB for Uganda. Our friend Erlina Berhan has done so much work globally for TB, representing Indonesia, and we've worked with her. Phil has worked with her forever. We worked with her in country as well on rolling out drug-resistant policies and trainings. So that's just, and ATS MECOR, again, something Phil has been a part of since the very beginning. Curry has been involved with in their capacity building of early stage investigators across 6 different sites around the world, and that continues annually, spreading the word. So what is the secret to success? I can say Phil and Gisela really represented what makes things work. It is the marriage between academia and public health, working hand in hand to make a difference, right? It's regional success doesn't mean that we're leading the way. We are augmenting and growing the regional expertise in the area. We're there to help and give a hand. And I think that's, again, made all the difference in the world and the rest of the region. And now, last year, we just moved here on campus. We are embedded in the hotbed of clinical trial work, new diagnostics, implementation science, policy and advocacy here at UCSF. I think that's the secret. But beyond that, it's the not so secret sauce are the folks that have contributed. And I just want, I'm hoping you guys will help me honor and thank the staff at Curry. I think Kelly Masoki, come on folks, stand. Kelly Masoki, our Deputy Director, Kay Wallace, our Director of Education, all you guys stand. Mari, our Internet Coordinator, our Program Managers, and Ruanchi Kumar. Lisa True is now our Senior Nurse Consultant. Please stand on up, Lisa. Where are you? There you are. Colleen Holland is online. Anne Rafferty, did she come in? She just moved over to the state, but we still consider her part of Curry. But along with that, you guys, in the room, a lot of folks who are former Curry staff members. Everyone keep standing. Former Curry staff, Liza, Lisa Stoller is here. There's a lot of people. Our Warmline faculty, please stand. Ken and Barry. Susanna, you're on Warmline. Our contributors in faculty, our contributors in to our guidelines. You guys all keep sitting down. It's actually half this room. We also want to honor our CDC colleagues and funders. There's 3 of the staff members are here that lead from DTB, the Centers of Excellence. Don Tucky, Nick DeLuca, Neela Goswami are here. Our former CDC leaders are in the room. Sundri Mace, Christine Ho. I know, I'm trying to think of who else is here that I'm not seeing from right here. You guys have to know that this is such a village of contributors. And I mean, I'm looking at the experts who hop on the case, everyone from our immunologists to everyone else who actually make a difference. Our community members, I know there are folks in the room from APTO who are on our advisory board, or they're going to be speaking. Our advocacy colleagues who have worked with us so closely. We have survivors on our advisory board as well. I didn't think they can make it, but this is what makes a difference. Because it's down to when you're sitting across the table with the mom with the kid with TB, you're putting pills in bellies, you're helping to train up that frontline nurse, you're going all the way to the policy and making sure that we connect and we get in the best research possible. This is how we're going to do it. And I want to thank the crowd who's here for being with the Curry Center for these 30 years. So thank you very much. And I'd love to introduce the next speaker. So the founder for Curry, Phil Hopewell. I don't know that there's much I have to say about Phil. He's a professor emeritus. Vision chief, associate dean at San Francisco General. He's been the president of the American Thoracic Society. He's won every major award in TB, both nationally and globally. And he's going to tell me to stop saying all this stuff. But he's, yes, I know. But it's just, I'm so glad that he's here to head things off the next part of this talk.
Okay.
Here you go.
Thanks very much, Lisa. I'd like to join Lisa and Payam in welcoming everybody. And it's great to see a lot of old friends and a lot of current friends who all share the interest in this disease that sort of brings us together. I just wanted to very briefly make the connection between the Curry Center and its founding and TB research as it is currently expanding here at UCSF. A couple of words about Frank Curry. He was the director of the Division of TB Control for a number of years, and in that position, he was highly regarded nationally as both an administrative TB control director and as an investigator. And he had a substantial amount of national influence in developing policies, particularly related to isoniazid preventive therapy, for example. There's a lot more in the, there's a lot more in the Curry Center website that describes Frank's accomplishments. The one that I have always emphasized is that after he finished as director of the Department of Health for San Francisco, retired, he went and worked in a clinic in the Tenderloin, serving mainly impoverished seniors, and worked there for a number of years. He really put his money where his mouth was. Just a couple of mentions of his research contributions. I would like to emphasize these two. These were enormous, I guess today would be called pragmatic studies, school tuberculin testing in all the schools in San Francisco. Kids were tested at three levels. And emanating from that, this report in the New England Journal on the prophylactic effect of isoniazid in young tuberculin reactors. He had thousands in these studies, and this New England Journal report on isoniazid prophylaxis showed a dramatic effect of isoniazid given for a year in preventing tuberculosis. So we've come a long way in 30 years. And I noticed in Ken's bio sketch that he was with his career at CDC was 31 years. So I would like to say we can take credit for Ken's success. His division funded us, and his career took off after that. So. But we have come a long way in 30 years. CDC funding wasn't always generous, shall we say. But being from West Virginia, this looked okay to me. But we have come a long way. And we've scrimped on our lunch money. We've had bake sales and done car washes and other fundraising activities, and now we have a much more elaborate, Curry Center. Some would say it's named for another Curry, Steph Curry, but in fact, this is where we are today. So but in fact, this larger center really should be renamed the UCSF Center for Tuberculosis that Payam and many others, Joel Ernst in particular, have developed, and that encompasses a number of areas of work shown schematically in this slide that you may or may not be able to read, but you can get a general idea of the scope of activities that the current center now encompasses. And just to indicate the areas in which Curry Center has contributions, makes contributions, I've circled these. The clinical services that Curry provides are those that Lisa mentioned of the clinical consultation for often complex cases from all over the U.S. or from all over the western part of the U.S. at least. And so these are Curry Center contributions to the TB Center. So I'd like to add my congratulations that Lisa described to Payam for his unexpected promotion to director of the Institute for Global Health Sciences here at UCSF. I think we're all quite proud of Payam and wish him well in what is a very big job. So with that, I'll close with this photo, and we'll introduce Ken, who is sort of unrecognizable down here in the there. And as as I said, we can take credit for Ken's success, and but Ken was longtime director of the Division of TB Control at CDC. Now is a professor of epidemiology at Emory, which he describes as having a license to hunt for funding, which is true of all academic positions, I think. And also is a consultant to USAID, the TB program at USAID that funds a major hunk of research in the SMART for TB program that we are part of here at UCSF, together with Johns Hopkins and the KNC, the Dutch Tuberculosis Foundation. I won't list all of the participants in the SMART for TB project, but Ken, you were there at birth. You were in the delivery room when we were born. So welcome.
Thank you, Phil. It's a real honor to be here with you today. And you're seeing tangible evidence that I was once thin and had pitch black beard, as I've told others at Emory when they saw this photograph. In keeping with today's theme, I've chosen to entitle my remarks, What's Past is Prologue, basically really acknowledging that history often sets the context for the present. In doing so, I will take many of you who've been around for a long time down memory lane, and those of you who are new, hopefully will share with you some of the advances. I will also acknowledge that tuberculosis is a millennial disease, and I'm just making an editorial decision to start from no more than 39 years ago and tell you what happened in the United States, then move and tell you what's been happening globally. This is the outline. So first I'll talk about the resurgence of tuberculosis in the United States, the contributing factors, the painful and powerful lessons, the local and national responses, and really you'll see me very selectively show you articles that were published and contributed to by the UCSF and other collaborators, but this is by no means a meta-analysis and a systematic review of the literature. It's a very biased approach to it. Then acknowledge the research advances that led to updated policies, and conclude with new challenges, renewed multi-sectorial mobilization to overcome the chronic disinvestments that have plagued tuberculosis both here and globally. So I come to you today as an evidence-based storyteller. This graph, for those of you who haven't seen it, is from a publication in JAMA by Mike Cantwell, who was an EIL officer at CEC, with Dixie Snyder, George Coffin, who I'm sorry to say passed away recently, and late Dr. Aidan Orato. Basically, they showed that following more than 3 decades of a steady decline, with TB incidence decreasing at a rate of about 5 to 6% per year, it came to a screeching halt in 1985, and there was a 20% increase in tuberculosis incidence in our country between 85 and 1992. And the George Coffin estimated that 52,100 excess cases occurred during that time that shouldn't have occurred had the original trend continued. And then you can see the factors associated with this situation: HIV epidemic, institutional transmission, the widespread occurrence and transmission of multi-drug resistant TB strains, the erosion of the infrastructure, and immigration from countries where TB is common. This chart comes from paper that we were invited to co-author, Charles Wells, summarizing the experiences in many places. So you can see a variety of hospitals with a number of people who had multi-drug resistant TB. More than 90% of them to 100% had HIV co-infection. And the mortality rate was unacceptably high, was at least 72% and went up to 98%. The rapid disease progression, the time from the diagnosis to death went from 6 to 16 weeks, or actually 4 to 16 weeks. I've added in here, not included in that, a replica of this occurring in South Africa in KwaZulu-Natal, reported by Neil Gandhi in 2006. And, you know, as Yogi Berra would have said, I read that paper and I said, it's deja vu all over again. Some of the problems unveiled during the MDR outbreaks during that time: number one, difficulties in diagnosing tuberculosis in persons with HIV infection, that you no longer saw the classic cavitary disease in the upper lobes. You saw disseminated postbacillary disease, extrapulmonary disease, and many clinicians were not suspecting that. Lack of real-time diagnostic results. We did see persons who died while waiting for their drug susceptibility test results, only to learn that the original strain had resistance to multiple antibiotics and met the definition for multi-drug resistant TB. Absence of infection control precautions. This photograph was taken during an outbreak investigation in New York City, where the person you see walking with the IV pole was a person who was supposed to be in respiratory isolation, walking past the nurse, and obviously no one was enforcing the measures for airborne infection precautions at the time. We witnessed the death of healthcare workers and prison guards, which led to a call to action, and you'll see that in the next couple of slides. So then I'll also talk about the cost of recovery, which was inordinate, but as I say, it's a matter of pay now or pay later, and usually it's a lot more later. Here are some of the lessons: the role of ventilation, rapid disease progression, and the value of genotyping. The first article shown here was by a young Chuck Daly when he was in training here with Peter Small, Gisela Sector, Gary Skolnick, and others, with Phil Hopewell as a senior author, describing an outbreak of TB with accelerated progression in a hospice for people with AIDS. Remember that at the time, we didn't have the antiretroviral agents that we now have, and people with AIDS had a very short life expectancy. I remember that as a clinician, whenever I saw someone with manifest opportunistic infections or CD4 counts that were in the double digits, their life expectancy was generously 2 years, if not less. I was part of an outbreak investigation in New York City with Michael Greco, where we saw many gay men with AIDS at Roosevelt Hospital in New York City. And that was that second publication that appears there. Then the other thing we saw, and there were these two companion papers that appeared in the New England Journal of Medicine in 1994, was the value of using restriction fragment length polymorphism. The earliest, well, before RFLP, there was genotyping, but this was a more refined approach using insertion sequence 6110 to identify the strains of tuberculosis. And Peter Small, working with colleagues in UCSF, described the epidemiology of TB in San Francisco, and David Land, working with colleagues, described it in New York City. And it really helped us further characterize the dynamics of tuberculosis transmission. Keep in mind that the natural history of TB in the absence of HIV is very different, and this truncated it in a way that we were able to study it in a way that no IRB would have approved had we designed the study. So here's something that is available online. In New York State, Officer Pietro Petrosino died of multi-drug resistant TB. The end of watch, which is what's used in the correctional guard jargon, was on October 24, 1991. And I quote here, Officer Petrosino died after being exposed to inmates with drug-resistant tuberculosis at the Auburn Correctional Facility hospital ward. That gave rise to a lot of concern from prison guards saying, what are you doing to protect us? We shouldn't be dying of MDR-TB. And following that, the Healthcare Worker Union in New York City and ACTA held demonstrations. This is around 1991 and 1992, and you can see a couple of photographs from that time period. That resulted in the release of resources, and just to contextualize, this busy graph comes from the Institute of Medicine report entitled Ending Neglect and Elimination of Tuberculosis in the United States. It's available in the National Academy Press, published in the year 2000. But what you see here is the response to tuberculosis after more than a decade of the absence of categorical TB funds between 1972 and 1982. By the way, those histograms that you see in 80 through 82 were just emergency funds. They were not categorical funds for TB, but they were allowed to be used for TB. But you can see how congressional representatives who heeded the advice and concern from all these groups increased the funding for tuberculosis at CDC, and that's what enabled us to start places like the Center of Excellence and rebuild the eroded infrastructure. And what you can see there is that the funding at CDC has been stable, but that doesn't account for the diminished purchasing power when you adjust by either consumer price index or other modalities. What did we do? We came up with a national action plan, and I'm sorry that some of it is in Spanish. Some of these slides I've used, and I just realized that instead of national, I call it nacional, but there's a national MDR-TB, and with the new resources, we really worked hard with our consultants and the field services branch to restore TB programs and training. I will pause here and acknowledge that Esther Sumartoyo had a very powerful paper that's not well known, published, I think it was in American Journal of Public Health, and it was a survey of credentialed clinicians through the American Medical Association, showing that of those surveyed, about 50% of them when asked about TB treatment, would have given the erroneous treatment regimen. And there was a clear need to retrain clinicians who were no longer used to seeing TB patients in the United States of America. There was a focus on directly observed therapy and treatment completion to overcome people who were started on treatment, but then there were lost to follow up. Another very powerful paper back then from Karen Brutney, and I'm forgetting her co-author's name, described how at Harlem Hospital of AIDS patients with TB in 1 year, only 11% were followed to successful treatment. The rest were lost or died. The other thing that we had to do was update lab diagnostic capacity. We moved away from solid media that take 6 to 12 weeks to liquid media that cut the turnaround time in half. Even that, in my personal and humble opinion, was too long. We implemented infection prevention control precautions dating back to 1994, updated treatment guidelines, and reestablished TB research capacity monitoring and evaluation. We had to redefine and protect the TB public health functions. There's that MNWR from 1995 that defines the essential component of a TB prevention control program, the core lab services for public health labs, and CDC ended up funding lab capacity at state health departments. And we also, at a time in the early or mid 2000s, when many in our country were saying maybe we should divest ourselves of these programs and maybe we should pay managed care organizations to do that, worked with Sarah Rosenbaum and UC Bestmiller. We co-authored this paper where we said, if you go into a contractual arrangement, make sure that you cover these key components. So we came up with what's called model specifications for managed care organizations to make sure that all the right things were done for tuberculosis. Culture-based, drug susceptibility testing, follow-up, patient-centered care. At the time, CDC sponsored TB centers, Curry Center, Rutgers, and the Harlem Center, the Charles Felton National TB Center, were initially funded 30 years ago. That configuration has changed. I think New York City continues to fund Harlem Center, but we now have 4 centers, and we'll talk more about that. The other thing we saw, it's powerfully illustrated by Kevin Schwartzman article in 2005, and Dick Menzies and a variety of other co-authors, including folks from CDC, is that if the United States were to invest in improving TB control in countries such as Mexico, we would see a big return for investment. That would be a lot cheaper to do it that way than to keep investing after people have come to the United States. And that paper was accompanied by an editorial written by Barry Bloom, where he talks about enlightened self-interest and why we should be spending in global tuberculosis. I've already made mention of this. This was a guiding light for us. The Institute of Medicine reviewed, is TB elimination feasible, attainable in the United States? And if so, what will it take? And they came up with a series of recommendations that we've heeded in the United States to make things happen. And they very powerfully had a quote that I think is very relevant today. The issue now confronting the nation is whether we will allow another cycle of neglect to begin, or instead whether we will take decisive action to eliminate tuberculosis. I'm going to pause here and share with you, I usually paraphrase Dr. Brown, who was part of the New York syphilis eradication campaign. I used to say, whenever you arrive and approximate the eradication of a disease, you're more likely to eradicate the program than the disease. And I think it really holds true. And I have a slide that I didn't include with that quote, but I'd be happy to share with you. The impact of reinvestment in the TB infrastructure. This paper by Tom Frieden and colleagues, Turning the Tide, showed that New York City had to invest about $1 billion to recover, but they did recover, and the incidence of TB came down significantly. The fall after the rise, we analyzed that in early mid-90s. And then as I was leaving CDC, we analyzed the averted cases and their economic costs averted in the United States over the 2-decade period. This is a graph afterwards, and this is what we did. We had a couple of counterfactual scenarios. Scenario one is, what if the rates had continued to go up as shown in scenario one? Scenario two is the rates start coming back down for at the rate of 5.1% for U.S. born, but not for for foreign born. And then you can see the actual cases, and then the difference is what gave us the ability to estimate. We estimate that using these different scenarios, at a minimum, 145,000 TB cases were averted during those two decades, up to 319,000. And the costs averted or societal benefits were $3.1 to $14.5 billion. And I think it's a strong case for the investment in TB programs. Other selected lessons from the investments early on, the implementation of the TB Trials Consortium demonstrated that the intermittent therapy for people with AIDS was not good, that you were likely to have relapses that were rifampin monoresistant. Then we see other advances in diagnostics and treatment of TB, as paper from Payam and Madhupai and Phil analyzing and talking about the prospects of newer technology that should be used. The TB Trials Consortium in 2011 had a very significant trial that demonstrated the safety and efficacy of a 3-month treatment regimen that consisted of once weekly isoniazid and rifapentine given over 12 weeks, so 12 doses. Pill burden was high, I will acknowledge that, but if I ever converted my TB, that's what I'm going on. I'm not taking 9 months of isoniazid. The 4-month rifapentine regimen with or without moxie also provides proof of concept and the ability to cure TB in less than 6 months. Other advances that you see at the top of the slide is a completion of what started as a Bangladeshi treatment regimen for multi-drug resistant TB at a time when we relied on injectable drugs. 18 to 24 months of treatment, they established the proof of principle that you could actually cure using this regimen, which included clofazimine and mostly oral regimens, for 9 months. And more recently, you've seen the remarkable improvement by using repurposed drugs such as linezolid combined with bedaquiline and protonamide, and the novel treatment is being used in the United States, and that's also shown in this other publication of the 6-month treatment regimen in the United States, with the first author being Connie Haley, and many of you having contributed to that. And we've also seen the push for a 24-week all-oral regimen for rifampicin-resistant tuberculosis. So that's a reality that I didn't think I was going to witness, and I'm delighted to see. Again, if I were to develop NDR-TB, you better not come close to me with the 18-month regimen. I'm taking the BPAL or something like that. All these drove evidence-based policies. Dr. Lisa Chen mentioned that earlier. You see here the updated American Thoracic Society, CDC, IDSA, guidelines, first author Payam, and many of you contributing to this effort. Then more recently, moving beyond directly observed therapy and establishing again the value of video directly observed therapy as part of many of these treatment trials and research activities. The paradox is we're back to the decline. There's a loss of medical proficiency and expertise. I can't tell you how frustrated I get when I see someone who's been bouncing between doctors with clear-cut symptoms and signs of tuberculosis, but no one suspects it. No one orders the tests, and then they get seen months later. So those delays in diagnosis probably contribute to ongoing transmission. There's a concentration of disease in at-risk populations, and we see the increasing role of social determinants of health. And we see festering outbreaks in the United States caused in part by these delays in diagnosis, ongoing transmission, limited funds to support optimal patient-centered therapy, relapse, leading to relapse resistance and transmission. I was talking with Dawn Tuckey a few minutes ago, and she was telling me that CDC is down to 16 public health advisors. When I was there at its peak, we had 66 public health advisors and at least 8 medical officers in the field. So you can see clearly the erosion taking place right in front of us. Contact investigations, to me, is crucial, and people tend to do it in a very sloppy manner. Break back your contacts and let me get them tested. That's not right. The centers of excellence, the outcome have been quite clear. You can see the California multi-drug resistant consult service described here by Neha and others of you here. The then Sundry wrote one of the first papers looking at the medical consultation centers, and more recently Neela, who's also in the audience, published this other accounting of the role of these centers in places like the United States. This is the new funding cycle. What CDC did was, instead of just having TB centers of excellence, they're now linked to neighboring states, so that if you happen to be, and by the way, I think that as of a year ago, this may be no longer valid, because I think that the Mayo Clinic took over the Texas Heartland Center. But what you see here is that if you happen to be in Texas, you shouldn't be calling California for your medical consult, or New York, or elsewhere. So it's more regionally based approach. I wanted to digress here and acknowledge that many of us who were trained in tuberculosis were taught not to pay attention to latent tuberculosis, because that's not where the action is. Worry only about people with TB disease, and let those who had latent TB be. These modeling exercises by Chris Dye, published in 2013, replicated for the United States by Andrew Hill, Jose Becerra, and I in 2011, show that you really need to treat people with disease and with infection if you're going to bend that curve to where you want to get to. This is showing the projections for TB case rates, and this is projections for TB deaths. So I'm not going to dwell on this. You can go and look at the reference. But the point here is that that made the global TB community emboldened. And during the 2018 UN high-level meeting on tuberculosis, the first of its kind, there were commitments specifically to treat successfully 40 million persons with TB, including persons with drug-resistant TB, and another 30 million with TB infection. Of course, they call for increasing the investments and how member states need to be committed to taking concrete actions. The world came to standstill. There came COVID. We were all in lockdown. Services were messed up. And what I show here is from a report in the Global TB Report by WHO, 2028. Please take a look at what I show in the red squares. The reallocation of TB staff to COVID response. I was part of that, and many of you were part of that. 85 of 184 member countries and 20 of 30 high burden countries had that experience. They reallocated funding, 14 out of the 30 high burden countries. In fact, I was working with Botswana to implement the National TB Prevalence Survey, and I got a call in March of 2020 saying, Ken, the survey is off, the money is going to COVID response in our country. So we've seen that time and time again. The repurposing of gene expert machines to use the SARS-CoV-2 cartridge instead of the MTB RIF cartridge, RIF cartridge, happened in at least 13 of those 30 high burden countries. But not all this doom and gloom. You know, any one of us who works in public health needs to always look at the glass half full. And there were mitigation strategies implemented which successfully overcame that in many settings, but it was not easy, and it came at a high price. For the first time in several years, TB incidence globally dropped 18%. In the United States, it was about 19-20%, and we're seeing evidence of recovery. For the first time in over 15 years, TB deaths came up by 100,000. It had been steadily declining. That's that lower graph that WHO reports on. So the progress towards high-level commitments, not surprisingly, were not as we wanted. Only 84% of TB treatment, only 52% of persons started on TB preventive therapy. In terms of investment, only 44% of the funds required were invested in TB research, is about 50%. So, of course, we didn't meet the target because of COVID, because of lack of funding, because of lack of access to latest diagnostic tests, and slow rollout of TB preventive therapy. The new challenges, Payam, this is an area close to his heart. One size doesn't fit all. We in TB have always promoted this. Make it simple, make it programmatically implementable. But you're not doing a service to your patients. And the precision and personalized medicine is a way of the future, given what we've learned about how some people tend to respond better to treatment regimens, how others may require longer duration of treatment. And I'm showing here some of these publications addressing this. And I know that Payam and I have had conversations about this some years ago. We're also seeing an explosion of the use of digital chest radiographs with artificial intelligence, what's being called computer-assisted diagnostics, or CAD for TB, as a way to screen populations at risk for tuberculosis. And at the bottom, I placed the analysis of a phase 2b trial showing 50% efficacy of the M72AS01E vaccine. We just learned a few days ago that the Gates Foundation is moving this into phase 3 trials, starting in South Africa and moving to different other countries. The other thing that we've learned that it's posing to me an immense challenge is the large burden of people with TB disease who deny having cough, fever, night sweats, or any of the symptoms that we normally ask about. These people don't seek care. They feel well. What are we going to do about them? And there's evidence that they're contributing to transmission, as shown in that first report. This second report is from March 12th, a meta-analysis. And in many settings, national TB prevalence surveys where you go door to door, you invite people, you screen them by X-ray, then you collect samples, at least 50% denied having any symptoms. So this is something that we really need to confront and not stick our heads in the sand about. Other challenges is addressing the comorbid conditions associated with TB. These are the population attributable risks. Undernutrition is accounting for more than 2 million of the 10 million cases reported by WHO. You can see HIV, alcohol disorders, smoking, and diabetes. TB is unfortunately a tracer of poverty. These two graphs come from WHO. There's an inverse relationship between TB incidence and gross domestic product, and a direct linear relationship between nutrition and TB incidence. On the positive side, the global TB community has come together, and actually another person who's out of UCSF, Paula Fujiwara, led this charge. The updated global plan to end TB. This is a funded a plan with a cost price. They estimate that we would need about $250 billion, 209, let's round that up to 210 billion for high priority interventions, almost 34 billion for research and development, new medicines, regimens, diagnostics, and vaccines, and about 7 billion for basic TB science and research and development. I'm delighted to see that later today, we're going to be hearing about that research and the output of that research. And the milestones for tracking progress are also mentioned here. And as you can see at the bottom, the targets may need to be revised if we don't get to them in the time that we've set out to accomplish them. The other nice thing that this global plan has done is estimate the cost of inaction. We don't do this. An additional 43 million people with TB disease and 6.6 million deaths will occur, and that's going to cost $1 trillion. A lot of that work led to the second UN high-level meeting just last September, new targets, and again, calling for new investments. And you can see that we went from 40 million treated for TB to 45 million, and now the target is 45 million for people to receive TB preventive therapy. Surrounding that, some people have asked me, is there any value on these UN high-level meetings? I say, I was a skeptic, but I say absolutely yes. Number one, you have the heads of state making commitments on TB, who in turn hold their ministers of health accountable. Then we're seeing John Green has done a fantastic job, and surrounding that high-level meeting, USAID and PEPFAR announced that they had secured a 30% reduction for the drugs that used for the 3HP regimen from 14.25 cents to close to $10. The global drug facility secured a 55 and a 33% price reduction for bedaquiline from Johnson & Johnson and Lupin, respectively. And Danaher also was to provide expert ultra cartridges at cost if purchased through the global drug facility. So you can see that there's that opportunity for change. The US government is committing to ending global TB. USAID, as you heard earlier from previous presenters, Payam, Phil, and Lisa, is funding Smart for TB, as well as other activities, as well as need to acknowledge that the US is the biggest contributor to the global fund to fight AIDS, tuberculosis, and malaria. And in the last replenishment, they contributed $24 billion. That was the replenishment hosted in 2022. This is what we're now seeing, and I'm probably in violation of my time limitation. It goes to show you can spend 30 years being trained on how to deliver a presentation on time, but you can disregard it altogether. So this is the latest instance I understand from Phil LeBou. By the way, he used these slides at a congressional briefing last week on March 14. So incidence rate in the United States is 2.5 per 100,000. And yet we also heard from some of you, oh, by the way, I prematurely neglected this. This is the reality for cases reported in the United States in 2022. Basically, 3 out of every 4 persons are born outside the United States. That's the global reality hitting us right here in our midst. Then when you look at US born persons, look at the high percentage of Hispanic, Black, Latino that are afflicted by this. And this is really challenging us to do better with the implementation of programs, and 5% American Indian or Alaska Native. This is from a recent February publication where and state-line TB cases on the rise, but public health agencies say they lack the resources to keep up. Aren't we back to where I started this presentation? Since this is a quote attributed to Donna Wegener, the head of the National TB Coalition instead of the National TB Controllers Association. Since 1994, funding for CDC's division of TB elimination has declined by about 60% when adjusted for inflation, according to a division analysis provided to Donna. So clearly there's plenty to do. I hope to have shared with you that the history has placed the context to the present. Yet past disinvestments in TB gave us the unprecedented resurgence. I don't want to see that repeated under my watch. Painful lessons at the price of preventable morbidity and mortality. We're about to see that again. The reinvestments yielded TB decreases and costs averted. The national and global research advances in rapid diagnostics have shortened treatment regimens, relied on use of video DOT, personalized medicines prospects, and hope for safe and effective vaccine. And my ultimate goal in life is to see such a damn good vaccine that there's no justification to have a TB program, but we become part of the immunizations program of CDC, if that were to be true. I don't think it's going to happen in the immediate future. There's plenty of work for all of us to be doing. You can see that what happened during COVID, the global setbacks, along with new challenges and opportunities for accelerated progress. I co-authored a commentary with Phil and Lee Reichman saying, many of the lessons that we seem to be learning during COVID, we had previously learned on tuberculosis. And in fact, that's why many of you TB workers with expertise were uniquely useful for the COVID response. You knew what contact tracing was about. You knew what airborne infection control precautions are about. So diagnosis of a disease that in the case of TB, it's a bacteriologic diagnosis. In the case of the other is a virus, but still, microbiologic evidence of the pathogen you want to see. And it's clearly evident that continued political commitment, public pressure, and added funds as sustained gains are going to be crucial if we're going to ever see the end of tuberculosis. And with that, I want to share with you that although what's past this prologue is really a quote from William Shakespeare in The Tempest, this is on this statue right outside the National Archives building. So if you go to Washington, make sure you stop by. It's called Present. And Robert Aitken is the sculptor tribute to this. So I think it's on the west side of the National Archives building. Thank you so much for the work you do. Thank you for your attention. I hope we have time to engage in Q&As. I know that there's also a virtual audience that we need to be attentive to. Thanks.
Okay, thanks very much, Ken. That was a very complete summary of where we were and where we are. Our questions from the audience, comments. And I want to specifically call on Gisela to make a few comments, given that she was part of the origin of the Curry Center.
Thank you, Lisa. Thanks very much, guys, for what you presented. I'll present a little bit of a context. Forgive me for a little nostalgia. I think back to those years, 30 years ago, at the corner of Folsom and 18th, with the parking lot full of bougainvillea. And I have very fond memories of that place. And I truly mean fond memories, because what I tried to bring to the founding of this Curry Center was taken from Francis J. Curry, the emphasis on the individual patient and the importance of dealing with every single patient's immediate and future needs, and how much fun it was to work with patients over time and bring them back to health, and how much fun it was working with Bill, Ken, everybody in this, those in the room who were there, Lisa, and especially I'll shout out to Peter Small and Chuck Daly, who were fellows at the time and really contributed so much. And I loved working with the young people like Peter and Chuck and how much they contributed. And I wanted to emphasize always, that coming to work should be fun. And I tried to make it for the Curry Center as well. And some of you might remember all the artifacts that were on the walls in that building, from Samoa, and to try to capture that world experience. So I'll leave it at that. Thanks for letting me make the comment.
So questions for Ken?
Are you monitoring the chat from
Yes.
virtual? Great, thanks.
And I've got a question for you. Payam shared the California numbers. I know the national numbers are not yet announced yet, but I understand they're coming very soon and people should be watching. Every other day, there is a Californian who dies from TB. That's the data that Penn and Barry had just shared. And I noticed how we've made progress with drug access and drug pricing globally. But right now, and I'm looking at Susanna and Janice from the TB clinic here, our programs across this country are having problems with accessing drugs. Our programs don't get the price breaks that are happening across the globe. In fact, one case of MDR going on this new fabulous regimen is, basically decimating a small program's budget for the year because of public health funding that have been flat funded or decreased through the years. You've problem solved a lot of things, and I know you're not in the hot seat anymore, but what would you suggest to us? How do we help move the dial? I know my CDC colleagues in the room would love to move the dial if we could, but you've always been a forward thinker. What would you do if you were in that seat now?
Don't get me started. So let me first acknowledge that the U.S. taxpayer dollars pay for the global drug facility, and I find it unacceptable that we do not benefit from that. So let's lay it out up front. I think that we need to work with FDA to get them to approve drugs that are in the list of approved drugs at WHO so that we can import them into the United States. Not unprecedented. Just recently, I read that FDA enabled the introduction of drugs for syphilis at a time when we had a shortage of penicillin for the injectable penicillin. And I think we really need to push hard. I think we need to unleash the community to demand that this be done. I don't know that these are poor quality drugs. In fact, they're quality assured by WHO standards. So, of course, the other problem that we have is that none of these producers of drugs want to spend the money that it would take to get them FDA approved for a pittance of what there's they don't see a return for that investment. But having said that, I think that, and by the way, I've been in conversations with the people who run the global drug facility. They stand ready to send us the drugs the moment that we say the drugs can be imported into the United States. So I think it's time for a rebellious type of action with FDA and others saying it is unacceptable that U.S. taxpayer dollars are funding the global drug facility, and we do not benefit from that. That's my starting argument. Then go from there.
And the same could be said for the new diagnostics.
Absolutely.
I know a lot of people in this room are funded to do the R&D that basically leads to the access to these rapid diagnostics. It was easier for me to get a expanded gene expert cartridge in Tanzania way before I could get it in Alaska. And I fully agree. And in fact,
Cepheid has already announced that they're not going to produce anything but Ultra, and yet in the United States, I don't know that Ultra has been approved for use. Yeah. So you have that conundrum that we face here. And then there are many other drugs, pardon me, not drugs, diagnostics. TrueNath, produced in India, looks very promising. There are many others. In fact, Madhupai just recently co-authored a commentary. There's a whole list of really promising agents, including for drug-resistant TB. I mean, what we witnessed back in the late 80s, early 90s, of patients dying while waiting for their drug susceptibility result, and having a line probe assay that can give you a result same day within minutes, if not hours, is the way to go. And I'm going to have to channel Paul Farmer. You know, the injustice, thinking that some people, I'm going to paraphrase him, health is less worth than ours, is the root of all injustice in the world. I mean, in many ways, we need to push back and say this is unacceptable.
Okay.
So somebody's, yeah, I can't read the sign you're holding up. So
wrap up.
We'll wrap up.
Wrap up. Time to wrap up.
We have a question online.
Yes.
Apparently, some online.
Yes, we have a question from online from Baby Ruth Garing, which says, how true is it that the active cases we have in California right now are due to latent TB cases that were never treated?
I could talk to this, but the surveillance chief in the California Department of Public Health for TB is here in the audience. And he's also my partner co-editor of the Survival Guide. So here.
How true is it that the active cases we have in California right now are due to latent TB cases that were never treated?
Yeah, well, so we estimate using some genotyping data to look at what proportion of cases are due to recent transmission and a few cases arising soon after arrival in the United States. If we take out all those cases, what remains is more than 80% of our cases that we attribute to untreated latent TB infection. So this is the data underlying efforts to roll out LTBI testing and treatment to try to bend that curve, as you said, Dr. Castro.
More questions? Sindri with that. Thanks.
First of all, thanks so much. Fantastic presentations by all. But I wanted to piggyback on what Lisa said, because it's not just a lack of access to the drugs, but it's drug shortages. And this has been going on, as we know, forever. And we've been talking to, FDA. We've been talking with all of our partners, yet we don't have a solution for these drug shortages. In fact, I think actually the survey that was performed by CDPH and CTCA, looking at counties here in California, shows how they've impacted programs and even negative outcomes. So I want to put in a plug for exactly that, the Global Drug Facility, and reaching out. In fact, the Stop TB session that we're going to have in NAR and NTCA next month, we have a speaker from the Global Drug Facility.
Who's coming?
Who's the, do you remember? Winning? It's the director, yeah.
Brenda Winning, she's great.
Yes. And so I invite everybody to come to that.
I instigated you to ask her the hard questions.
Oh, I know. So we can open the dialogue at least, because I know 10 years, 12 years ago when we reached out, there's no way, no how we were going to get drugs from the Global Drug Facility. But just a plug for that. And actually in the U.S. affiliated Pacific Islands, Dick Brostrom is leading the charge to use, it's a non-FDA approved formulation of 3-HP, which is a combination, and it cuts down the pill burden significantly. So why can we not move forward towards this? Because I'm very sad to say that no one's using 3-HP. After all of the time and effort that went into the clinical trials and the post-marketing surveillance, all of this, and yet nobody uses 3-HP. So just a plug for us to try to use the tools that we have and use them better.
Thanks, Andrea, and thanks to all of you for participating in this. I guess
I could see we have two things. I know Priya really would like to ask a question, but then we have to give Elizabeth time to step up to the stage. So
let me just do this because I saw you.
Sorry, I had to get in on it. Thanks for that really wonderful talk. I just want to piggyback on a couple of the ideas and make a plug for how to talk about TB in the context of this country and low incidence settings. And a lot of what the discussion has been around about drug shortages, lack of political will to kind of, leverage the global drug facility, et cetera. I think from a lot of the research that's gone on, and you referenced this in your talk, is related to underlying social determinants. And if we're really explicit in this country, the only way to make the argument for return on investment is as an equity argument, because among US born, only Black and brown populations are struggling with TB, and the rest are primarily non-US born, also Black and brown populations. So what are we really talking about, and how do we include equity as a primary outcome and how we advance these discussions? And so any tips about that are always welcome.
Tip is go vote. Yeah, I mean, it depends on who's in the administration. I bet you could have an administration that's totally insensitive and wouldn't care less. And there are different administrations that will go on and try to do the right thing. So go vote. I'm not telling you who for, but you get the drift.
But foreign born people are not able to vote. Like until you go through this painful immigration process and then become green card holder. And that process that we have all these missed chances to treat latent TB is actually a very painful process. I went through that myself. It is not a process where I look back and have warm, fuzzy feeling about, right? Like it's not, it was very painful. And that these a lot of missed opportunities and just not, these are the people without voice.
Yeah.
It can help enroll voters to vote and encourage them and give rights and reminders so they can be part of the process.
Just very briefly, and I'm digressing, in the medical school, there are a bunch of students who are working with the American Medical Association about making sure that during every patient encounter, you also ask your patients, are you registered to vote? As part of the care we provide is also raising awareness about the importance of that.
Okay, I think
you can tell I'm no longer at CEC.
You can speak the truth. Okay.
Well,
thank you all.
Yeah, I'll get us transitioned to our next week. But first of all, please thank both Phil and Ken for coming, flying in and joining us, because it's because of you guys that all of this got started here at UCSF. So thank you very much. I'm going to hand the mic over to our own Elizabeth Fair because she has a very special announcement, and Payam's coming up.
We are stealing the mic for just a brief interlude here. First of all, my name is Elizabeth Fair. I'm one of the co-directors of the Center for TB. You've already met Dr. Nahid. We are representing leadership of the UCSF Center for TB and delighted to announce the inaugural Phil Hopewell Mentoring Award.
A newly created award.
Newly created. So this is... So this is a new award presented by the Center for TB in honor of Dr. Philip Hopewell and in recognition of dedication to mentorship in the tuberculosis field. A unique feature of this award is that the nominations came all from early stage TB investigators. So the award recognizes Phil's remarkable mentorship of several generations of TB experts within UCSF and globally, and honors an individual in the same spirit of generous and exceptional mentoring. I'm sorry, this is we could say a lot about Phil, and I think he needs no more introduction in this audience here. I think Payam and I, along with so many of you in this room, were privileged to be lifelong mentees of Phil. And I think it's safe to say that his mentorship shaped us both as researchers, as professionals, and as people. A little bit more about the award. It acknowledges an individual who exemplifies exceptional mentorship in TB, including a demonstrated commitment to mentoring and empowering early stage TB research investigators.
Okay.
Do you want to?
Yeah, shall I make an announcement? Where's the envelope? Well, we are thrilled to announce the inaugural winner of the Hopewell Mentorship Award. And that will be, drumroll, Dr. Aditya Katamanchi, Professor of Medicine at UC Irvine and also at UCSF. Congratulations to Aditya. Now, oh wait, no, he's not here. He's in Geneva, but just as they do the Nobel laureate call minutes before the announcement, we're going to try and call Aditya, who does not know that we're calling, and we're going to see.
Might not even know about the award.
I don't think he even knows about the award. No, that didn't work. All right, let's try again. Let's try a different way.
Recognize your number.
He's blocking it. He's blocking it. Let's see. Give me a sec. You know, the Nobel calls don't always go to plan. Let's see what happens here. Oh. Oh.
He really doesn't know anything.
Hello.
Hey. Hey, man.
Hey.
What's going on?
Not much.
Where are you?
How you doing? I was meeting with Claudia and Puneet, but I just hopped out.
Oh, cool. Thanks. Say hello to Puneet and Claudia. You're on speakerphone, by the way, at the World TB Day event.
Oh my God. What is going on?
Well, we wanted to congratulate you because you have been selected as the inaugural winner of the Hopewell Mentorship Award.
It's such a huge honor. I'm really shocked that's why I'm getting called out of meetings.
Yeah, well, just like the Nobel Prize, we wanted to let you know right as it was announced. So, but congratulations, Aditya. We'll tell you more about it. But first, I want to read you, or Elizabeth's going to read you a couple of the nominations, just so you hear how much you're loved.
Congratulations, Aditya. It's Elizabeth.
Thank you.
So I just wanted to share, instead of talking about Aditya, I wanted the voices of the nominators, the early stage investigators, to be heard. So one nominator wrote, Aditya exemplifies great academic mentorship. He's endlessly supportive of his mentees and will give us the resources and the kick in the pants pep talk to take big swings in our research. His leadership shows us it's possible to excel in an academic career that prioritizes collaboration over competition. Through working with him, we've learned that there is room on every paper and every grant for our collaborators around the globe, and that this is an essential step in promoting more equitable global health research. And another nominator wrote, because of Aditya's efforts, we now have a large cadre of early TB researchers that will continue to make a large impact in the field. Moreover, he served as the model for the next generation of TB mentors.
Man, I'm at a loss for words, guys.
You're
really
lost.
touched. Thank you so much. It's really, really a huge honor, especially given the amazing mentoring work Phil has done. So honestly, this is all trying to continue his legacy.
And Aditya, Phil is on stage here listening as well.
Yeah, they by mistake let me have a mic. But Aditya, Payam has likened this to the call from the Nobel Committee to the Nobel Prize winners. Don't count on $1 million.
But you do get.
Here's the award.
You do get a
I'll
plaque.
deliver it to you next week.
You get a beautiful plaque with your name on it. And again, many congratulations, Aditya. We're very proud of you and for everything you've been doing in TB, and your mentees are so grateful for the leadership and support you've given them. Congratulations.
Thank you all, and I'm really sorry I wasn't there, and now I'm even more sorry.
All right, go back to your beer and,
All right.
and say
Thank
hello
you.
to Puneet and Claudia.
All right, I
Bye.
will do. Thank
Bye.
you guys. Bye.
See you.
Okay, switching gears now. Let's see. We're moving into session 1, which is the TB research advancement early stage investigator presentations. I believe we have early stage investigators from all of the 6 tracks online who will be presenting here. And I have both the exciting and slightly daunting job of presenting very quickly what the tracks are. I know you've heard Payam referred to them in the introduction, and we wanted, for those of you who aren't familiar with them, to have a sense of the scope of this new investment by NIH. So TRAC stands for the Tuberculosis Research Advancement Center. It's funded by NIH, NIAID. It's a P30 Center Core Grant. And I like to think of it, for those of you who are familiar with CFARS, the Center for AIDS Research, which are really well-established funded mechanisms through the NIH. These are like mini CFARS for TB, and really signals sentinel funding, I think, from the NIH into TB. This was initiated just in 2022, so it's a new mechanism. Thus far, 6 tracks have been funded in this first cohort. And I just wanted to share a little bit about what is common across some of the tracks. And then I've got a slide on each of the tracks that just to show you the breadth of work people are doing across the country. So all of the tracks have a developmental core, which is really focused on mentoring, training, research opportunities, and science cores. And the primary goal really is to invest in the next generation of TB scientists, both early stage and those who are new to TB, to bring great expertise into the TB field. There's a focus on promoting interdisciplinary work, inter-track work. We're spending a lot of time thinking about how we can collaborate with the center, all 6 tracks across the country, and international collaborations where the bulk of tuberculosis is. These tracks really do increase the profile of TB. It's a deep investment in TB at each of these institutions. And as I said, attracting new to TB researchers. So some of the common themes that you'll see across the track cohort, the 6 tracks, are pilot awards to early stage investigators and new to TB. It's really investing in that seed money to get research launched. Mentorship program for early stage investigators to facilitate that transition from postdocs, fellowship into independence. There's lots of different consultation services that I'm going to highlight on each of the different tracks. They bring their unique set of skills to the work that they're doing and what they're offering through this. And annual events like this. So seminars, talks, open to other people. Also listed here are some of the inter-track activities, events like this. The session we're having right now is ESIs from other tracks. Some of us got together at the union meeting in Paris, et cetera. So trying to really not just deepen our work here, but cross-fertilize across sites, and looking at co-funding programs. So very briefly, we were provided 1 slide per track. I don't dare present other people's work, but wanted to put up on the stage or on the slides each of the 6 tracks. So this first one is Johns Hopkins University. They, as you can see here, they have sort of grant development programs. Many of the programs have that developmental awards, that seeding. In addition, they have clinical and scientific cores listed here, and unique to Hopkins, they have a bioinformatics, modeling, and biostatistics core. And by core, it means really providing support, resources, consultation in these areas. They have a clinical core, a pharmacology and pharmacometrics core, as well as a microbiology, immunology, animal modeling, and imaging core. C-TRAC is the second track, based in Seattle at University of Washington. Again, this shows some of the highlights of what they offer. Similar developmental core offering awards, mentoring, and unique to C-TRAC, I believe, is a data science core. So bringing in their expertise in data science that you can see here. NYC track is a collaboration between Weill Cornell Medical College at Cornell University, Rockefeller University, and Memorial Sloan Kettering Cancer Center. Again, you can see the similarities in the administrative and developmental core, offering lecture series, peer support, mentoring, grant writing support, as well as, just to highlight here, their clinical science core. They've got large clinical cohorts, as well as a curated biobank of clinical samples from Haiti. The Texas Biomed InTrack is an interdisciplinary next-gen TB research advancement center. As you can see here, they've got quite a few different cores that really bring out their expertise. Some of them are the BBC is the biocontainment core, AMC is an animal model core, RIC is research imaging core, and the CRPCC is a clinical research and patient care core. So again, different expertise across different sites that hopefully, the idea is we can all begin collaborating across cores. The Emory, Georgia, Ken, I feel like you should present this, not me. Ken is affiliated with, again, highlighting similar professional development, mentoring, et cetera, and unique cores in clinical basic science and systems biology, but a huge amount of work that they've pulled together really focused on TB. And finally, the UC track, which is a really an equal partnership between UCSF and UC Berkeley. We have a basic science core that is co-led by Babak Javid here and Sarah Stanley at Berkeley, offering accelerator awards like Boost Awards to pay for support in BSL-3s. We have a clinical science core led by Priya Shetty and Patrick Phillips, which has a robust consultation service. They're putting together a data catalog. Unique to ours is we've stood up a community advisory board. So you can see here in the numbers, we have a community advisory board with 7 members representing 4 different countries that will review protocols, et cetera. And the developmental core that I lead with Art Reingold at Berkeley, offering pilot awards through the UCSF RAP mechanism. We've got the TB Ramp Mentor 2-year mentorship program, and also unique to ours is a global fellowship program that we're just launching now to provide some mentoring and research support to our colleagues who work in LMICs with opportunities for research funding and stipends. And of course, the admin overall core puts on events like this. We've got the Bay Area TB scientific symposium in September, et cetera. So I think that is an overview of the cores, and really just to highlight the opportunity that this creates, the investment from NIH and TB, I think in the last couple of years, really feels unprecedented in this field, and it's very exciting. So stay tuned, and if you're interested anymore, you can look these up on the website. So with that, it's a pleasure to invite Dr. Sophie Huddart, who's an assistant professor here at UCSF in the Department of Epidemiology and Biostatistics, as well as a TB Ramp Scholar alum and a real driving force between this World TB Day. So I'm going to hand the mic over to you, Sophie.
Thank you so much, Elizabeth. It is always one of my pleasures at World TB Day to moderate these early stage investigator sessions. And I just think it's so critical to give early stage investigators the floor and highlight the incredible work that they're doing. And I'm so excited that this year we can highlight the breadth and depth of research happening across the tracks. This next cohort of US TB researchers is really exciting. So we have 6 people to bring up. We, unfortunately, due to time, they only have short little 5-minute talks, but it really gives us a chance to appreciate the vast diversity of TB research is going on at these tracks. And since we're going to start with the UC track, just because host's priority, I guess. And so I'm happy to bring up Dr. John Budzik, who's an assistant professor of medicine at UC San Francisco, where his lab studies innate immunity to tuberculosis infection.
I'm very grateful to the UC TRAC, the NIH, and the UCSF Department of Medicine for supporting our work on using proteomics to identify new host pathways that respond to TB infection. And I'd also like to thank the conference organizers for the chance to share this work today. Macrophages are one of the first innate immune cells to get infected with tuberculosis, but TB still grows in them. It doesn't get killed very well by them. And our hypothesis is that the host proteins that are getting phosphorylated in macrophages during TB infection are mediating signaling changes that are important to allow TB to grow inside these host cells. And so if we could better understand what are those host proteins that are getting phosphorylated in the macrophages during TB infection, we could hopefully design host-directed therapies to better kill TB in our innate immune cells. And so our approach to do this, and with Jeff Cox's lab and Nevin Krogan's group, we developed a mass spectrometry method to a proteomics approach to look to understand and identify what are all of the host proteins that are modified during TB infection in macrophages that are infected compared to mock infected control cells. And then to test the hypothesis that one of these host proteins we found from this screen here is important in controlling TB infection, we infected mice that are either wild type or deficient in that phosphorylated host factor. And what you can see here is that this particular host factor called Tax1BP1 is actually promoting TB pathogenesis because mice that have that gene are dying earlier than those that are deficient. And then using cell biology experiments here in macrophages ex vivo that we infect, we can figure out how does this host protein change the cell biology of the macrophages to promote TB growth. And here in this experiment, this fluorescence microscopy image, you can see that the macrophages that have Tax1BP1 up here are not dying from apoptosis compared to the deficient macrophages down here. And apoptosis is a mode of cell death that is protective against growth and spread of tuberculosis. And then using genetics approaches, we are making knockouts of other host proteins that we found from the screen to figure out what role they play in TB pathogenesis. Here's this Sanger sequencing tracing of knockout macrophages that we made using CRISPR-Cas9. And you can see at this site here, there's a disruption in the genome sequence of the macrophages, indicating our ability to knock out various host genes in macrophages to study their role in TB pathogenesis. So overall, we're using proteomics, genetics, and in vivo mouse animal infection models and ex vivo macrophage infections to try to unravel how TB thwarts innate immunity.
I will give you a chance to ask questions of our ESI superstars, but I'm going to make you wait till the end. So keep those questions in your head. Thank you so much, John. All right, we're going to move online now. Thank you to our Curry team wizards who make this all look very, very easy to get everyone on the screen, even though it is not. And our next speaker is going to be Dr. Karolina Maciag, who is an acting instructor at the University of Washington. She received her PhD in immunology from Harvard Medical School and her MD from the Harvard MIT Division of Health Science and Technology. She did a residency in internal medicine at Johns Hopkins and her fellowship in infectious disease at the University of Washington. Thank you so much, Karolina.
Well, thank you so much for the Curry Center for this opportunity to share our science. And thank you to TRAC for allowing me for the opportunity to act as an ambassador for our center. So. Great. So I appreciate that Dr. Castro pointed out the imperative for the development of an effective vaccine against tuberculosis. So with a disease that's difficult to treat and that may be transmitted asymptomatically, vaccination will be required to combat the pandemic. And in truth, we still don't know what the elements of an effective vaccine against tuberculosis are. There's several reasons for this. So TB has been with us for over 10,000 years and is an expert at evading the immune system. TB invades and affects lung tissue, which can be challenging to study. So it's no surprise that patients aren't lining up to contribute pieces of lung tissue to research efforts, nor would we want them to. And of course, TB is largely a disease of the disenfranchised, which has further dampened recent research progress. So thanks to support from the NIH and other sponsors, the lab of my mentor, Dr. Kevin Erdahl, is focused on discovering elements of a protective immune response against TB to inform the development of a more effective vaccine. So as Dr. Budzik noted, TB infects macrophages, which are phagocytic cells in the lung. The macrophages gobble up TB and they try to kill the mycobacteria, but TB can manipulate them from within, so they're unable to kill. So TB then replicates in the macrophages and goes on to infect other cells. And as a shout out to my colleagues, in 2018, Dr. Sarah Cohen, who was then a postdoc and is now a research scientist in the lab, and others in the Erdahl lab published findings showing and highlighting the critical and distinct role of alveolar macrophages and monocyte or bone marrow-derived macrophages in the establishment of TB infection. So vaccines are typically assessed. So again, the goal is to have a protective vaccine that will induce macrophages, which are the main host cell of MTB, to kill the mycobacteria instead of letting them survive and even replicate. So vaccines are typically assessed based on their ability to elicit interferon gamma producing T cells upon exposure to antigen. So this works for some infections, but for TB, this measure has not reliably correlated with actual protection. Furthermore, within the past 15 years, a couple of publications using the mouse model have come out to challenge the role of T cell derived interferon gamma entirely. So here's an example of why we use the animal model. So in a in a study that we can obviously only do in model systems, mice that had no T cells and were infected with TB succumbed to TB disease quickly within about less than 50 days. Mice with no T cells that received an IV transfusion of wild-type T cells survived much longer. Mice that received T cells that lacked interferon gamma did achieve some protection. So the protection was not perfect. They did survive a bit longer. So this is expected since many parts add up to make a complete immune response, right? Well, another publication, again, went further and said that even though there are interferon gamma independent mechanisms of T cell protection, this publication suggested that interferon gamma from T cells plays a minimal role and can actually be harmful. So this is really important to know because the type of vaccine we give will determine protection, and we want to protect and not to harm. So two main provocative questions. To what extent is T cell derived interferon gamma actually required for protective immune responses to MTB in the lung? And then if there is some interferon gamma independent protection from T cells, what are the protective pathways induced in macrophages independently of T cell derived interferon gamma? And so what I'll show you today is addresses the first question. So when we tried to improve on the mouse model that was used in prior studies that used adoptive transfer, basically a transfusion of T cells. So instead we used a T cell chimera model, which I'll summarize quickly to mean that we took mice that specifically lacked T cells and we gave them bone marrow from donors in a way that those mice that bone marrow was able to mature over the period of 10 weeks and then develop a full T cell repertoire. So we ended up with mice that either lacked T cells completely, had completely wild-type T cells, or interferon gamma knockout T cells. But again, these aren't transfused T cells, but these are T cells that have matured, went through regular selection and maturation in the host mouse. So then we took our mice, our T cell chimeric mice, and infected them with MTB. And this method is really the core of the results that I'll show you very quickly below. So we found that mice that had no T cells and mice that were wild type actually didn't lose weight over the first 30 days of infection, but mice with T cells that lack interferon gamma actually did terribly. So clinically, we tried to take this experiment out to longer, like maybe 35 days, but these mice were dying earlier than that. So there's something about interferon gamma deficient T cells that may be pathologic. So furthermore, those T cells that lack interferon gamma do not decrease the amount of TB. So on the y-axis, you have the amount of TB in the lung, and in the spleen over on the right. Mice that had the wild-type T cells were protected a bit by about a log, but the interferon gamma deficient T cells in our, we think, more physiologic model did not provide protection against TB in the lung or the spleen. And we repeated this experiment 6 times and got the same result each time. And when we asked a veterinary pathologist to look at these lungs in a blinded fashion, they concluded that lungs with interferon gamma knockout T cells had more necrosis, as well as more severe and extensive lesions, as well as an infiltration of eosinophils, which was surprising. So we looked at the distribution of cell types in the lung using flow cytometry and found that indeed there are more neutrophils and eosinophils in the lungs of mice where T cells lack interferon gamma. And we verified these results using confocal microscopy. Just to highlight, in the mice where T cells lack interferon gamma, we see lots of eosinophils, which are the small yellow cells, as well as the red cells, which are neutrophils, which are known to be pathologic in TB infection in the lung. So we looked at cytokines in the lung to kind of get from the whole organism down to the to a molecular basis. And we found that when T cells lack interferon gamma, these mice have a lot of Th2 cytokines, IL-4, 5, and 13, and they completely lack overall interferon gamma, meaning that other cell types like NK cells really are not picking up the slack and producing interferon gamma as they may do when T cells lack interferon gamma. This leads to macrophage polarization differences. So when mice have normal T cells, macrophages express a lot of NOS2, making nitric oxide and other anti-mycobacterial effectors, whereas when they're Th2 skewed, when T cells lack interferon gamma, they make arginase 1, which is a M2 or alternative macrophage polarization marker. So overall, when T cells lack interferon gamma, we don't protect against TB infection in terms of number of mycobacteria. We have mice that are more ill and they progress towards death faster. We have more lung lesions. And we have increased influx of neutrophils and eosinophils to the lung, and macrophages have this alternative polarization. Oops. And this is important because we want to maximize protection and tolerance to disease. And again, our results show that when T cells lack interferon gamma, you don't have either of those. And we need a Th2 balance, a balance between Th1 and Th2, which leads to polarization, classical or alternative among the macrophages. And we think this may be relevant to protection against TB, particularly because we need a vaccine that would protect against TB in areas where both TB and helminthic infections, which lead to Th2 cytokine milieu, are endemic. So I'd like to thank everyone, especially my mentor, Dr. Kevin Birdall, and funding from CTRAC, including the New Innovator Award, which has really made this work possible. Thank you.
Thank you so much, Karolina. That really drives home just why developing a TB vaccine is so difficult. Our next speaker is Dr. Hedwin Kitdorlang Dkhar, who is a staff scientist working with Dr. Jyoti Rangarajan and many other collaborators at Emory University in Atlanta. He joined his current lab after his postdoc with Drs. Josephine Clark Curtis and Professor Roy Curtis at the University of Florida. So take it away, Kit.
Can you see? Thank you, Sophie, again for the introduction, and thank you to UCSF TB Center and the Curry International TB Center for this wonderful event. And also thank you to all the viewers. We are almost like 200 online. So today, as we commemorate the discovery of Mycobacterium tuberculosis, we are all gathered here to discuss about the challenges and success in research and clinic. Today, I'm going to share with you one of the problems that we are trying to investigate here at Emory and in collaboration with the bioengineer at Georgia Tech from Krishnan Duroy's lab. So the problem is that during MTB infection, there is vast information about the expansion of a very heterogeneous myeloid-derived suppressor cells, or MDSCs, which are recruited and infiltrate into the lung-infected microenvironment, which they are now in conjunction with other immune and non-immune cells. And they have been well established in tumor and cancer model where they have an immunosuppressive function where they suppress the immunotherapy. And they have been well classified using flow cytometer and single cell RNA-seq, where you can see both in the mouse and the animal model, there are different surface markers which can identify these MDSCs. And also the main features of these MDSCs are that they have these immune suppressive mediator like IDO, INOS, arginase 1, and also they secrete IL-10. And there is this function of impeding the function of other immune cells like T cells and other myeloid cells. So we hypothesize that these features of MDSCs might be suppressing the protective immunity against TB, even though the proportion of cells that they are might be low, but we still feel that it might cause an change in the lung environment during TB disease. So to look into this problem and how to deplete these bad cells, we, in a collaboration with the bioengineer at Georgia Tech in Roy's lab, they had shown in 2021 when they systematically delivered the synthetic nanoparticle, which have a bifunctional phase where one side of the nanoparticle, these are gold nanoparticle, which can target the surface of MDSCs, and the tail have the FC mimicking ligand, which can be seen by the activated macrophages or neutrophils, and they can act in an antibody-dependent killing of these targeted MDSCs. So they have shown this in the splenocyte 4T1 tumor model, and so in collaboration, Jyoti and Krishna DeRoy had a NIHR1 grant where we are looking into depletion of these MTB-induced MDSCs. For example, I'm going to show you 3 groups that we took. We had a control nanoparticle without any peptide, and we had the S100A89, which is called as the G3 SNAP, and the CD124 SNAP. So when we infected the animal with a low dose 100 CFU MTB into the C3H animal and gave 2 doses of the nanoparticle at day 18 and 21, and then I designed a 20+ color multi-parameter flow cytometry and look at these CD11b positive myeloid cells. You can see it's a heterogeneous population of myeloid cells, which constituted of DC macrophage and neutrophils. And also, and this dotted line, which is a population 1, is the signature, is the population which is constituting these granulocytic MDSCs. So using multi-parameter flow cytometry, I was able to look into the individual features that were contributing to this population. And you can clearly see that this population 1, which I annotate as granulocytic MDSCs, have a very high IDO. They express CD124, they have cyclic F, they have arginase 1, and these mediators are not present in the neutrophil, which is a population 2. So using this immunophenotyping, when we look into the individual animal, so I'm showing you here the representative of each animal from each group. So here, this is the control. You can see that a lot of MDSCs are present, but in the G3 SNAP and the CD124 SNAP treated animal, there were like less GMDSC, which shows that the specificity and the efficacy of the nanoparticle. And we can quantify this by looking at the contribution of each animal into the population. And you can see that compared to the control, both the nanoparticle treated animal had depleted MDSCs. And we also look at the neutrophils, and we did not see any change in the neutrophils, showing the specificity of these nanoparticles. So while we depleted the MDSCs, we were interested to look at the impact on T cells, and you can clearly see here that there is a better T cell function which increased cytokine secretion like interferon gamma and TNF. And also using Ki67, I was able to look at ex vivo the proliferation of CD44 activated T cell. So these are very exciting results that we found, and the outcome of both depletion of MDSCs and the better T cells function and proliferation was reflected when you look at the bug burden in the lung. So you can clearly see that by depleting these MDSCs, there is a reduction of the bug burden. And since we have looked at 3 weeks, we are very interested now to investigate this problem at a later time point, where to study more about the impact of the lung environment and the immune response and the function in disease context. So since these nanoparticles share the peptide that we use share the sequence with humans, in collaboration with Chris in the lab, we were able to establish this in vitro model of expansion of PBMCs, MDSCs, and we treated, I'm showing here with the S100 SNAP, when we treated these expanded MDSCs with the SNAP, you can clearly see that there is a depletion of these MDSCs, and they are the same that have IDO1 and INOS. And when I do a high dimensional reduction of both the expanded without and with the SNAP, and use the immunophenotyping for annotation of these population, you can clearly see that this population 3 have a very high INOS, which is rare, IDO, and they have an intermediate HLA-DR, which is known classification for MDSCs. And also, interestingly, we discovered that these expanded MDSCs had a very high CD206 and CD200R. And based on this observation, we have also synthesized new particles that we are trying to target the CD206 MDSCs in the human PBMCs. And again, when I split this UMAP into the untreated and the treated, you can clearly see that these SNAPs were able to deplete these MDSCs even in the human. So I would end by saying that the problem that we are investigating is very important, because if we label these T cells and co-culture them with the MDSCs, which is a very classic assay in all the tumor and cancer model, we also see here in our hand, in our lab, that yes, they have a very strong immune suppressive function. And hence, we are very interested to look into these MDSCs in different disease condition and depletion using these SNAP particles. And maybe we'll better understand the function, and maybe it could be a good target for host-directed therapy in a lab. So with that, I would acknowledge the funding support from NIH, EVC, and then all support of members of the Rangarajan lab here, and also the Flow Core. And also, I would say I'll thank Emory TRAC for support for the other projects that is ongoing, where I'm looking at the omics of the lung. We're using single cell and metabolomic assays. Thank you very much for listening.
Thank you so much, Kit. That's really exciting. It feels like science fiction come to life to have the nanoport.
Thank you.
Okay, so next up, we're lucky to have Dr. Riti Sharan, who's an assistant professor in the host pathogen interactions program at Texas Biomedical Research Institute. Dr. Sharan is a trained microbiologist and immunologist with over 12 years of experience in animal models of infectious diseases. Dr. Sharan obtained her PhD from Central Queensland University, Australia, and did her postdoc training at the Pasteur Institute in France. Thank you, Riti.
Thank you so much, Sophie, for the introduction. And I would like to thank INTRAC for organizing this event today and for giving me the opportunity to present. In my independent lab, which is fairly brand new, I study preclinical animal models to study TB-HIV co-infection. So TB is a curable and a preventable disease, but we still have over 1 million people die of it each year. And despite this ongoing burden, the funding for TB and TB-HIV research is pretty inadequate and flatlined really since 2018. And as you can see in this figure over here, the Stop TB Partnership and Treatment Action Plan report in 2020 showed that a mere $900 million were raised in comparison to the commitment for achieving the UN goal of $2 billion annually. And so the need for this increased funding is to essentially be able to better understand and model TB infection as well as TB-HIV co-infection. And so people who are living with latent TB infection have an increased risk of developing active TB because of HIV co-infection. And so we try to model this in our rhesus macaque model, wherein we understand the mechanisms of what leads to this reactivation. We know that there is a drastic decrease of CD4 positive T cells, and that there is initiation of ART, which is antiretroviral therapy, that increases the risk. But we have, and some other people have recently shown, along with my previous mentor, Dr. Deepak Kaushal, Dr. Smriti Mehra, that there is chronic immune activation that is driven by the virus during very initial stages of co-infection, that in addition to the CD4 depletion is a correlate of the reactivation. And so our model really allows us to do a lot of the state-of-the-art techniques, such as single-cell and spatial transcriptomics, in addition to the traditional and standard flow cytometry and pathological and clinical studies, to really understand the targets that can be directed for host-directed therapeutics in future. And so today I will be giving you a snapshot of one of the recent studies I completed under the leadership of Dr. Deepak Kaushal and Dr. Smriti Mehra, wherein we wanted to understand if we concurrently treat our rhesus macaques that are co-infected with ART and 3HP in the same regimen that are given to humans, are we able to bridge the immune gap that ART treatment alone is not able to do? And so for this, we compared 4 different cohorts: LTBI only, ART naive, which essentially means co-infected but not treated, ART treated alone, and then ART plus 3-HB. And so for this, all of the macaques were infected with a low dose of TB. They were co-infected with SIV and then given 12 weeks of treatment of ART plus 3-HB and then euthanized. And so when we look at the CRP values, which is essentially C-reactive protein, it's an inflammatory marker that associates with TB risk. If you look at the purple group and the blue group, we see that they are pretty similar, indicating that clinically, the treatment is able to maintain the clinical manifestation of inflammation and keep it under control during the tenure of the study. When we look at the pathology, if you see the on the panel on the left, we see that the lowest most column is the ART plus 3-HB, and the pathology really looked pretty similar to what would be seen in LTBI animals. And it was much better in terms of the different scores criteria compared to ART alone or, of course, not treated animals. If we look at the panel on the right, which shows the percentage lung involvement, it is an amalgamation of a number of criteria that the pathologist scores on. We see that pathologically as well. The treatment with ART and 3-HB definitely shows results that are similar to what would be seen in a LTBI only animal. However, much to our surprise, when we did the immunophenotyping of the T cells in the lung as well as the BAL, which is the bronchoalveolar lavage in these macaques, if you look at the purple and the green groups on the right, it is seen that they both are pretty similar, which is the ART or ART plus 3-HB, and that both these groups are significantly less compared to the blue group, which is the LTBI group, indicating that the CD4 T cells are not really getting replenished to the levels that were originally seen when the animal just had LTBI. When we further immunophenotyped these replenished CD4 T cells into central memory and effector memory, you clearly see that there is an expansion of the central memory response after the SIV co-infection. But then when you look at the lowermost panel there, we see that after treatment completion, we don't really see the replenishment of the effector memory responses. We know that effector memory responses are very important because they are responsible for the polyfunctional cytokine responses that are really critical for controlling the TB infection. We are now further doing single-cell RNA-seq on these samples. So we are essentially collecting the BAL samples at week 5, which is LTBI, week 11, which is co-infected and treatment has not started, week 13, where they have been co-infected and treatment has been given for a couple of weeks, and necropsy or end of 12 weeks of treatment. And what we are seeing so far is really important in terms of understanding what the therapy is doing to immune responses, in that we see upregulation of pro-inflammatory genes, KLF6, ICOS, and NF-kappa B. We are still seeing a reduced IL-22 and IL-23R expression, and we are seeing significantly reduced Th1 response gene expression. So overall, we conclude that despite lowered pathology and an earlier and effective control of the virus, ART and 3-HB are not really reconstituting the skewed effector memory responses, and they're not really able to control or dampen the chronic inflammation response that is ongoing in the lung. So now in my lab, I'm trying to continue studying these from a different perspective of looking into the MTB-specific CD4 and CD8 responses. And here you can see clearly that when there is a co-infection at week 11, there is a drastic depletion of MTB-specific CD4 T cell responses that are not replenished despite treatment. I'm also performing single-cell RNA-seq on these samples, as I have mentioned before, but I wanted to give another snapshot of how we are able to study them time point-wise and look at a number of other cell subsets. I'm only showing CD4 T cells, NK cells, gamma delta T cells here because they show the most obvious decrease in the Th1 repertoire of responses. And I'm also right now writing up and doing some pilot studies to look at the host-directed therapy. And here we propose to use IL-21, primarily because IL-21 has been shown to very successfully control chronic immune activation in SIV-only infected macaques that are on ART therapy. And so essentially we have the hypothesis that if we are able to provide this IL-21 in conjunction with the standard therapy, we would be able to really have a better bridging of the innate and adaptive immune response during the earlier phase of co-infection through STAT1 mediated Th1 response, STAT3 mediated Th17 response, and a fully differentiated NK cell response to overall result in a better quality of immune reconstitution. I have also recently completed a study that I'm analyzing data for, wherein we have also done cohorts of macaques that are treated with ART, and then they are also the ones compared to in which the ART is interrupted. So essentially, we treat the macaques, co-infected macaques, with a certain number of weeks of ART, And in the other cohort, we interrupt the ART to mimic what happens in humans and really see if the treatment is able to provide a sustained immune response and what happens to these immune responses, in particular IL-22 and Th17, when there is an interruption, and what are the markers that can then be targeted to really help in designing of the host-directed immunotherapies. And then finally, I'm going to conclude by saying the most recent project that I've taken up for myself is the establishment of humanized mouse model. And the reason for doing the humanized mouse model in the lab is to be able to really look at the lungs and the granulomas at every time point, which is difficult to do in rhesus macaques, especially because of the cost, and perform some very high-level spatial transcriptomics and RNA-scope to correlate the presence of TB and SIV in these lung granulomas from different cohorts of macaques and understand the cell space location, numbers, and gene expression of CD4, CD8, NK, IL-21, and Th17 responses. And so with that, I would really like to thank INTRAC for providing all the facilities and resources that I need to perform my research, my mentor and guide, Dr. Deepak Kaushal, Dr. Smriti Mehra, Dr. Larry Schlesinger, Dr. Joanne Turner, and the INTRAC Developmental Core and Admin Core for providing the platform to continue to do this research in TB and TB-HIV. Thank you so much.
Thank you so much, Riti, for highlighting just how much nuance there is in that interplay between HIV and TB. Our next speaker that we're going to bring up is Dr. Andrea Doltrario, who is an infectious disease physician from Brazil. She's currently a postdoctoral associate at Cornell Medicine and works with urine-based TB biomarkers.
Good morning, good afternoon. It's a pleasure to be here. My name is Andrea Doltrario, and today I'm going to talk about my TRAC-funded project with novel urine-based biomarkers for diagnosis of pulmonary TB in people co-infected with HIV. And briefly, sputum-based TB diagnostic tests lack sensitivity when performed in people living with HIV/AIDS. And to remedy this situation, we proposed using liquid chromatography, mass spectrometry, metabolomic technology to discover urine-based biomarkers that can then be used in the future for the development of point-of-care tests. We used urine samples from patients enrolled in the SDR-TB clinical trial conducted in Haiti. This trial included only patients newly diagnosed with HIV who presented symptoms, could be cough, night sweats, fever, or weight loss. And our final cohort included 304 patients. 76 of them were diagnosed with pulmonary TB, and 228 were age and gender matched to compose our control group. Our main hypothesis was that TB disease in people living with HIV/AIDS is associated with an overlapping set of urinary biomarkers as those without HIV. And we had two specific aims. The first was to conduct a targeted analysis focusing on 10 metabolites previously discovered by Flonza-Isa to be elevated in pulmonary TB cases. And our second aim was to perform an untargeted analysis to discover a complementary set of people living with HIV/AIDS specific biomarkers. And here on the slide, on the right, you can see a table from Flonza-Isa publication with a little more detail about these 10 previously described metabolites. And a little bit of my progress so far, I extracted the metabolomic data from the 304 urine samples by conducting the LCMS experiments in batches, and I performed the targeted analysis we proposed in name 1. And this analysis, we obtained that uridopropionic acid, metabolite unknown 1, and hydroxyuridine are also elevated in urine samples from our TB patients. As I show here on the left with this volcano plot. And on the right, I also show the violin plots of each of these 3 metabolites for the control and for the TB groups, along with the p-value of each pairwise Mann-Whitner comparison. And our results actually built up on the previous analysis by Flonza. And I highlight here on this table that she discovered these metabolites in mainly HIV negative patients. And my cohort was 100% of patients infected with HIV. So in summary, we were able to demonstrate that there is an overlapping set of metabolites that are associated with pulmonary TB, both in patients with and without HIV co-infection. As our next steps, I want to complement these results with the untargeted analysis, which I proposed in AIM2, and also conduct a pathway analysis. I want to perform additional stratification of our patients, especially stratify our patients for the CD4 count to account for the degree of immunosuppression, and also another stratification based on how they were diagnosed in the clinical setting. I want to evaluate the influence of other covariates on these metabolomic abundances and to perform a diagnostic performance evaluation of these metabolites individually, but also combined in biosignatures. So thank you for the attention. I want to say a special thank you for all the people listed here in this slide, especially Dr. Curry and Dr. Daniel Fitzgerald, that were my mentors in this project. I want to say thank you for the clinical trial team and all the participants that were enrolled, the TRAC clinical core to facilitate the access to the samples, and the TRAC for funding this project. Thank you.
So much, Andrea. That's a really exciting signal that you're describing, and we look forward to following along with your future results. And we are at the last stop of our little track tour here with Tess Ryckman, who is an instructor at the Division of Infectious Diseases at Johns Hopkins. Dr. Ryckman's research involves the use of mechanistic modeling and cost-effectiveness analysis to inform policy decisions through deeper understanding of the natural history and transmission of infectious diseases. All yours, Tess.
Great. Thanks so much, everybody, for the opportunity to speak today. My talk is entitled Population Modeling and Economic Evaluation to Inform TB Policy. And much of my research is focused around this broad motivational question of how can we most efficiently reduce the burden of TB. I aim to answer this question through a combination of population-level infectious disease modeling, as well as economic evaluation or cost-effectiveness analysis, and use these methods to answer questions such as which interventions are most likely to impact the population-level burden of TB, which interventions are likely to be the best value for money, and increasingly, what can we learn about underlying TB epidemiology by synthesizing different and diverse sources of data in mathematical models. Topic-wise, my research is focused mainly around active case finding, novel regimens for TB treatment, as well as TB preventative therapy, or TPT. One project that I would like to highlight today is a recently completed analysis of the population-level impact and cost-effectiveness of scaling up household contact investigation and short-course TPT for household contacts, as well as for people with HIV. And this research was really motivated by quite low coverage globally and in a lot of countries of TPT among household contacts, particularly older children and adult contacts. So the mathematical models that I and my collaborators built to conduct this analysis are described on the left of this slide here. We started with a population of household contacts stratified by age at the point of potential contact investigation, and then we modeled screening and diagnostic algorithms and simulated the results of those algorithms, including initiation of TB treatment for people who were found to have active TB, or initiation of TPT for those among whom TB disease was ruled out. We modeled the sort of eventual TPT-related outcome, including whether TPT was initiated, fully completed, or only partially completed. And then as a result of this model on the top, we then had individuals enter this model on the bottom, where we tracked their TB-related states over a period of 12 years, including sort of active TB disease, latent TB, or no TB. Data to parameterize this model came from the published literature and included estimates of TPT and contact investigation uptake and outcomes, costs, and data on TB epidemiology. We found through running this model that TPT, compared to a scenario with no household contact investigation and no TPT, was likely to have a substantial impact, averting between 1 and 2 cases of TB per 100 contacts, and between 0.3 and 3.4 TB-related deaths per 100 contacts, with a sort of outsized impact projected among younger age contacts whom we predicted had higher likelihoods of progressing to active disease if infected, as well as were projected to face worse outcomes if they got TB and weren't treated. We also projected that the costs of TPT were not insubstantial. We estimated that scaling up this full program, including not just TPT itself, but also contact investigation and treatment for people found to have active disease, would cost between $20 and $23 per household contact. But combining these health impact and cost projections, we estimated that household contact investigation with short course TPT would be less than $500 per disability adjusted life year averted in most of the 29 high burden countries where we conducted this modeling. And in most of these countries, the sort of incremental cost effectiveness ratios that we estimated were well below somewhat accepted country-specific willingness to pay thresholds. Importantly, while we did find that contact investigation and TPT were likely to be most cost-effective for young children, as you can sort of expect from the impact results on the top right of this slide, we still found that this intervention was likely to be quite cost-effective also for older age groups, for whom, again, TPT coverage under the sort of status quo is quite low. And much of the impact from this intervention came from the contact investigation itself, demonstrating the importance of scaling that up to not just scaling up TPT. So future work that's evolving out of this project is evaluating the relative impacts of mass screening and mass prevention under different structural modeling assumptions. And I would just like to close by acknowledging the Impact for TB Consortium that funded this work and collaborators at Orem Institute, UnitAid, and Johns Hopkins. Thank you so much.
Thank you so much, Tess, for that really strong evidence about the importance of preventive therapy, which kind of echoes so many things we've talked about today. So I will give you a moment to ask our all-stars any burning questions you have about their research, but I really quickly want to highlight a couple additional resources that we're launching today to support inter-track connectedness and facilitate this research and research collaboration. So 2 resources. First one I'm going to highlight here is launching today. This is the TRAC database, which will hopefully show up in just a second. But we recently had a survey of all members of TRAC, staff, faculty, early stage investigators, trainees, and asked them to describe their research interests, contact information, and consent to thank you so much, to be shared in this public database. So this will maintain an update, but if you want to actively seek collaboration, or if you're also looking to maybe connect with someone who's an expert in a new area that you're moving into, I think this is going to be a really important resource. So basically what we've done here is grouped by your track. We have identified a research group if that's applicable to you, and then the people affiliated with that research group, their stage, their email, a brief overview of their research interests. And then this, I think, is the most interesting column. If you're actively seeking a research collaboration expertise, we can put that information in here. I myself was reading through this earlier this week and was like, oh, I got to email this person because I think we actually have a lot of overlap. And so I hope that this can be a useful resource for people. The second thing I'm going to highlight really quickly here is, if you like Slack, I know not everyone does, we're not going to make you use it, but we are launching a Slack channel that's open again to everyone at the tracks. I think this is really beneficial If you're trying to share resources or, I need a consent form from this, has somebody else written it? I don't want to write a new one. Do you have a protocol for this lab assay? And this is a really efficient way to share and connect the knowledge between these tracks. We also have places, if you have events that could be open to the track, you can view that here. If you want to publicize grants and applications, maybe plan applications together, we have a channel for that. If you want to share new work, make sure people have seen it. We have a channel for that. And then we also have a group for early stage investigators. So if you have particular resources for ESI, this is a great way to share it with ESIs at the tracks. So with that, hopefully I can pull back up our speakers if you have any questions for them. And additionally, if you have any other suggestions about how to build kind of inter-track collaborations and connections, I would love to hear that as well. And maybe while the audience here is thinking of those questions, is there anyone on our kind of VIP ESI panel who has things they'd like to see in terms of building this research collaboration in tracks, or things that their track are doing that they really think should be duplicated elsewhere? Or Shrad also, I don't know if anyone in the chat has answering those questions online as well. Everyone's just so impressed by my Google sheet. I've stunned them into science. They're all on the Slack right now. Yeah, Suzanne?
I want to make sure.
Oh, sure. Okay, we have a microphone for you.
Thank you all for this awesome overview of what's going on at all the tracks. As an ESI, I definitely appreciate it because it helps me see where the community is and the people I might connect with in the future. Could you state again where we can get onto both of those things?
Thank you for prompting me on that. Each track program manager has a link where people can join the Slack channel, again, open to anyone, not just ESI, and you should see reminders about that going out next week. We will also share with each track program manager the link to that directory and the link to the survey if you missed the survey the first time, but now you want to be added because you saw the cool kids are there. We will be happy to add you. Yeah, and we have a question online.
Yes, it's a little long, so
okay.
I'll try my best. So BCG is not encouraged, especially in the US, but developing countries still administer BCG to infants. What other vaccines can be given to high-risk population for TB to take the place of BCG? Is there any research underway to improve the efficacy of BCG to provide better and long-term protections against TB for all ages globally, knowing that prevention is ultimately better than cure and considering the amount of money invested on TB treatment?
Okay, Karolina, maybe I'll see if you have thoughts on that one.
Yeah, very quickly. BCG is hugely used as both as a research tool and again, I'm not working directly on human vaccines, but starting in the preclinical models, there's been and continues to be research on BCG as an adjunctive. So other vaccines will be piggybacked onto BCG. And there has been recently also a lot of, I think there have been published clinical trials on BCG revaccination as well, but certainly the new vaccine technologies are learning from BCG and again, considering the potential of combining.
Okay, thank you so much. And I'm just checking the time, and unfortunately, I'm going to have to cut off the Q&A. But please join me in thanking again all of our superstar ESI for showing up today. Thank you so much all for being here in person and for highlighting again just how incredible the ESIs are at these tracks. And I hope this is a new season of collaboration between all of the tracks, especially for the next generation. So with that, we are now on to our break. Please be back here at 11:30 for our patient advocacy session, which you will not want to miss. Thank you so much.
Well, thank you again for this opportunity. I want to introduce myself. My name is Richard So. I'm the executive director of SF Hep B Free. And you might be like, wait, that doesn't sound like TB. You're right. It doesn't. But we at SFF Be Free have been a strong member of this TB coalition and T for a while. We know it affects a lot of the same patient population. In the earlier slide, you saw that Asian immigrants make up a huge chunk of the TB cases that occur here in the United States, as well as other minority populations. So we're always working on that. Our group on the ground works in the Bay Area here in San Francisco and San Mateo County, and we do a lot of community education and free screening on hepatitis B, and then do a lot of kind of regional and legislative work as well. But enough about me and me being unrelated. Today, I'm so happy to be here and moderate this little panel or this little story with Renee Purdy. Renee is a TB survivor, and she's also an advocate for We Are TB. She was diagnosed with active pulmonary TB in December 2022 and only just finished her treatment this January in 2024. So today, she's going to tell just a little bit about her whole experience, and I'll just be here to comment and ask some questions, but she does a great job. So with that, I'll let you take it away, Renee.
Great. I first of all want to thank all of you for working in this field that is very underfunded and doesn't get as much attention as it should. So I very sincerely thank each one of you for all of your work. Let me just use the clicker here. So a little bit about me. I'm hoping to get back there, a very competitive tennis player. I played 2 sports in college. I live here in the Bay Area. I'm a first grade teacher in the East Bay in San Leandro. I am a mom to a wonderful 7-year-old daughter, and I have been a type 1 diabetic for now 44 years. And actually, I'm curious, because there's a lot of people here that have worked with TB patients. Has anyone ever had a type 1 diabetic with TB? Not type 2, type 1. Okay, so that is my experience. I've worked with Curry Center, the Mayo Center, and different things, and we have not been able to find another type 1. So while diabetes is a huge risk factor, type 1 has made my experience, I think, a bit more unique. So a bit about me. I'm not totally your typical TB patient around the world necessarily, and here in the United States. I was born here in the United States. I have my master's degree. I speak English and Spanish both fluently. I have a ton of family support, but unfortunately no family right here in the Bay Area. I have a very great network of friends, stable employment, healthcare. I had access to a therapist at the time that I was being diagnosed. I was in the middle of going through a divorce, and so I had a therapist for that, which plays in. I wanted to show this because I had a ton of resources, and I barely made it through my TB experience. So this is me 3 weeks prior to diagnosis. I was coaching the Girls in the Run team. We had done a 5K the weekend before, ran it no problem. There I am at the 5K. That is my daughter and I getting our family photos taken the week before. And then there I am with my family at Thanksgiving in very close quarters inside. And my brother-in-law is a doctor at Mayo, and they had a lot of Mayo doctors over. So I also exposed a lot of physicians to TB. The most amazing part is in that photo, my mom is there, and she has rheumatoid arthritis and is on a ton of drugs that make her highly immunocompromised. She'll get an infection at like just the littlest, like any exposure, and miraculously, she did not get TB. So that is one of the biggest blessings. So on December 6th, we had gotten our tree, Christmas tree. My daughter wanted a pink flocked Christmas tree, which will forever be ingrained in my brain. I looked at it every day for 75 days. And we had gone to see Frozen the musical here in San Francisco, which I find a bit ironic because in the story, Elsa is jabbed by ice that, her sister gets penetrated. And I feel like it was like, for me, I had been penetrated by something I did not know, and it just got worse. So on the way back from that Frozen the musical, it was a matinee, and I just remember feeling this unbelievable fatigue. And to the point where I almost had to pull the car over, where I was like, why am I so tired? We get back home that night and I spike the fever. So I get my daughter dinner and I was like, I need to go to bed, take NyQuil. And I'm like, oh, I have test for COVID, not COVID. And then my daughter gets sick as well. And she throws up in the middle of the night. Turns out we did in fact just have a virus. However, my daughter recovered a few days later, whereas I had this low-grade fever I couldn't quite kick, and this feeling that something wasn't quite right. I also am a type 1 diabetic, so for me, life and death is knowing every little fragment of my body, and so I know my body probably better than most people. So I called that Thursday, so a few days later, I called the Kaiser advice nurse, and I said, I've done a body scan and I just have this funny feeling that something could be hiding in my lungs. I had no cough. I don't know why I felt that way. I said, I have this low-grade fever I can't quite fix, and I think I have an infection somewhere. And the doctor says, how about you do a UTI infection test or, the urine for UTI, and I'll order the x-ray. Great. So I go to the urgent care and I get my chest x-ray, and right as they've done the scan, the woman who takes it walks me out. She's like, so am I walking you back to urgent care? And I was like, I didn't come from urgent care. And she's like, let me ask you again, can I walk you back to urgent care? And I was like, got it. I'll go make an appointment at urgent care. So I made an appointment for the next morning. It was as soon as available. And they asked me, they said, have you had any exposure to TB? And I was like, I haven't traveled. I've been here. I don't even know, to be honest, exactly what TB is. But then I remembered that I had gotten an email from the county that fall there had been an active case at my school that I was not a direct contact of. So I showed them the email, which is there. And they're like, oh, there's no way you have it. You haven't traveled. We're going to send you home with antibiotics. And they diagnosed me with pneumonia. So then I go back to my primary care. They put me on 2 heavy antibiotics, go back to my primary care a couple of days later. And as I told her, I wasn't necessarily getting worse, but I wasn't getting better. And then I tell her, the weirdest thing, I'm starting getting these night sweats and I, then get these chills. And she's like, I'll be right back. So she leaves the room for like 20 minutes, at which point I'm texting my sister, I think I'm going to be hospitalized. Pneumonia must be really bad. Something's really wrong. And the doctor finally comes back in and says, we want to move forward with looking at tuberculosis. So I was formally diagnosed. I had the quantiferin blood test. I had the sputum test, and I was 4+ on the sputum test. And so I started on the RIPE regimen. So I was in isolation through the holiday season, which was brutal. And one advice I have is that when I was first put in isolation, they would tell me 5 days to 2 weeks max, 5 days to 2 weeks max. And that is what my brain held on to. I highly encourage just telling the facts of like, we need to wait till we get these, test negative. And had they not put that guideline in my head, it still would have been hard, but I think I would have had a slightly different perspective. So this is Christmas Eve, me by myself, looking at a church service and with my family on FaceTime. That is Christmas Day. I am in a car with the windows up, watching my daughter open up a Christmas present from that's zoomed in from my phone from through behind glass. And then, I'm sending the text messages, skipping some slides. So I'm in isolation, and around January, I think it was 15th or so, I hit kind of rock bottom. I realized that I was nowhere close to getting out of isolation. I was in a house by myself every day with no one checking on me, my family, obviously, and friends, but no one looking at me, no one having eyes on me. It's the same thing. I was too weak to read books or even do a word search. All I had the energy to do was to come and sit in a reclining chair. I couldn't even sustain my attention on a movie for 2 hours because it was too taxing for me. I could watch short shows and the Hallmark Channel. Thank goodness those movies are very predictable. And so I could sustain attention for that. I also was so sick, I didn't realize how sick I was. I was barely able to eat. Food was just very fascinating where if I ate it, it tasted good, but I had no appetite. I'd lost a ton of weight by this point. And I kind of hit rock bottom. And my sister actually called my parents and was like, could Renee be suicidal? I've never had mental health issues in my life. And I, that same day, reached out to the therapist I've been using for the divorce and said, I think I need to talk to someone. I don't think I'm doing well. And so I talked with a therapist. I started going, at that point, I've been pushing myself to go outside for a walk every day. So I continued to go out. Even when I was at my weakest, I would try to walk half a block. And then it became, one morning I would just try to push myself. And that was one of my saving graces during isolation, was getting outside with a mask and seeing nature. I was nowhere near anyone. And this is the rock bottom where, yes, it was January 3rd. And I just felt totally disconnected from society. I didn't feel like a teacher anymore. I didn't feel like a mom. I literally felt like I didn't exist. And part of it was because I was so sick and I didn't realize it. So one of the things is being active. That is me during TB. I would go out every day, even when it was raining. And eventually I was able to get back to running before I was out of isolation. In fact, I could run 3 miles before I was out of isolation, which makes me think that my isolation was probably a little too long. And I'm thankful to those people who are looking at changing the guidelines, because I think that they're very, very, isolation is unbelievably hard on a patient. And to this day, I have PTSD from it. So if I get a cold or a cough and I'm at home for a couple of days, it brings it back in a way that I can't explain. One of the best things I found was We Are TB. They have a support group that meets every Monday in English, and they have another one, I forget what day of the week it is, but also in Spanish. And that was one of my biggest saving graces. So I went to the first TB support group, and immediately I just felt seen. I had people who were like, yes, I experienced this, or no, I haven't. And it was great to see how similar our cases were, and yet also how different they were. And for them to be able to provide me with feedback of things that could help me throughout my journey. A couple of other things is the meal trains were really helpful. We were able to do Apple Share Play as a family, so we'd all kind of watch the same movie in different areas and have that. We did a lot of Google Hangouts, which really helped, and then with Google Chats with people. And so those were really helpful things. Even though I wasn't seeing people, the idea that someone had left food outside, and even if I couldn't eat it all, made me feel seen, that someone knew I was inside suffering and that they saw me. So that was very helpful. It's also, the isolation period was highly hard on my daughter and her dad, who had to take on the sole responsibility of parenting at that time. So those are different activities that eventually I was able to do. So this was the ice skating picture, was me in a car, again, taking the picture from outside. That one didn't go as well. She wanted me there ice skating with her. And so I learned things. This one right here was her after swimming lessons. So she wanted it regular. So her swim lessons had a big glass window. I could go in my car, sit outside. I called them first so they didn't think there was some stalker watching kids swimming, and told them I was going to be watching my daughter swim. And then afterwards, we would always get frozen yogurt. So her dad would get frozen yogurt. He'd leave it outside the car. I'd eat it inside my car, and we'd be side by side in cars eating. And so she felt like mom was doing swim lessons and frozen yogurt with her. And then Christmas came for us on Valentine's Day. So the end of my isolation was on February 14th. I finally got 3 negatives in a row, and we were able to celebrate Christmas. So that was kind of the first wave, I'd say, of the TB. The second part, which is just as brutal, is the side effects of the meds. And that started then the second half. So it's ironic because last year on World TB Day, I did a talk for some people up in Washington. And one of the questions was, have you experienced any side effects from the meds? And I was like, no, I've been really lucky. I have not. And then it became a steep downward climb after that. So this was me when I didn't realize I was having any side effects. Skiing, and we had gone back to the cabin, we'd gone skiing, and we were playing Uno, and my daughter's like, Mom, you're cheating. Okay, and I put down the card. That's not green, that's blue. Again, Mom, you're cheating. And I look at her dad and I was like, I'm not trying to cheat. Like, and I realized I couldn't tell the difference between blue and green. So as it turns out, thiambutal had caused color blindness, that because I was seeing the same thing every day, I had not realized, because if you look at the same thing every day, you kind of just know what it should look like. So that was my first side effect. And then the meds started giving me severe liver issues. So I basically would end up eventually in the hospital, throwing up and dehydrated because my liver could not handle the meds anymore, at which point I had to have to stop the regimen and we try another one. I'm going to kind of ramp up again, and then my liver couldn't sustain it anymore, stop another one. And then last spring, I went on the fluoroquinolines, and I'm a huge athlete. And my brother-in-law is an orthopedic surgeon. And he said, Renee, I would advise stopping playing tennis and running just because the fluoroquinolines do have a risk of tendon issues. And so I stopped all of my rigorous activity, which for someone like that's my jam. So that was rough. And I hope that I had avoided it. I did make it on the last regimen until January. I spoke, maybe some of you were in the room in October, and basically after October, I realized it was so gradual. I didn't fully realize that I was struggling to walk. And by the new year, I could barely take a step without pain and fear of rupturing my Achilles tendon. So I didn't make it through treatment. And then I am now in rehab, and unfortunately, fluoroquinolones have caused damage to my tendons, but hopefully it's mild enough that it will recover. But I have about a year of physical therapy to get back to myself. And today I'm very excited because I did not have a boot, and the walk from the parking lot was not overwhelming as it has been for the past month. So I'm definitely finally on my upward trajectory. The one thing I did the direct observed therapy, and I have to say that is such a fascinating thing of having someone watch you take meds. But I did try to make it fun. That was one of actually the few people that made me feel seen during of all things, on an app. But the nurse would write messages and saw me daily. My daughter would join in, like we do things. And then this is a group of friends from college. I was able to make it on a trip to Palm Springs, and we did Mrs. Roper's Romp at brunch. And so all my friends were in the background dancing. I tried to make it engaging because I imagine also for the public health nurses, it's a lot to watch those every day. And then my only lessons learned, so I'm a first grade teacher, but I think a lot of being an effective teacher is very similar to being an effective healthcare provider. One is I think you really need to listen to your patient. Each patient experience is very unique and different, and you need to listen to them. And then two, you need to adjust course to them. So, repeated communication, just if it's said one way, trying a different way. For me, I got so much information at the very beginning, and I was so overwhelmed, I couldn't process it. And so having another touch, I was also too sick fully to comprehend it. And so having people come in and explain things over and later and reviewing them, I think is really important. And then I also just think making your patients feel seen. Throughout my treatment, the people bringing me the food deliveries made me feel seen. The people on the IMOCA, or I guess now they've changed names, but when it started it was IMOCA. The nurses there made me feel really seen as a person and not just a checkbox. Unfortunately, my experience with the county was not that way. They had a reminder. It was very clear to me at the last day of the month, I'd get a text message like, "How are you doing?" And it felt like I was checking a box. And I was a very compliant patient, and I would advocate for my needs if I wasn't feeling well, but it didn't do anything to make me feel valued as a person. So that is kind of my story. And I did just complete treatment. And finally, I feel like by next year, I will be back to pre-TB.
Yeah. Thank you so much, Renee, for sharing. I just have a couple of things. You talked so much about the arduous journey in so many different ways. And I think you talked about just now what physicians should do. And I wanted to ask you more, if there's anything more specifically, like if this was a room, it is a room filled with many doctors, what would you say after your experience that could tangibly help them with TB patients and better understand their patients?
Yeah, I think one is that each case is unique, right? And different things impact it. So for me, the type 1, obviously, I think my theory is it probably impacted my side effects of drugs and the way my body metabolizes it, but we couldn't find someone that had it, so it's hard to know. So really finding out the history of your patient and their unique experiences with that. And then just being an empathetic listener, right? Empathic listener. My doctor was really good at listening to things. And we also built a trust where if I said something, she then really listened and was like, if Renee is saying this, like, yes, like there must be something wrong. Or we need to explore this. And it took some time to build that trust. But I think also with TB, I think because I do have type 1, I work with doctors in other fields. You know, some of the population of people that are being treated might not realize that they can advocate for themselves, or might be from a culture where they are not asking the questions or don't want to step on someone. And I was actually referred to as fiery, which I laughed because I've never in my life been viewed as a fiery person, but in the world of TB, apparently asking questions and advocating for my health is more unique. I swear if I'd had cancer and been in an oncology department, I wouldn't have stood out at all. So I would also encourage you to want fiery patients in the world of TB, wanting people who are taking, because if you have a quote unquote fiery patient, they're invested in their care and they're invested in learning more about it. And so I would say as a doctor, work on making your patient a little bit fiery, right? Get them to ask questions, check in with them, get them to communicate more, keep teaching them.
Yeah, I think that makes a great point. And we saw the slide about how many patients probably with TB are immigrants. They may be monolingual. And you talked about how you're maybe not the most average patient. And you can imagine, for me, like, let's say you have to be in isolation, but you only know your native language and you don't know that much about health or to advocate for yourself. Then it's like, you're probably even in a worse spot. If your support system with your family or friends doesn't exist, then that would be terrible. And then at the same time, they're probably not going to say as much about it. So I think it's important that we highlight that. I'm wondering, in the beginning, was there a lot of like non-knowledge from your friends or even other physicians about TB itself? Was there any stigma from it, or?
Yeah, it's interesting. You know, I don't think I experienced stigma the way some people would, especially if you're a recent immigrant and different things, right? I think my experience was more unique. However, no one I knew had ever heard of anyone with TB or anyone in the United States that had TB. And so that was extra isolating for me. One of the pictures I had up there during the meal train was actually one of my neighbors had moved from India in the past like 5 years. And her daughter and my daughter are very good friends. And, you know, one of the things that made me feel really seen was that she knew people, her family members who had TB. And just her telling me, Renee, you're going to get through this. It's going to be hard, was one of like, I tell her continuously now, like she was one of the biggest gifts for me. And she would deliver these wonderful meals for me every day that her uncle would say, okay, put this ingredient in because it will do this and this and this. And I can't even tell you what they're made with, but they were amazing. And so that was something that did make me seen, because in my community, no one was even familiar with it. I will say now, my school community is very familiar with TB, as are all the people in the area.
I always like to ask this question, but if you're in front of a bunch of policymakers, what would you tell them to get them to take action?
Oh my gosh. I mean, the fact that TB still exists, truthfully, is mind-boggling to me. It's treatable. It's preventable. One, it's hugely underfunded. Those drugs are brutal. And I guarantee if we had more funding, we can make a better regimen that did not cause serious harm to your body. And I also, you know, unfortunately, TB is not impacting all of the world in the same way and all of the same people in the world. And it does not need to exist. And so I just wish that policymakers, one, isolation guidelines are highly outdated. They're from, I think, the 40s. And we know so much more, thanks to COVID, about how things spread. And I think those could be updated. Two, the medications need improvement. And three, I really would just love to see us be able to push and eliminate this disease.
The last question, other before we open it up to more questions, is, you know, if there are potential family members or patients in the room, what are, like, you talked about this a little bit in your presentation, but what would you say to them?
Great question. I would have them join the We Are TB support group. It impacts the whole family. Since I joined, you know, I went to my first meeting, I think December, January, right after December 22, January 23. And since that time period, our group just continues to grow as more people are diagnosed. And we do have family members who they come and they speak about their experience and they don't know and they've noticed these, or I've noticed a symptom, should I be worried about this? And so one is getting them the resources because I think in some communities you have the stigma and you don't feel safe talking to people about it. So it's a safe space. And two, there's just so little information out there in the United States. And so giving more information.
Great, great. Well, I do want to open it up for any questions for Renee.
Thanks, Renee. It was really wonderful to hear your story, and I'm sorry you went through all of that. Just reflecting on your experience, as you mentioned, you talked a little bit about how your community had really never heard about it, and in many ways it was a rare disease for you. And I sometimes wonder whether, as clinicians, researchers, public health professionals, we kind of put a disservice to individuals in the U.S. that have TB because we kind of tend to speak on a global context and say TB is this huge issue. It's the single, infectious disease killer globally, but that sometimes leads to not providing the support and resources to individuals. So I was just curious in the US. And so I was curious with your experience with type 1 diabetes or others, whether you felt there were support services that maybe in like the quote unquote rare disease field that maybe could be more supportive for us in the US.
Yeah, I think absolutely during the isolation period, not having someone physically come check on you, even if they come to your door or even FaceTime now and physically look at you every day. I think that's almost criminal. My parents, they're not doctors, but they were seeing me every day, but they're not knowing what signs to look for if I was, tanking, right? Like they didn't know what to look for. And, with the thing about color blindness, I didn't realize it was gradually happening to me, and had someone come and done the simple eye test, right? It would have been identified earlier. So one, I think, is giving resources to people during that time. We have technology now and there's ways to do it outside. And so I think giving more support then. And that would be my main one in the early stages. And the second part, just, linking people up with other people, because it is more rare in the United States, finding ways to give them community and give them resources because it's really hard to find. I Googled things. The CDC did have a great, that was one of the things I found was stories. And I watched every one of them because I was like, oh my God, there's someone else who's had this. And some of the stories I related to and others I did not. But finding that was another great resource for me.
Thank you.
Thanks so much, Renee, for sharing your story. I wanted to get suggestions about how to be a more fiery patient advocate, especially because I think about just my conversations with you about your story and how you were privileged to kind of navigate the health system and feel like you could be an advocate and try to advocate. And I'm wondering, how would you suggest ways of advocacy for patients who need additional support, need culturally responsive and culturally linguistic support and advocacy?
Absolutely. I think trying to build those networks of community, right? Like the We Are TB. So finding people and also letting patients know, it is okay to ask these questions. It's okay to push back. It's okay. Empowering them to push back. When I would go to my We Are TB group and I talked about some of the things, some of the treatment I was getting, from the county, which was beyond subpar. It was helpful to have them because I was like, I don't want to be that patient that's complaining. And then, to get that bar of what is normal and then what is that extreme and where and how to advocate. So giving people resources and people to talk to and also encouraging that. I will say my doctor at Kaiser appreciated me pushing back and would tell me that, right? She would say, I like that you're asking these questions. Yes, you push back on me, but I appreciate it. And as she'll say, now I've learned a lot from your case because it wasn't as typical and getting to that point. But it's hard. Finding those networks, right? Like the We Are TB. We probably need one truthfully in a few different Asian languages, right? If we look, especially in the Bay Area and different things. And so how do we get that going?
There is a question from online which says, they say, thank you, Renee, for sharing your unique experience with TB. When you were first diagnosed with TB, was contact investigation conducted to trace your contact? What would be your advice to public health providers on how to make patients with TB not feel completely socially isolated or feel that they matter at the infectious stage of the disease, knowing that people might be scared about contracting TB?
Yes. So the first part, absolutely, the contact tracing. What's interesting is I was also deemed fiery then because I was in a school system, and the ways kids move and the way we share kids is different than in other situations. And so they only wanted to originally contact trace just my class, but we rotate kids. And so the level of, 8 hours, this much time, I came into contact with a lot of students and faculty. And so I pushed really hard to get more testing. Luckily, I did not, knock on wood, transmit it to my daughter, or it's unclear that I transmit to anyone. In fact, there were some other cases identified that were luckily still latent, but it's unclear if it was from me or a different air quality or the different air within the school. As far as the offering of support, I think, at the very first initial part of being diagnosed, like I remember, one of the infectious diseases calling me for a couple hours and walking me through everything. And it's just overwhelming. Like they're walking me through these other, all the side effects, and this is this, and what this is what it means. And it just like, at the very beginning, I felt like I was inundated with a ton of like information and support. And then once the isolation kind of started, it really dropped off. And so I'd say that is a key area where I think you need to be checking back in, especially asking like, yes, I got the list of side effects, but having someone check in and say, how are you feeling? And maybe not even, when my issues with the tendon started, they kept saying, are you experiencing pain? Well, that word wasn't exactly how I would describe it, right? But if they had said, how is your body feeling? Or tell me more about how your feet are feeling. What I would have said was, well, I'm really struggling to walk. And I am noticing that with each step, I just have this like weird cracking sound that I've never experienced before. And I'm worried about, and if I looked on my like health app and I didn't even realize this, but suddenly I'm walking 1/4 the steps I would normally walk in a day because I think I'm afraid to walk. But could I check that box? No. So I think opening up and letting the patient talk and asking some open-ended questions. But I think there's that window of like from initial to then that there's right in that area, I think is a really crucial time to meet with people and build those relationships. I've also heard amazing experiences. I have a friend who had multi-drug resistant TB in Texas, and literally when she sees her care team from the county, they hug and cry, and like they talked every day. She had someone every day texting and just made her see, and she's now becoming a TB nurse to work for the county because of her experience. And I've heard of another one here in San Francisco where because of the county here in San Francisco, they changed the life for a person. The person literally is on a different life trajectory because of the people that were involved in the care. So don't underestimate your power either.
Thanks so much for your story, Renee. A lot of what you've said strikes me kind of as an interesting intersection of you receiving care from your primary care provider and from public health, which for those of us who work in TB is sometimes a really challenging space to be in. I'm wondering if you could talk a little bit about, in a perfect world, how would you have liked to receive your care? And going forward, you've had quite a few side effects. You've got an optimistic, really great optimistic view of like your recovery, but many of us take care of people who have potentially much longer chronic roads ahead, right? Who should care for, who's taking care of you now to kind of help you manage all of those?
The county has never even congratulated me or told me I'm done with treatment.
Sorry, say that again.
The county has never even congratulated me on being done with treatment. So I can tell you I've had no contact with them. So my care is my doctor and then the We Are TB support group. Those are my two, for me, those are my two. Do I wish that was the case? No. Do I wish that the county was? My doctor is great. She is so educated on, she's knowledgeable, and she works half time. So she is not always accessible, and some of the side effects can come on quickly. And so you're trying to find someone to say, like, for example, when my Achilles took a drastic dive, I was emailing her and she was gone, right? And then I go to the county and say, I'm really concerned, like I'm noticing a significant change, and they literally refused to contact, like they would not get back to me. And I'm like, I don't know, do I stop meds? What do I like? And no one would tell me. And so I do think that is that what you're saying. right? The county is saying, well, your doctor, your physician is managing this. We don't have all, and you do go against that rep, right? But I do think that the county part, from wonderful stories I've been told, does have a huge part. And I think especially on the emotional support and the checking in and providing during the direct observed therapy and the isolation, a really critical part. And even after, I think too. And the doctor, and then I think finding those support networks for people. Just recently, someone who had gone through treatment was talking about coughing up some really gross stuff, right? And she's like, oh my gosh, I'm freaking out. And it was amazing because so many people in the car were like, yes, this happened to me post-treatment. I went to my doctor, I was so nervous and it was just normal. This was finally coming out. And so you do need support at that time and post-treatment because your body is going to still have things that are, and it's not clear. I mean, that's the hard part, but I do think it is the primary, having your doctor, but I do think that county does, the emotional support needed from there at times, I think is huge.
I have a suggestion for the public health people. It would be somewhat directed at athletes. We should have some sort of public health message sent to the particularly football, baseball players that spit. That's very bad. And that is definitely a way to spread these things, not just TB, but influenza, et cetera, et cetera. It'd be directed at them primarily, but it maybe could be helpful for the rest of the population too.
Yeah. It's interesting.
We have time for more questions. Okay.
Hi, Renee. Good
Hi.
to see you. Yeah. Thank you so much for telling your story. It's really powerful. And I just want to say thank you for being a fiery patient, and thank you for your continual engagement, and to be here today, for what you're doing, to be part of the TB personal stories at CDC, to be an advocate for support groups and all of the work that you're doing. I think it's just wonderful. And I just wanted to make sure you heard that from all of us. We really appreciate it. Thank you so much.
Thank you.
I was wondering, just because from the funding perspective, I know how public health offices have been decimated. And do you know anything about what is going on in the county office, that it was just sort of MIA, not there for you?
I don't know. It's a great question. I know recently they've had a massive outbreak that was undiagnosed. I think my opinion is that there's probably some managerial things that need to be changing at that particular site. I don't know. And I'm sure funding impacts it, and you have people who are tired. I also worked in San Francisco County because of my contacts and where I play tennis, and they were phenomenal. And even just from communicating with them, it was a drastically different experience. And then I also, where my school site was in Alameda County. So I was between two counties, which is interesting. Contra Costa County managed me personally, and Alameda County managed my school site. And Alameda and Contra Costa seemed more similar. And I think they're tired. And I get that. As a teacher, we're tired too, right? And not forgetting to see people as people. And you're trying to check boxes and you're trying to just survive, but going back to that. And I think with the pandemic, it impacted that, like, you need that interactions with people, and that people are seen and valued. So I also question my experience post-pandemic versus pre-pandemic, right? But the pendulum, I think, is swung too far, and so that could be part of it too.
Interesting. I had a quick one. The We Are TV, did you find that on your own, or was that advised through county or one of your doctors?
Yeah, great question. The county gave me this wonderful packet of information that when they first gave to me, I was like, "Whoa, it's a lot." And then when I hit that rock bottom, I was like, "Let me see what's in there." And so I started reading. I also had a little more energy probably at that point. And there was a flyer for a different support group that was on Facebook, and it no longer existed. So when I went to go to that website, and I was so devastated. So then I was like, I wonder if there's another one out there. And when I Googled it, We Are TV came up. And then ironically, in the back of that pamphlet, when I made through more papers, there was a We Are TV one.
Yeah.
But the other one was in the front.
Yeah.
Yeah.
I think, and this is our experience from Hep B, like the informal / like maybe nonprofit driven support groups seem to end up playing such a critical role. I mean, there's a global forum for Hep B, and a doctor from Australia runs it. And he just let people post. And of course, he still has to sort through all the spam that unfortunately that comes through. But it's people just telling their stories, and you just see the same thing. Like, oh my God, you're going through the same thing. Oh, you're worried about a partner having this, and like what I should tell them. And I think more and more one thing public health can do, and I get it, there's some limitations because you might expose a patient to misinformation, but hearing other people's stories. And so I think for the TB advocates here and many of these diseases, like getting funding to create patient storyteller forums, or so you can watch those 10 videos and go, oh my God, someone's there, is like a great way to do it. Just a thought that I think is something that maybe doesn't really require, like if a public health department's like, well, I can't be there every day for you, then at least you can say, here is a good resource so that you don't feel alone. So it is, I think, a nice way that takes some of the burden off directly something produced by public health, but at the same time can do leaps and bounds 100%. For the patient.
And even text messages go a long way, right? A simple like, hey, thinking of you today, or how are you, right? We have that technology now. So it's not that I need someone to like, have a long conversation with them every day, but just somehow be seen, right?
Mm-hmm. Yes.
There are two more questions, one from online and one from my own. The one from online is it true that public health efforts will focus more on following up patients that have no insurance or no primary care doctors, so that they rely on the help of patients' doctors to follow up with their care, example, Kaiser?
Great question. I imagine that I was a very compliant patient. And I had a lot of resources. So I imagine that, and I get that, right? And I think that's the thing. I mean, in a classroom teaching, for example, right? I have many kids with different needs, and it's true. My student who is homeless and new to the country and is literally trying to find a place to live and survive, does she get some more of my time? Yes. But as my role as a teacher is to make sure that every child is growing at what's best for them, and that they're all coming at different points. And my job is to take them from where they're at and to where they're going. So yes, was I a more compliant patient, didn't need as many resources? Absolutely. But does every person deserve to be taken from where they're at to where they, could be? Yes. And so if that is the model, I get it, right? I think you do need to be more resources, but that doesn't mean you ignore other people.
And I have a question of my own, which is that have you, as a survivor, ever considered joining other support groups across cultures or across boundaries? For instance, I know in India we have Survivors Against TB, and I think a lot of the champion work that you've done and you've survived will really inspire and motivate the youth who are unfortunately falling ill with TB. So is that something that you?
No, I'm still new to this, just out of recovery, but the reason I do it is I believe really wholeheartedly that you need more people talking about this. I also understand that with my privilege and my experience in the United States, that my voice is heard differently. Which is why I try to speak and I'm willing to advocate, and I want to spend the time, because there are people that don't have these resources. And it is, with all the resources you saw, I've never been through anything more isolating or harder. And I've lived with type 1 diabetes since I was 1. And nothing, TB is a vicious illness. And so I would be happy, I think the more you're creating these communities, and it is really tough, right? When people hear cancer, so many people have had a touch with it. They know, oh, this is really hard. It's not just the initial diagnosis, it's treatment, and it's recovery from treatment, right? And with TB, people do not realize all the ways that it impacts you, and not for one short amount of time, but potentially, like people are saying, if you have lifelong side effects, right? It can continue. So yes, the more it's talked about, and I'm happy to join any groups. Right. I just don't know what they are. So if people want to reach out to me, I'm happy to do that.
Great. Well, thank you. I think we're just about out of time here, and going to bring up our next couple speakers.
Well, thank you, Renee.
So thank you so much, Renee, for sharing your story, for of course coming up here and talking in front of all these people. Handing it off to you, Kiva.
Hi, everyone. My name is Chibo Shinagawa, and I'm a senior program manager of infectious disease at APCHO, which is the Association of Asian Pacific Community Health Organizations. I'm up here with my colleague, Vivian Lane. She is a government and community relations representative at Northeast Medical Services, which serves the San Francisco Bay Area and is a federally qualified community health center. We're actually both members of the California Coalition for TB-Free California, and also major advocates and supporters of We Are TB. And Richard is also a member of the California Coalition for TB-Free California. We're up here because we really want to share that in addition to the wonderful research and community initiatives that you all are a part of in California and locally here in the Bay Area and nationally, we have so many enriching community resources that support survivors like Renee. And so I'm so thankful. Thank you so much, Renee, for sharing your story. We're just going to share a little bit about APCHO and the TB Elimination Alliance, and then we'll also let Vivian share more about NEMS and the Coalition for TB-Free California. All right. So APCHO is Association of Asian Pacific Community Health Organizations. So we were formed as a national voice to advocate for the unique and diverse health needs of Asian Americans, Native Hawaiians, and Pacific Islanders. We are a national association of community health centers. And again, Northeast Medical Services is one of our community health centers that we serve. We're dedicated to promoting advocacy, collaboration, and leadership. And over here, you can see in the location items, the areas that we cover. We're uniquely nationally based, and we serve many of the U.S. affiliated Pacific Islands. And I just wanted to share more about the Tuberculosis Elimination Alliance. So we were led by APCHO and the Asian Pacific Islander American Health Forum. I'm actually here also with my colleague Jamila Ship, who is one of the steering committee members. And through APCHO and Asian Pacific Islander American Health Forum and the Hepatitis B Foundation and Stop TB USA, we were able to put together the TB Elimination Alliance, which is funded by the Division of Tuberculosis Elimination at CDC. We are 15 current members representing community health centers, community-based organizations, and public health agencies, academic institutions, and partners. Thank you. All right, so the TB Elimination Alliance, we're a national partnership of community leaders dedicated to increasing knowledge, testing, and treatment of TB and latent TB infection among communities at risk. So we started off as a national partnership focusing on Asians, Asian Americans, Native Hawaiians, and Pacific Islanders, but we've expanded our approach to serve Black and Brown populations in the US. Again, the goals of our alliance are conduct outreach to communities most affected by TB, increase awareness and understanding of latent TB infection testing and treatment strategies, and also share resources and best practices. And finally, developing partnerships to scale existing initiatives. Sharing here our mission and our vision. Our vision is really to focus on building healthy communities free of tuberculosis. And then just wanted to share, I think this umbrella of, just getting kind of a sense of the TB Elimination Alliance. We started in 2019, and now we are in 2024. We're in the last year of our cooperative agreement. And feel like, I definitely think that we have built a sustainable program that really looks at the impact of strengthening our health system and supporting our community and our survivors, our TB survivor advocates. Through T, we just sharing a little bit more information about T's work. And again, through T, we have several strategic pillars: collaboration and partnerships, community engagement, access to testing and treatment, provider education and research and data. And I'm not going to go over all of these, but I do want to share that, we have a lot of health equity expansion goals as well. And primarily to make sure that we're uplifting and empowering the voices of non-US born Latino and African American communities, and also non-US born Asian and Asian American communities as well. So forging, these long-lasting partnerships with TB programs, researchers, and healthcare, settings to focus on health equity initiatives. And then just sharing some program highlights. So you can see that we're out here on the Hill. A lot of us just came from the Hill last week. And we were also at the National TB Conference. We have a picture here with our colleagues at the National TB Conference, and also some of the webinars that we've been able to put together. And then also sharing more about the Preventing TB to End TB event and our work with the Health Forum on their Voices conference. All right, just wanted to share a bit more on our summit. So we do have a summit that we do that's for partnerships and collaborations. And our summit has happened, yearly from 2020 to 2024, actually, and 2023. And we've been able to host, national summits each year that helps to support discussion and dialogue, similarly to the Symposium on TB and TB awareness. And also we have a mini grant program. So our mini grant program has funded actually several projects in this room too, and also has served so many projects like from We Are TB and Somos TB. And so our mini grant program provides funding dollars to small local CBOs, community-based organizations, and community health centers. Just wanted to share a bit more about the recipient organizations and the different locations. And then finally, just a list of all of our members and the people that have made up the TB Elimination Alliance. And also just, the importance of community members and researchers and advocates and survivors coming together to eliminate tuberculosis elimination. So I'm going to bring it forward to my colleague, Vivian Lane, who's going to talk more about the Coalition for TB-Free California. Thank you.
Everyone. My name is Vivian. I'm with Northeast Medical Services, or NEMS. Some of you may know Dr. Amy Tang. I don't know if she's here yet, but she'll be speaking later today. But I am here on behalf of the Coalition for TB-Free California today. We're a statewide coalition made of community organizations, public health experts, survivors, and just TB experts in general. Over the years, we've kind of turned into a coalition that seeks to educate people at the state level, because we are a statewide coalition. So we have folks from LA, San Diego, et cetera. And we have been working a lot these past 2 years to do outreach education for legislators specifically. So as part of this patient advocacy panel, that's a bit of what we're talking about. Since 2021, we've had 6 webinars. We've talked to community, we've talked to stakeholders on impacted populations. We've strengthened relationships with other coalitions. We got a new consultant, and Ryan Clary, I don't know if any of you know him, but he's done a lot to expand the coalition and make sure that we get more members. So if any of you are interested in joining, I'll have his information on the slides at the end, but we would love to have more members. Earlier during the talk, I think a lot of the questions were like, why isn't the county doing more, et cetera, et cetera. And through a lot of our education efforts, like the legislative briefings, meetings with members and staff, I'll tell you, I've talked to so many people at the legislature and staff members, et cetera. And I tell them all the normal talking points, like there are 2 million Californians estimated generally who have TB. Only 13% of them know that they have TB, and they are completely mind blown. They just have no idea. And people out there are willing to support. They want to help eliminate TB, but they just don't know much about it. If I go out there and I say TB, they don't know what it is. They don't know how it spreads. They don't know which part of the body it affects. And so by getting more members in the coalition, we're hoping to expand a lot of more of that outreach. I know you might have institutional or structural limitations from your leadership, et cetera. We're always happy to have people who are interested in TB just from an expertise level. So sometimes I'll just talk to Dr. Graves and I'll say, can you please just give me the technical information? I don't need you to advocate beyond what your job scope is, but having technical information is extremely helpful. And we've been doing a lot of that. So in the past few years, we've had a few budget requests at the California level. Unfortunately, because of the extreme deficit that we're seeing, we haven't been able to secure any money. We initially wanted to pilot some programs statewide in highly impacted counties to see if we could do more education outreach. We were able to secure a advocate in Assemblymember Riggs Zabur down in LA County. Unfortunately, he just wasn't able to get that through, but he did want to support us. So what we did this year is we put a bill in the state legislature with Assemblymember Evan Lowe that some of you may have heard of. We actually modeled this after a Hep B bill that Richard's organization helped work on. And what the bill would do is require primary care providers to offer a TB risk assessment, test, and screening to patients whose insurance covers it. So we know that in California, most people will have it covered. And it's tied to the USPSTF recommendations, obviously. And this did pass 3 years ago with AB 789, the hepatitis B bill. And so this was actually just heard in Assembly Health this past week, and it did pass Assembly Health, which was great news. And if you are interested in getting involved with the advocacy, please reach out to me. My information can be found here, or Ryan, who is the consultant for the coalition. And please come up to me afterward if you have any questions. Otherwise, other ways to get involved are just to contact Ryan. You can reach me through him as well. And we just really want to get more people involved, even if it is at a limited scale. Thank you.
So I'm going to hand it over to our moderator and another, my esteemed colleague on the organizing committee here, Paul, to bring us into the 3-minute abstract competition.
So, thank you, Sophie. I hope you have had a good day so far. We started from looking back with Dr. Castro, then future. I don't know whether you also couldn't help but notice that towards the last slide is just the same question that was there. The same, some of the questions still remain the same. So that tells you how cyclical the story of TB is. You make progress, and then sometimes you don't cover as much space. So in this session, and I also hope you have had enough lunch, you are geared up for this session, which is interesting. It's interesting because in the morning during the ESI sessions, you saw different presenters. John talked about macrophages, Riti talked about HIV co-infection, Karolina, so different things. So my work is to make sure that when we walk across the street, right, we can explain the science we do in a manner that is accessible to everyone. It's not an easy art, right? And the whole of this idea is just supposed to have fun. Say what you do in 3 minutes in a manner that is easily accessible, as I said, so that when you talk about what you do, the next person knows what it is about. Therefore, we have 3 brave presenters. So these three brave presenters, one is virtual and the other 2 are in person. But the beauty of this is that there's also actually a gift. There's a prize for being brave enough to come and share your story. So this is not just any other session about communicating. And our presenters, I'll introduce them. First, we'll have Karolina Maciag, Tessa Mochizuki, and Kinari Shah. But before that, I learned from Patrick Phillips last time that she was brave enough to be the guinea pig or the mouse for test purposes. I decided I'm also going to give you an idea of what I do, and in a manner that can help you, or I can communicate myself. So my name is Paul Ogongo, and I'm an immunologist. I study how the immune system responds to infection with the bug that causes TB. By understanding how the immune response, our body responds to the bug that causes TB, can help us develop a TB vaccine. And this is important in helping us control the scourge of TB. The question is, why would I be invested in studying TB or getting a new vaccine for TB, yet we have a vaccine? Yeah, indeed, we have BCG vaccine that was given at birth, most distributed vaccine globally. But despite that, there are still 1.5 million deaths in a year from TB. So what's the problem? The problem is that the protection you get from BCG vaccination wanes with age. That is, as you grow older, that protection is lost. And coincidentally, as the protection is lost, that is also, especially in adults and adolescents, that is the the age group that has the highest transmission of TB. So you have a situation where your protection is lost when you most need it to protect you. How do you go about looking for TB vaccines? There are different ways of doing it, but the method I use involves understanding the bug that causes TB and using our cells as our allies to fight the bacteria. So what do we know about the bacteria? You know that the bacteria is coated by different particles, both inside or outside the bacteria, that the immune system sees. So when our cells see this, then the body is able to make a response. We also do know that out of those massive group of particles on the bacteria, some of them the bacteria uses to evade the immune recognition so they can keep surviving. But there are a small category of those particles that when recognized by the immune system, the body is able to kill the bacteria. And these are the category that is most important for us. But the onerous task is to identify what are these individual particles on the bacteria that when recognized by the immune system, then we are able to, the body is able to kill the bacteria. Once we identify those, then we begin the long process of developing them into a vaccine. And that is potentially going to be better than offering you better protection than BCG across the entire lifespan. But because I studied the immune system, the work I do is also important in being able to identify people in the community who are likely to develop TB disease. The reason why that is possible is because when you are infected, when you are exposed to the bacteria that causes TB, not everyone falls sick immediately. In fact, 90% of people develop a control. So they are able to control the disease without falling sick. So by knowing how the immune system of people who are exposed to TB but don't fall sick is different from people who develop the disease, we can be able to monitor people in the population by getting blood from them, look how the immune system is, and then follow them with time to see when they are most likely going to develop TB. So we are able to prevent TB before it is developed. So the work I do of looking for TB vaccine is important because we know an effective TB vaccine can prevent TB infection, can also prevent development of TB disease from those already infected, and this will help us eliminate or reduce the burden of TB globally. Thank you. So with that, Karolina is going to be our first speaker, and I'll reintroduce Karolina Maciag because she was already introduced before. So Karolina Maciag received her PhD in immunology from Harvard Medical School and her MD from Harvard MIT Division of Health Sciences and Technology. She did her residency in internal medicine at Johns Hopkins and fellowship in infectious diseases at the University of Washington. She has been passionate about TB since before medical school, especially after completing a 6-month fellowship workshop working with community health workers in rural Guatemala. Please welcome Karolina.
Thank you, Paul.
Thank you,
it's
Paul.
A pleasure to be here again. And I'll try to make this a little bit different from the morning talk. All right. So as Paul has very eloquently introduced, an effective vaccine against Mycobacterium tuberculosis is desperately needed to combat the pandemic. Currently, vaccine candidates are routinely assessed on their ability to elicit T-cell memory responses. So how well can T cells in the peripheral blood respond to antigens and produce interferon gamma? But are we looking for the right thing? So in the Erdahl lab, we're looking for what makes up an effective immune response to TB. So T cells producing interferon gamma have long been considered a stalwart for immune protection, but their relative importance has been challenged, not only by the lack of correlation between interferon gamma production with protection in clinical trials, but also in studies in mice that used adoptive transfer. So basically a transfusion of T cells into mice that lack, actually the previous studies used mice that lack both T cells and B cells. And they found that T cells that lack interferon gamma still provide some protection. Another study in mice used transfer of a large amount of pre-activated antigen-specific T cells and showed evidence that T cell-derived interferon gamma plays a minimal role in protection and may actually be harmful. So this is an important question to answer. We know that adoptive transfer experiments, these T cell transfusion experiments, come with their own limitations, like artifacts from self-handling, and as a transfer of a set number of cells with a limited T cell repertoire. So we decided to apply an arguably more physiologic mouse model to address the important question of the role of T cell-derived interferon gamma. And again, this is important because Paul mentioned antigens. Adjuvants are also important. The combination of antigens and adjuvants can determine the type of immune response, the type of skewing that occurs. So we found, first we used a T cell chimera model, which we argue is a more physiologic model. Here we take mice that specifically lack T cells. We irradiate them to make a little room in the bone marrow, and we give them donor bone marrow where the donor bone marrow is outcompeted by the host, except for T cells. T cell precursors develop from the donor. So we end up with mice that specifically, we can make the T cells be whatever genotype we want. All the other cells are wild type. And then those T cells develop for weeks and weeks and develop a normal T cell repertoire. So this is a more physiological model. And so we investigated outcomes in these mice in an organism, lung, organ, tissue, and cytokine and gene expression basis across all these levels. We found that when T cells lack interferon gamma, the mice get sick faster. You do not have a decrease in bacterial burden. You have a lot of neutrophils, which are harmful, and eosinophils in the lung. And we found this using flow cytometry, using microscopy, and we found that the cytokines are heavily skewed towards Th2 responses, which also notably predominate in helminth infection, which may be relevant to TB infection. We think that our findings may affect TB vaccines because it underscores the importance for a balance between Th1 or classical activation and Th2, which ends up with alternative macrophage activation. So this may affect further vaccine development. Thank you.
Thank you, Karolina. That's amazing. To put those interferon gamma and put in a language that she has done is not easy. And thank you very much again, Karolina, for that. So next up is our next competitor is Tessa Mochizuki. Tessa Mochizuki is an epidemiologist and research scientist working on TB diagnosis studies across Africa and Asia. Her prior work included several years working on TB prevention in California. Welcome, Tessa.
Very much, Paul. I'm very happy to be here. Tuberculosis remains a leading cause of infectious disease death worldwide. As researchers and practitioners in the field, we know this. We also know that diagnosing patients fast and starting treatment is important to both patient health and improving public health. The World Health Organization has long recognized this and called for universal access to rapid molecular tests. Molecular tests such as GeneXpert are faster and more accurate than standard of care smear microscopy. Tests like GeneXpert can provide a result in just 2 hours, shortening the time needed to diagnose a patient and initiate treatment. We might expect that implementing such a test at community-level health facilities would lead to fewer deaths. Yet it's unclear whether rapid molecular testing reduces mortality. Combined analyses of 9 previous trials have failed to show that GeneXpert reduces mortality. As a staff researcher working on a number of diagnostic studies, I endeavored to better understand this. With a team of collaborators, we conducted an analysis of the EXPEL TB trial. In this trial, we worked with collaborators, and there were two groups. There were health centers in one group that implemented an on-site GeneXpert testing intervention, and health centers in a second group that just continued on with routine TB care. The EXPEL TB trial was the largest TB diagnostic trial of its kind with over 10,000 patients included. Through that trial, we showed that implementation of on-site molecular testing at these health centers increased TB diagnosis and treatment substantially by 50%. We then followed up with those patients for up to 18 months to assess vital status. And here's what we found. Mortality was low across all patients at just 3%. There was a 23% reduction in mortality among patients with the molecular testing intervention. But like previous trials, the results were not conclusive, suggesting there could have been a greater reduction or there could have been no reduction at all. Our large trial suggests that it's very challenging for any single study to make a confident conclusion about the impact of molecular testing on mortality, especially among non-hospitalized people. Faster TB diagnosis, however, has many other important benefits. Some of the most important ones are improvements in quality of life for patients, as well as prevention of onward transmission or TB spread that might have occurred had a patient's diagnosis been delayed. We should also continue to study how these rapid diagnostics can reach patients who not only present to the lower level health facilities, but who may not be accessing care and may be at risk for poor outcomes. So while mortality remains important to measure, and it's the ultimate outcome that we hope to reduce, whether or not a test reduces mortality, specifically within a trial setting, shouldn't be the make or break. More immediate outcomes, such as the number diagnosed with TB, number started on treatment quickly, should be the ones to drive policymaking and scale up considerations. Thank you.
Thank you very much, Tessa, for your presentation. So policymakers in the audience, notes about the nitty-gritties that you can pick that can also inform the practice that we do. So last but not least is Kinari Shah. Kinari is a researcher in the Department of Pulmonary Medicine, working primarily on novel diagnostics across Asia and Africa. She previously worked on patient centricity in clinical trials at a nonprofit in DC, and earned her MSc in Global Disease Epidemiology from Johns Hopkins and a BS from University of Michigan. Welcome.
Thank you, Paul. TB is once again the world's leading infectious killer, and a significant contributor to this position is the estimated 1/3 of cases that slip through the cracks each year, also known as the diagnostic gap. Better tests are the first step in reducing the global TB burden and closing this gap. In 2014, the WHO introduced target product profiles, or TPPs, for priority areas in the development of new diagnostics. These profiles were shaped by the expertise of providers, innovators, and policymakers across geographies, but strikingly missing from these accounts is the voice of those actually being tested for TB. Persons accessing TB testing are the most affected by these tests. What choices would they make if given the opportunity? And should we not ensure that these tests align with what they actually prefer? These questions drive my research. I use discrete choice experiment methodology, commonly used in the marketing world, to answer these questions. For our experiment, we selected 5 main test attributes: type of sample, accuracy, location, time to test result, and cost. Within each attribute, we included 4 different levels, such as fingerprick blood, sputum, tongue swab, and urine for sample type. And these levels were then randomized into 12 hypothetical test pairs. Like choosing your own adventure, participants then selected their most preferred option within each pair of tests. Instead of just giving respondents a list of options and asking them to choose their favorite, this is actually a better way for us to estimate their preferences as they consider the whole testing picture instead of an attribute in isolation. We surveyed over 1,000 people in the Philippines, Vietnam, South Africa, Uganda, and India who had recently been tested for TB. From our data, we discovered which attribute they preferred the most and which level of attribute they also liked best. We also were able to simulate trade-offs to see what people were willing to sacrifice in order to access a specific test feature. Preferences varied greatly by country. For example, in Asia, the countries and people mostly preferred a tongue swab to other sample types, while people in Vietnam indicated that they would accept a home-based test, although most people overall still preferred a hospital-based test. Above all, people accessing TB testing want a rapid or within 15 minutes, highly accurate test result. But when we did our simulations, we actually found out that participants would be willing to trade up to 20% accuracy in order to access a rapid test result. These insights should significantly inform future TPPs and the development of TB diagnostics, and we should be ensuring that novel TB tests garner acceptance and trust among those undergoing testing. Thank you.
Thank you, Kinari. Can we get another round of applause for all our amazing presenters? So in the audience, there are anonymous judges who are doing their work, and we will know how our participants have performed. But for sure, somebody's going to go home richer than they walked into this place. So unfortunately, the sacrificial lamb doesn't. I don't qualify to get the prize. So as that goes on, I'll now call upon Dr. Nahid to come and lead the next part of the session.
Thanks, Paul. That was a lot of fun. Just a round of applause for Paul and Sophie and the group. We have a special message for you. A special message from Congresswoman Barbara Lee. She, as you know, is a fierce advocate for global health and really has been involved, either authored directly or co-authored every HIV/AIDS legislation that has come through Congress and many TB-related legislations. In fact, she co-authored the Global AIDS and TB Relief legislation in 2000 that ultimately led to the Global Fund. It's just terrific to have this message from her. She couldn't join us today, but this disease and this collective fight we are having against TB and HIV/TB, she believes in, and she wanted to share this message with you all today. So we'll start the message now with Congresswoman Barbara Lee.
Hello, I'm Congresswoman Barbara Lee. Thank you so much for having me speak today about a topic that is incredibly important to me. TB is one of the deadliest infectious diseases in the world today and the leading killer of people infected with HIV. It is critical that we address the global tuberculosis pandemic if we are ever going to achieve success in defeating HIV and AIDS. Even though it is completely curable, TB kills over 2 million people worldwide each year. In addition to early access to ART, high-quality TB screening and expanded use of TB preventive treatment are critical interventions to ensure that people with HIV receive timely treatment for TB disease or TB infection. As the original author of legislation to create the Global Fund, I am so proud of the U.S. legacy of support for an institution that has saved as many as 44 million lives over the last 2 decades. Funding for TB steadily increased from $310 million in fiscal year 20 to $394.5 million in fiscal 23. It is imperative that Congress continue to expand access to TB screening and prevention. It is also critical that we address the global tuberculosis pandemic if we are ever going to achieve success in defeating HIV and AIDS. I am so proud of America's 2 decades of leadership in the global fight against HIV and AIDS, as well as tuberculosis and malaria. But that leadership is coming into question. A few extreme interest groups and members of Congress have tried to bring right-wing abortion politics into the effort to reauthorize PEPFAR. It's having a corrosive effect on America's leadership of these life-saving programs. I am fighting alongside a bipartisan coalition of Republicans and Democrats who believe as strongly as I do that America needs to keep up our leadership and, in fact, do more to end TB, AIDS, and malaria. Your continued activism and organizing is so vital for our work in Washington. TB is completely preventable. We can't stop fighting until TB is defeated for everyone, everywhere. Thank you so much for inviting me. Enjoy the rest of your event. Take care.
Again, with thanks to Congresswoman Barbara Lee and her office for recording that. It's great to have an ally in the halls of power. Okay, we're going to move to the next event, which is session 4, public engagement training with Cynthia. Thanks for coming.
My name is Cynthia Chample. I am a health and public health systems researcher slash health economist at Brandeis University. But most people who know me in this room know me as the chair of Stop TB USA. That's what I call my full-time free time. Because I have been working on policy and advocacy around tuberculosis for going on 22 years now. And so, Ken, thank you for that trip down memory lane. And for the pieces that I wasn't actually an adult for, I actually remember using in my assignments, because I wrote every single one of my PhD course assignments on tuberculosis. And so I was able to recognize almost every single publication that you put up there. And between you and Vivian setting me up, I mean, you're all going to think that the organizers are geniuses. All right, let's get into it. That was me. Okay, here's our agenda for today. We're going to do a little grounding exercise, which is what I like to do when I'm working with my research assistants. And then guidelines for public health employees. We're going to pay a little particular attention to people who do work for offices that have some kind of restriction on the L word or the A word. Public health communication tips. So this is straight out of the social and social linguistics and social psychology research. It's going to be just a tiny little dip of the toe. So hopefully it whets your appetite to go search up some of these. And well, I'll do the caveats when we get to that section. Then we're actually going to do a skill building exercise. Okay. And I love that we're an academic center because I'm sure you all brought pens and papers and, or, those of you who are digital natives, maybe you type things on your devices more quickly, but be prepared to actually write things. And then we have, I'll do a few, so we'll train on the tool, then we'll do a few more tips, and then we're actually going to do the thing. And that's the practice and group discussion. We'll come back and have some peer feedback, that type of thing. And then we'll have a final thank you and come join the fun. Let's ground ourselves. Why do you care? We had an amazing talk from a TB survivor, which may be all the reflection grounding that you need. But I also heard so far today, amazing collegiality, right? Maybe it's supporting your team members. Maybe it's because you have a lot of professional pride and you want to make your program the best program possible. Maybe it's because that burning curiosity to get to the answer for what biomarkers we need to have a 10-day Z-Pack for TB. Why not? Why shouldn't TB patients or people suffering from TB have a 10-day course instead of the months with devastating side effects? Why do you care? And that's what we want to bring and match with the skill building. But first we need to do a little bit of exploration of the space for folks with lobbying and or advocacy restrictions. According to the tax code, nonprofits, so let me just say that I'm actually a little bit of what I consider a non-traditional PhD person, because I did 10 years in the nonprofit policy, advocacy, and some direct service world first. And then I went back and did my PhD, and I just never left Brandeis. I love the Heller School. And one of the key things that every nonprofit I ever worked for was like, oh, well, we have the tax law. We're going to lose our tax exempt status if we do the L word lobbying. What it turns out, though, when we actually would go to trainings about here's what's allowed and here's what's not allowed, it turns out that up to 20%, if you file the H form, up to 20% of all resources can go to lobbying. for nonprofits without risk of losing their nonprofit status. So that's the first thing. Yes, you can. Yes, you can. Now, caveat, that 20% of all resources includes in-kind donations. So if you have volunteers that go under your logo or your organization, then you have to count that into your overall consideration of the 20%. But, and one of our previous speakers spoke about this, it's the interesting thing is that much of what some people are just the general aura out there thinks is lobbying every single minute of every single visit with every single elected official. That's not the definition of lobbying. It's very, very concise. It's when you ask for a specific thing of a specific lawmaker. So please give this much money in the budget for this line item. That is lobbying, right? But if you are telling them the latest epidemiology of tuberculosis for the Bay Area, that's education, okay? If you are organizing and rallying people in an office to like go with you, right? That's advocacy. And there's a huge, Venn diagram, because the vast majority of advocacy and the vast majority of lobbying actually involves educating. And so what we know is that if you do have restrictions, there's always something you can do, okay? Yes, you can. Sí se puede. All right. There is this really awesome flow chart. We can't take credit for this. This comes from Public Health Awaken, an online resource for again, tailored specifically for people who work in public health. But I like to expand that to other folks who have job restrictions or nonprofit status concerns. And so then you're like, okay, well, is this my work hat that I'm going on, or is this my personal hat that I'm going under? And then you can say, no, not sure, yes. And you can follow the logic and say, okay, then maybe not this, but maybe yes to that. And so the bottom line here, and I think we have this on our website at Stop TB USA. I'm not sure which page, but we can also make the slides available to attendees as well. So know that this resource is out there and that, yes, you can. All right. So now let's dive into some of the research that I have personally drawn on in my 20 something years of advocating and speaking with lawmakers. And most of these, because I think it's not just the most compelling, but they make it the most digestible in terms of their research findings, is most of this information is going to come from some communication or part of the website of frameworksinstitute.org. And if you noodle around now, they don't just have messaging memos online anymore. What they have are actual videos. So Framing 101 and 5 little short videos that are just a delight to watch. And again, very digestible, whether you have any psychology training or not. Talking about government. And maybe one other thing, I'd like to give you a background on Frameworks Institute and what they did. And partly why I find this so compelling is they've actually trademarked now what they call strategic framework analysis. And maybe I should do one more back step and say framing. Have you all heard of framing? Do you have any connotation? Okay, I'm seeing blank stares. Framing is basically, it's a fancy term from psychology field that says, okay, how we speak about things makes a difference. So your audience is going to get something different from your communications, depending on what you say, what words you choose, how you say it, what words you emphasize, what words you don't emphasize, what words you don't use. Okay. And then the idea is when you're getting this new information, how does your brain connect it to all of your existing knowledge inside of you and organize everything in a nice, neat, retrievable sort of construct framing. So, strategic framework analysis, now trademark. In the original one, they were contracted by a think and action tank called Demos. And the founders of Demos had decades of experience lobbying in their state houses for social services. And they're like, why can't we get any traction? What is going on here, right? And they noticed, I think what really piqued their interest was this long-standing survey in American political world of trust in government. And basically it had been going down steadily since the 1950s, where it had its peak. So they're like, okay, this is probably something, because you can't fund these social services. There's just too many people. There's too great a need. You can't fund these services without the involvement of government. And if there's no support in the government, then how are we going to do this? So they contract with the frameworks folks, and they say, hey, we're interested in knowing if you could come up with a solution, messaging solution, essentially, framing solution, to either increase the positives of people thinking about government or decrease the negatives, because we'll be happy with either of those outcomes, right? So what they did was a multi-year, multidisciplinary project. And they did a lot of different polls and person on the street interviews to map out the opinions of people. And then what they did was they said, we're not done yet. What we're going to do is we're going to do cognitive mapping, and we're going to see, how did people get to those opinions? And then they said, we're not done yet, because again, we have this mandate from the Demos organization that says we want to move the positives up or the negatives down. So they tried a bunch of different frames, which kind of sound like they come up with these great little bumper sticker titles for their frameworks. And they found that, yes, in fact, if you talk about government differently, both increasing the positives and decrease the negatives. The findings were so striking that they actually put on a roadshow, essentially, and did a huge sweep of different talks and trainings. So that was the original one. And they do tend to get commissions and focus on particular topics. So some of what I'm sharing you is what I've gleaned from some of these specific strategic trademarks analyses that I thought, hey, I can use that for TB, because I'm always thinking, hey, you should use that from TB, or hey, we can use that for TB. That's just how my brain works now. Okay, talking about government, here were some of the tips. They say you want to tell a story. Oh, this came from a newsletter where they brushed off that original one because in the wake of COVID, it was clear that it was really, really needed to brush off these findings. Tell a new story about government as an essential part of providing and protecting the common good. Now, in most of these strategic analyses that they've conducted, whether it be on race, progressive race-based policies that are directed to serve low-income folks, there's dozens. There's mental health for youth in Colorado. There's children's dental services. So go on the website. It's amazing. But the common good is one thing that has consistently, sometimes the frames contradict each other. It's like it's good for talking about government, but it's bad for racial equity issues, right? So sometimes the frames contradict each other. But one thing that is consistently good to trigger is the common good. If in doubt, you take nothing from this talk, elicit, always be thinking about how to remind people of the common good, because by and large, the vast majority of the United States of America population, they get that. It may not be the top of the mind, which is why you have to remind them in order to help them hear your message and be with you to like long enough for you to give your call to action. Spoiler alert. You're going to hear that later. All right. Name specifics. These are the concrete things that government does that really, frankly, not many other people, if anybody else, does. Emphasize roles that only government can fill. Again, remind people, it's like, oh, that's why we did the government thing in the first place. Avoid the broken beyond repair trap. Now, this has actually been pretty consistent finding across a lot of issues, not just the talking about government, is that you want to avoid the despair. It's, I mean, you know it, I know it, we all know it. It's easy to get down to the dumps with all the bad news that it's like, they don't call it doom scrolling for nothing. Am I right? So focus on how we're going to repair the public systems. We need to respond to collective challenges. And then that leads to the shared progress and prosperity. Now, that last piece is another one of their core findings that just is super consistent across everything, which is to start off with a shared value, something that, again, you can pretty much take to the bank that most people in your audience is going to share with you. So broad prosperity. I mean, you kind of got to be a, you know what, to like not want everybody to have prosperity, right? And then public structures is particularly helpful when talking about anything related to government roles or things that government would be funding. All right, so that's that one. And then here's an actual, let's put it all together and illustrate what this might look like in a communication. Maybe this is an oral communication, maybe it's a written communication. We've got our country's prosperity and quality of life depend on the public structures that we have created to keep society going. Structures like health and safety agencies have been put to the test during the pandemic, but their role remains crucial in keeping us all safe. Businesses, nonprofits, and individuals can all play a part in getting our country back on track, but only government has the reach and funding to properly and more equitably direct resources into vaccines, rollout, and economic recovery. Government is not perfect, but it can be fixed to ensure it works for everyone. We must continue to hold our elected officials accountable and work with them to heal and rebuild. So in a thought exercise, you're noticing they did the public structures, right? They were careful to like give the signal, no, you don't have to fall into the doom pit, right? We're going to work together to fix it. And then we got the nod to equity. In fact, people are big into fairness. Right? People are really big into fairness. And so if you're triggering that value, that's pretty good. And okay, continue to hold our elected officials. One of the reasons why public structures tested so well in that original strategic analysis or framework analysis was because what happens in your mind when you hear public structures? Does a picture come up? And if a picture doesn't come up, what do you do with structures? Inherent in the term is something that you have to build. And if you have built it, what happens after decades? Ken knows this. It gets deteriorated and you've got to maintain it. And if you don't maintain it, guess what? Past is prologue. A little bit more on health equity. And this is straight from, again, it was the Frameworks Institute, one of their researchers speaking at a NACHO webinar that was just amazing and really concretized a lot of something. It's a little bit of a good news, bad news story. So more concrete suggestions, right? Start with justice as a shared value and aspiration. This is when you're really weaving in the health equity message. I swear, I did not plant Priya's question earlier. Like, and so you say that's that idea of having that broadly shared thing that triggers to your audience, not just why it matters to them, but that they're with you long enough for you to then share what your issue is and then what the details and some of the nitty-gritty data might be. Here's an example. A just society makes sure no community is singled out or overexposed to harm. This also gets into, they call it fairness or fairness by place, which is another one that tested highly when they were looking at children's dental health. Okay, so there's very intuitive connections here from the longitude of their research. One thing that you do not see in this sentence is the word health equity. And unfortunately, that's where some of the bad news comes in, is because health equity has become a target for political polarization. So for some audiences, you do not want to use that term. But that does not mean that those potential audience members do not have that value within them. Because it turns out we all have a ton of frameworks operating in our brain, including contradictory ones. So the idea is to pull up one that is friendly to your message, to the top of your audience's mind, and not trigger one that is going to fight you, right? Because if you have, or if your audience has an unfriendly frame at the top of their mind, like a consumeristic frame, for example, or my tribe is the, what's that conspiracy theory? QAnon. If they pull up that frame, right, they will fight you on the facts. You can have all the empirical facts you want, but they will fight you on the facts. And I knew this before the 45th president, because I was fighting for immigrant passage, and you're like, legislators literally looked me in the eye and said, oh, it's going to cost our college system, so many dollars. And I was like, no, not even the Romney administration, Secretary of Economic Development believes you. Like, it's going to be a net win on the money. So never start with the money first, because that triggers a consumerism framework and you never win. Social progress, social programs never win when they've got the consumeristic, unfortunately, framework at the top of the mind. Okay, now unequal outcomes is not as useful as unequal obstacles, because again, this gets back to like, I don't know if we're hardwired this way, but like fairness, right? It gets into that. Oh, I'm going to have a knee-jerk reaction if I'm seeing something unfair. And that's where, because if you emphasize on the unequal outcomes, oh, it's their fault. We in the United States have a hyper-individualistic streak to our culture, aspect to our culture. And so it is the easiest thing in the world for your audience to go, blame the individual, or, only slightly less unhelpful, let me save that individual, right? As opposed to seeing the structural issue that we're dealing with and that we really need to do something about. Okay. In a similar way, one size fits all equal opportunity is not as useful to you as targeted justice. And then you hopefully are now thinking about those fun little pictures where you've got the kids trying to watch the baseball game, or the different bicycles. Here's what equality is, and this is what equity is. And then have you seen the next step, which is here's what justice is? Okay, look those up. They're great visuals, but this is some of the psychology research that really emphasizes that visual there. Okay, pair with collective solutions. So again, this is dovetailing well with the idea that, well, government is going to be involved. We've got the common good here, that it's not about individuals, it's about systems and what we have to do together to do that. It's more likely to give a us as or a we versus an us and them, because in generally us and them language is not going to be helpful. It's a we thing. And then, this turned out to be way more important than I ever realized. Shine a light into the black box of the causality. I know we're so careful about correlation is not causation, and that's fine. That's fine. But what you have to do is be able to give people at least a partial story about why this problem you're talking about exists, because it's the same, it's similar to that obstacles versus outcomes. It's so easy to slip into the blame the victim, or to like look at what's the individual doing? Is the individual choosing the wrong food? Did the individual choose to go breathe around other people breathing with tuberculosis? No, we've got a structural thing going on here. What happens is that it's guaranteed that your audience will fill in a causal relationship. So if you are not proactive, then they're going to fill it in. And because of our society, the messaging that you get, defaults, it's probably not going to help us when we're talking about the public health world. All right. And avoid vulnerable populations. I know this one was like, kick in the pants. How many times do I have vulnerable written in some of my article titles? Turns out what happens, and this is again, US population writ large, it goes to them, because the average US listener does not think of themselves as vulnerable. And so it's, what we need to do is cordon them off. If they're vulnerable and I'm not vulnerable, we need to cordon them off and isolate them, or get them out of the country. Who's heard that one before? Okay, so and then this is a few more from another resource online for general public health messaging is phrases.org. They collected a bunch of things. There's some toolkits. So reinforcing a lot of what we already covered from the Frameworks Institute, tangible examples of benefiting with partners, partnering with public health and connecting with the core mission of other sectors. So for example, if you're trying to move something and it needs business leaders to get on board, well, then talk about why this is going to help. I know I just told you not to trigger the consumerism framework, but you're gonna talk to their core mission and say your productivity is going to be improved, right? If you're having to interface or do something with educational leaders in the school system, then this is going to improve attendance. Like your students are going to be able to do better if they're healthier, right? So you're connecting that with their core sectors. And this is just, again, messaging 101. The messenger is important, but the tailoring what you choose to emphasize is going to shift from audience to audience. All right. So now we're going to transition into our skills building session. First, we have to take care of some alphabet soup because I'll probably at some point rattle off LTE really quickly. That stands for letters to the editor. Each congressional office interprets a letter to the editor differently, but I have heard from staff that some as few as 12 constituents, and one office said, well, yeah, we count each letter to the editor as counting about 110 constituents. So there was another congressional staffer that we had worked with in the past that said, it is impossible to overestimate the impact of letters to the editor, and this is particularly in the local hometown paper of the member of Congress. They say we clip them out, and of course now it's digitally, but we clip them out, we pass them around. They used to have a bulletin board where they, the physical printouts would be pasted. So it is a twofer in that you're educating fellow readers of whatever media outlet and also educating the congressional offices. Now, op-eds are called that because traditionally they were always opposite of the editorial page in old school print newspapers. These opinion pieces are generally longer than a letter to the editor. The average letter to the editor is depending on if it's a local paper or a flagship paper. So New York Times is about 150 words is a good target. A regional paper like the Boston Globe would be 250 words is a good target. Local papers tend to go for 400. But op-eds are in the neighborhood of 750 words to 1,000 words. Not very long, but very impactful because they are generally seen by congressional staff and members as representing more constituent voices than a letter to the editor. And then an editorial is even more impactful still because it's seen as representing the number of the circulation of the paper. So if your circulation is in the hundreds of thousands, then that's a pretty big deal for the editorial to be printed in that. And again, I mentioned the 2-fers. I love 2-fers, I love 3-fers. So be on the lookout. All right, simple formula, compelling, creating a compelling message. It's that broad shared value that we've already talked about, plus the epic format. Now, what's the epic format, I hear you asking? Good question. I have to give results.org a big shout out for developing this and honing it to the point where they literally get shout outs from the floor of the House of Representatives and the Senate floor as being the most impactful grassroots lobbying organization. Okay, so let's go through this. Now, I've already hinted at this from the frameworks, and these are this is from 3 of their earlier strategic framework initiative works. And I just love this graphic because it really shows how, I mean, probably you, because hashtag academia, and me, and we appreciate data and we love numbers, and you got to resist. You got to resist because the actual specifics, the actual data is the 3rd level. It's the least important of what you're going to communicate. The most important is that broadly shared value. 1, to keep, to try to trigger that friendly framework in your audience, but then 2, how to give them a reason to listen. Like, why are they part of this? Okay. And then you get into the policy domain, such as health, public health, infectious diseases, and then you get into the specific policies. Here are a couple of, or just a list. I told you they do really good like bumper sticker names for their different frameworks, and the values that they have tested well in some of the various analyses that they've done. Responsible planning, opportunity. I think responsible planning came out of the one for policies targeted toward low-income folks. Opportunity came out of the education for non-white students. Stewardship also came from there. Future preparation came from the low-income folks. Opportunity for all. Prevention, and then that common good one kept coming up again and again as always good. Like, you never go wrong eliciting and bringing up the common good. So remember, value first, and then you can get into your juicy details. So here's a frame bite that I lifted straight from the frameworkinstitute.org website that shows the interplay of, okay, here's how to get to the value first, and then we're going to do the 2 levels after that. So in many parts of our state, some communities are struggling because they are not given a fair chance to do well. This is because programs and services that support health are not fairly distributed across all communities. When some communities are denied the resources they need, they are unable to overcome problems like poor oral health for their children. There are a number of things we can do to level the playing field so that where you grow up doesn't determine your health outcomes. For example, we could improve funding for school-based dental screening programs statewide to identify children with unmet oral health needs. So they didn't even get to the issue until they were, 2.5, 3 sentences in. Did you see how that works? Value first. And it was very much, I had hinted at this earlier, was the fairness across communities. So the distribution of resources across communities. Okay, whoops. Here we go. Training. EPIC, EPIC format. It's a concise, powerful way to communicate. What is it useful for? Absolutely everything. I have used it for every single one of these examples, like personally, just in my life, including recruiting somebody to join Results Massachusetts that I had just met on the public bus. All right. Pens, ready? Devices, ready? Okay. Excellent. E stands for engage your audience. And I spent a lot of time because oftentimes thinking about which value to start with and how do I do this like welcoming, creating the most broad welcome mat possible to like, come learn about my issue. You too are part of this. Come with me. You want to respond, 4 letters to the editor. And my invitation to you is to think about an actual news outlet that you read, if not regularly, at least once in a while. And think about submitting what you work on today, actually submitting it for publication to that outlet. Okay, it might be a news outlet, although we've worked with groups. I did this similar training at Harvard and multiple places. I'm actually based in Massachusetts. I don't know if I said that earlier, but they got letters to the editor in academic journals published. So literally, you can use this format for anything. Invoke the common value, that's what we've been talking about. And then 1 to 2 sentences is ideal. Again, if you're in the elevator pitch, or if you are thinking of a letter to the editor. Here's an example. And this example is actually, I love this. This was one of the Stop TB USA youth leaders, she was a junior in high school when she got this published. Yes, you can. We need to be able to diagnose tuberculosis as fast as we can diagnose COVID-19 in order to adapt conditions according to diagnostic test results. In the same way that Thailand placed restrictions on communal activities upon rapidly diagnosing more than 50,000 new COVID-19 cases, effective diagnostics must be developed for tuberculosis so that similar preventative methods can be enforced in TB-prone areas. And then there's the citation of the actual article from her paper that she was responding to. That's just a tip for increasing your likelihood for being published. Let it be in response to either an editorial piece, first, a front page piece, second priority, and a third priority is anything else published in the paper. Right. That's E, engage. So now we go to P, present the problem. You want to present as close to the cause of the problem as possible. Here's a caveat. The reason why I say as close to the cause of the problem as possible is because you're going to be asking for something. You're going to be actually illustrating a solution. Spoiler alert, that's the I. So what you want is a match between the problem that you're describing and the solution that you're going to be presenting in a little bit. So presenting the problem, you want, again, the idea of anything that helps move your audience's focus on the structural issues that you're really trying to address, as opposed to going into that one person just needs to do X, Y, or Z, and then no more problem, right? Give details as necessary. And you can add a sentence about why you care about TB or the issue you are writing about. Now, the reason why I say this is because if you are passionate, and this connects directly to the grounding exercise we did at the beginning of the session, people, if you are really into what you're saying or what you're writing about, people get that. It comes through. I mean, I know it's obvious listening to me that they would get me, but no, it's true. I've seen it again and again and again. I mean, I have trained probably over 100 people as a results group leader, and brought them into meetings with their members of Congress, and the light bulb goes off. Like, even the quiet spoken ones, when they do this type of preparation in advance, it comes through. All right. So here's the example. Current diagnostic methods for tuberculosis are expensive, lengthy, inaccurate, and inaccessible for patient populations at risk. I mean, Ria did a fantastic job of using like a whole range of the problem in just one sentence. You got to give her props. And that's probably why she was successful in publication. All right. Illustrate the solution. That's the I. Give a concrete solution. Paint a picture. Whenever you're thinking about what word should I choose, just any word is better than no word, right? Because you don't make any impact if you never do this. But if you actually have time and think about it before you send it in, try to use words that are inherently visual, like that public health, the public structures example from earlier, right? One of the ones I like to do when I use this, I have a guest lecture that I do at a couple of our different courses at Brandeis. And so I usually use the public state lab as the solution that I'm presenting. And I always say it's the bedrock of our collective prosperity, so that I'm reiterating my value. And then I'm also saying bedrock. There's a lot of rock. Originally, I'm from Iowa. We don't have rocks like New England has rocks. Like you walk and there's just rocks in the soil. It's like, where's all the soil? So yeah. So I feel like bedrock is really solid. So think about that visual word options when you're writing. Okay, so Ria continues. The World Health Organization has recognized the need for a rapid tuberculosis test in the NTB strategy by stating that all countries should aim to achieve the uptake of new diagnostics by following the plan's first pillar, integrated, patient-centered care and prevention. A significant step toward achieving this goal is found in the work of the Global Fund Replenishment Conference to fight AIDS, TB, and malaria. So this was just before the big replenishment meeting in, I think, 2002. Was it September 23 or 22? 22, thank you. Yeah. But also, do you not just love that this was about COVID-19 crackdown on freedom of mobility in Thailand? And this is what she ended up. So literally, we can connect anything to TB. Anything in that paper can be connected to TB. That is the challenge. If we go to dinner together, that's my parlor game. You give me a topic, any topic, I'll connect it to TB in 2 sentences. All right, call to action. EPIC, EPIC, C is call to action. Your audience is primed. They are informed. And now it is time to activate them. You want to ask for something timely and specific. Now, I can't emphasize this enough. If you go into an elected's office, particularly at the congressional level, they are all drinking from a fire hose every single second of every single minute of every single day that they are on Capitol Hill. Even if they are 100% with you and want to support your issue, if you do not ask for something specific, they won't say this to your face in terms of, you just wasted my time, right? Because they especially like meeting with constituents. But you kind of wasted their time, right? Always come with a concrete action. The more timely, the better, because again, reference that fire hose, they'll want to do it. But by the time you've left the office, gone back to your home, their inbox already got another 30,000 messages, okay? So it's really easy. I mean, if you think about what your inbox looks like, how did I oversee that thing that I really wanted to do, but I didn't get to it? Okay, so here's how Ria wrapped up her letter to the editor. Urge your elected officials to follow through on the United States pledge by ensuring that the Global Fund's objective of raising $2 billion for fiscal year 2023 is met and appropriated for this next fiscal year towards saving millions from TB around the world. So she knew that the pledge had gone through, that we got the $6 billion over 3-year pledge. which first of all was a pretty big deal because one, it's a multi-year pledge, and two, it was pretty much the maximum that we were going to get from the administration. So that was really good accomplishment. And then the next step is make sure Congress appropriates that according to the pledge. Update. Unfortunately, we're not going to get the $2 billion, even though it was pledged. And that's because we have a statute in place right now that restricts the United States money that we send to the Global Fund to be 1/3 of what is donated. And because the global inputs and donations did not quite reach the 4 billion, we don't get to give 2 billion. So unfortunately for fiscal 24, I'm going to try not to swear. We didn't get the 2 billion because the rest of the world didn't quite put in the 4 billion. And fiscal 25, we've been told, don't even try. So we've modified that request. I think we're in the like 1.65 billion for the next fiscal 25 appropriations process. So it's not 2 billion, but for anybody who is connected to ministries across the globe, you know, give them a little nudge and say, hey, put in a little more. And then the US is going to, you know, put in a lot more. Okay. So that is an update on that piece. Call to action. All right. Just a few quick pre and post writing tips. Again, straight from our youth leaders. They put these together. Step one, pick your media outlet. And this could be a national outlet or it can be your local paper. And again, do not underestimate how important the local paper is to your members of Congress. Find out what town they're from and then stock that media outlet. Okay. Find the requirements. All you have to do is search up guidelines, letter to the editor, or letter to the editor directions, instructions, that kind of thing. And then follow the guidelines while you write. When you finish writing, obviously you want to submit it because it can't get published if you don't submit it. And then go ahead and set a Google alert for your name in that outlet. It doesn't always work. So again, our media work group and youth leaders, they've actually gone and did additional supplementary searches for the names and the media outlets when they submit. And then when the letter to the editor is published, it's important to share that, okay? Do not hide your light under what's your candle under a bushel? No? Let it shine. Because what happens is that you can leverage more impact, right? So you're like, oh, this takes my time. I don't want. No, literally, once you get published, other people can write in response to your letter. And that's the top tier of prioritization for publishing letters to the editor is if you are replying to something from their editorial page. Media outlets love that stuff, okay? Second of all, cut it out, print it out, or copy and paste it into an email and send it to your electeds and say, hey, I'm a constituent from Concord, Massachusetts, and I wanted to let you know that constituents are talking about tuberculosis, right? So you keep it alive and then you get twofers. You get twofers out of it. Actually, you can probably get a threefer because you can have a whole chain of letters to the editor from all of your friends, colleagues, cousins, buddies, dog friends. I mean, dog owning friends. Yeah, the typing is hard with the pause. All right. So now it's your turn. How much time do we have left in the session? We have half hour. We have 60 minutes. Excellent. Okay. So what we're going to do is probably for the folks in person, you know, pair up, have a 2x2, because I'm a big believer in peer coaching and peer learning. And what you're going to do is you're going to draft a letter to the editor if you have a media piece in mind, or you're going to draft a elevator speech. We call them laser talks at results. But elevator pitch, it's the exact same length as a letter to the editor, about 250 words is a good target. And you can deliver it in an elevator, or as one volunteer I know in Utah, when the senator came in for his latte, because she was a barista at Starbucks, she delivered an entire elevator pitch to him while she was making his latte right there in the coffee shop. coffee shop. It was on child tax credit. So I will circulate and answer questions. Feel free to raise your hand. I'll come running. If the call to action is a great starting point. Like when you know what you're going to ask for, then you can work backwards and say, okay, how much of the solution do I need to build? What's the portion of the problem that I shine a light on and really bring forward? And then you may have already an idea of what your value you want to use at the beginning. Part of the reason why I'm encouraging you to think about either a media piece or an elevator pitch is because we have a couple of opportunities for speaking with your members of Congress coming up imminently. And I can tell you more about that as well a little bit later. But here's some of the calls to action as we brainstormed. And so everybody should have a couple of worksheets by now. We handed them out? Okay. So you'll notice that one is really focusing on global TB and the other one is really focusing on domestic TB. And so the first sample call to action here on the slide is directly related to that domestic one. And we even broke out the worksheet as a sample: E for engage, P for problem, I for illustrate the solution, and C the call to action. Now, we have a couple of things that are percolating right now. These three are very concrete asks, but then we heard another one in this morning's session, right? You could also ask your member of Congress, either your representative or your senator or all of the above. Why not go for three? So don't stop after you just write one. Write all three. We need pressure on the FDA to allow the global drug facility drugs here, drugs and diagnostics, right? Because we're facing so many shortages and just hands tied. I mean, talk about the rough times that TB programs are having domestically. I mean, we're telling them to fight this millennia-old scourge with one hand and one leg tied behind their backs, right? So that was another concrete action that I heard about. If you want to go super local, we heard of the local bill. Priya, do you know the name of the bill again? AB 211. 2138. 2132. Okay. Right. If you want to go local and say, I'm going to write my assembly person in the California Assembly, do that. Absolutely. It's the same structure. And you're going to ask them to co-sponsor the bill because it's in co-sponsorship process right now, right? Because it just got in 2132. 2132. So that's a local California bill that you can also think about if you want to write your communication on. And then we have here a group of us, again, led by Dr. Priya, but a coalition sent in a letter to the CMS administrator, Brooks LaSure, well, specific contacts at CMS, to support the national determination of LTBI screening and testing. Specifically, let Medicare cover the IGRAs, okay? Because we've had the U.S. Prevention Task Force has been working on or has given an A or a B grade for the evidence for this. I think the original one was 16 years ago, and Medicare has never stepped up to say, yeah, we'll cover it. Turns out it's not an automatic thing. I thought it was because, I'd been teaching undergrads on the major provisions for the Patient Protection and Affordable Care Act of 2010 for years. And I just assumed that TB infection testing was covered, but it's not an automatic step. So we had to write to CMS and say, please do the formal thing that you need to do in order to get this coverage covered for your Medicare beneficiaries. It's called National Coverage Determination. And it turns out we got a response that said, yeah, we got your letter. Looks great. We can't get to it because we're understaffed. Or maybe some distant future time, maybe, possibly, maybe we'll get to it. The only way that we are going to get this moved up in the queue is if they get the message that this is really important to key constituencies. And I guarantee you that if a senator is writing to CMS Administrator Brooks LaSure, which is your concrete ask, asking in support of this national coverage determination, so please take it up and please pass it positively in the affirmative, okay? If she's hearing from them, then they're going to be talking to the people in charge of processing of this process. And then that's the goal, to get Medicare to cover this. Because TB programs got 99 problems, and we don't want that to be one. Do we have a question?
We already have an enthusiastic participant from online.
Suggested participant?
Yeah. Enthusiastic participant, sorry, who's already done the epic, gone through it, if I may.
Okay, so like an example that we can then.
Yeah, so engage would be, you all clearly care about tuberculosis. You get up each morning and go to work with aspirational goal of eliminating TB. Look next to you, there is someone else who cares about TB with the same goal. The problem is members of Congress don't know about the realities of TB you see and experience every day. Illustrate is you have a story to tell. Imagine if you wrote or directly spoke to our members of Congress. And the call to action is talk to the person next to you and the state and state what story you have to tell a member of Congress.
Cute tissue. That is so beautiful. That person gets an A+.
Teresa Rugg.
Oh, Teresa, thank you. You made me cry. Okay. Okay, so then on the global side of things, I mean, who can follow that up? On the global side, here's a concrete ask. We have the NTB Now Act S288, and that should have the House number too. I'm not making this up, people. The House number is 1776. Freedom from TB, baby. Right? It was destiny. So that's always nice to put in there too. But if you want to focus on the senators, you're going to ask them to co-sponsor the NTB Now Act S288. And the House, if it's a House, if ask your representative to co-sponsor S288/H1776. Another quick update in this space, there usually is a companion bill. So this is focused on coordinating our monies with global goals and global partners focused on the global TB. The domestic policy bill that's often a companion here is called the Comprehensive TB Elimination Act. And given the rugged goings-ons in the House, we don't anticipate pushing, it's just not going to get through. So we're shifting our focus on the political windows of opportunity that we do have right now. And that's why you do not see as a domestic call to action right now, please co-sponsor the Comprehensive TB Elimination Act. It hasn't been reintroduced, and we're rethinking the strategy on that one in terms of the national coalition called the TB Roundtable. Any updates I want to say on that? No, I think that's where we'll leave that. But again, that gets back to the key thing that works is timely and concrete. Okay, timely and concrete move together. Does anybody have any other calls to action that they want to share with your fellow audience members that you're thinking about, or that you know that's, okay, there's a group working on this thing and this will help? Okay. As they come up, because I'm going to circulate as you're writing, and as they come up, or if I hear new ideas, then we'll share them with the full group. All right. So I think, yes, let's go ahead and write, and I will circulate. And I'm also going to we'll bop on, we haven't forgot Zoom, folks on Zoom. Feel free to start drafting. Thank you, Teresa, already launched it extremely well. And yeah, start sharing your E's, your P's, your I's, and your C's. I was lucky enough to circulate to about 5 or 6 groups. I heard some amazing discussions. I heard some amazing drafts already. Does anybody want to share? You can either share your whole draft or just your E or just your P or just either your engage, your problem, your solution, or your call to action, and we can workshop it as a group. All right? Yeah? Okay, yeah. Where's the microphones? Do you have a microphone?
Yeah.
They come out anyway.
Hi, everyone. I can just go through briefly each of our points. So for engage, we have imagine living in a world where individuals are sick and dying by the millions to completely preventable and curable disease. This is our reality with living in a world with TB. And for our problem, we put the money we put into TB was directed to COVID, causing many people to lose their livelihood or even their lives because the resources weren't there to detect and support them. And for solutions, we didn't name Renee, but we kind of used her account. So we just said, from a TB patient's account, she had familial support insurance, but she still suffered for over 75 days and over a year on 3 different regimens. It's more expensive to ignore TB than to take action. And for our call to action, we said, it's time we redirect money into TB relief efforts. If we don't take action now, then when?
Okay. Yes. Thank you so much for that. Okay, the microphone is right there. So if you have an idea, raise your hand if you have feedback or, just share what you noticed, either something that you're like, oh yeah, that was great. I heard that, that's great. Or if you heard a gap, you're like, hey, maybe this might help fill your gap. So let's get some pure feedback here.
All right. If I wasn't in medicine, I would totally have been caught up by just really clear, palpable, the opening pieces, although in using Renee's stuff. If I was a congressional aide at the end, I'd hear your ending statement and I'd want to see like one of those things attached to it, like support this bill, so that then they could tell their representative or senator, like, look at this great thing. I really felt like, God, I felt for this one and support, I don't know, bullet one, fund the
You were
CDC,
like, you were on the 1 yard line.
But yeah.
And you just needed to go, here's the funding number.
Like, mom put money in my ATM, this account. Venmo me, mom, at this, like, it's right there.
Yeah. Okay, perfect. Who else has some helpful suggestions? Any other? This is a clue. At the very beginning, I heard disease, right? So I was like, oh, this is health, but for shared value. So that was level 2. I was like, we're jumping in on level 2. So you can think about what is another way of bringing in people, because if they've just had 4 meetings, including, again, when I said drinking from a fire hose, we're talking about minutia, like the name on the new senior center in Lowell. And then the next meeting is, iron ore mining. And then the next meeting is so a way to, again, ground them and bring them in and say, you're on this case. Because like, if they're like, oh, I'm healthy, maybe I'm not going to listen to you, right? Or be as compelled by your message. Yeah. Okay, who wants to share something from their draft? Let's have another draft. Oh, yeah.
Thank you. So for engage, California is known worldwide as a leader in health, education, and equity. When the COVID-19 pandemic hit, the state of California took the problem on head on to the benefit of all of our residents And yet another infectious killer, tuberculosis, is on the rise in our state. The problem, tuberculosis cases and deaths have increased worldwide for the first time in a decade, and California is no exception. More than 6% of Californians, 2 million people, have been infected with TB. Of those infected, only 1 in 5 are aware of their TB infection, and another 12%, and only 12% have received treatment. California's estimated.
Okay. Peer feedback. What did you notice? What's that changed the delta? No, the delta, the plus. Props.
I heard a super concrete ask.
Super concrete ask? Yes, absolutely. Okay.
The concrete ask, you could even go one step further and say, I forget the words you used, but ask your representative, will you join us in asking your representative by doing X?
Yeah. What else? Suggestion?
Cynthia, listening to you earlier, I think it was naturally very heavy on the data.
Mm-hmm.
I mean, I come from that background, so I appreciate it. But outside our realm, people just, the numbers don't make that much sense to them. So I would try to add that personal story to it.
Yeah, personal stories. And the, you know how sometimes they say your greatest strength is also your greatest weakness? That's true for stories, particularly in messaging around public health communications. So the two sides of the coin is that, yes, absolutely, personal stories. I mean, Renee, right? You want to tell it in such a way that it points to the systemic problem or point to the systemic solution. Either one, because you could literally use the story at the beginning, the middle, or the end, the E, the P, the I, etc. But it's always risky because we're, again, the extremely strong pull of individualism in this culture means that it's the easiest thing in the world for your if left to their own devices, your listener's brain to go into blame the individual, or this isn't it, fix the individual type thing. So absolutely yes to stories with a caveat and a caution. Okay, I think we have like 3 more minutes. Does anybody want to do one more quick share? Yeah, right here.
So we wear coats to protect against deadly cold in the winter, and we can find ones designed to fit children and adults of all sizes and different tastes. Tuberculosis affects everyone, including children and pregnant women, but they have more limited treatment options because data is not gathered until the drug is in the market. Earlier inclusion of these people into clinical trials will ensure that they can access the new effective treatment along with everyone else. There are new tools to make this safely possible. Would you work with FDA to amend their industry guidance so the pharmaceutical industry is properly incentivized to do the right thing?
Nice. All right. What did you notice? Give a little feedback. Anyone?
I'm actually going to have a question for you, Cynthia, because I think the same question came up here, is that if there's not a specific bill, if there's not something that concrete, who's the right person to ask and what's the right person to say? We came up with, would we direct this, all we could think of was, would the TB caucus take this on as an issue? And what do they do then? Do they write a letter? Do they write a proposal? Do they write, I mean, is that where to start to put something like this ask into a working group in Congress to give that issue visibility?
Brilliant. So I always phone a friend And usually it is one of the coalition partners that are in DC full-time. So a results.org or a TAG group. In the case of, is Vivian still here from Coalition for TB-Free California, who's following the State House closely? Because I do this at the Massachusetts State House as well as the Congress. There's so many steps. In a version of this talk, when I do the undergrad guest lectures, I start with, I'm just a bill on Capitol Hill, Schoolhouse Rocks. And what we do is we show it's not just 3 steps that passes in the House, passes in the Senate, and the Senate, the president signs it. It's not just 3 steps. It is a million steps, and that's just legislation. Then after it passes, there's regulation, right? So that's where we have multiple pieces of legislation passed. But this request here, this one of our sample call to actions here is, now we need to have the CMS do what they already are regulatorily supposed to do, but they're so understaffed that they can't get to our issue. So we need to put a little extra pressure to get up into the queue and make sure it happens for TB. All right. So there's administrative steps. Sometimes we don't write our members of Congress, but the focus, who is the key decision maker? Who can make the actual thing happen? You always want to ask who has the power to actually do what we want, and then work backwards until you find who you have leverage over. Typically for an everyday person like myself, it's my members of Congress, because I hire them, I fire them, and I pay their salaries. So they have to listen to me. And then what we found, and by we in this case, I mean results.org, over the years, is they found that members of Congress really listen to their constituents and they listen to their colleagues. Okay. And so when they had a chair of a particular committee get more feedback and just like, hey, nudges in the hallway from their colleagues on a given bill, that's when we passed the $1 billion mark for the Global Fund to fight AIDS, TB, and malaria, and not before. The AIDS orphan money, for example, it was being held up by one senator, and we call it the Oklahoma miracle. And it was somebody who knew his wife from church. And that's how we got to the senator. And yeah, within overnight, he changed his mind. So when we're formulating a concrete, there's always going to be a concrete ask. And in this case, the FDA might have to take an action, but I know I told them there's a couple of things going on. So Elizabeth Warren, there's a big concern in Congress of microbial resistance. And so there's initiatives on that. And maybe you can leverage that piece, see that bill as an example, and then you work with somebody, with the legislator, to say, hey, will you introduce this bill on making sure that there's dosing appropriate for children and pregnant women. But also, I've been hearing a lot from NIH on DEI initiatives, and I've been hearing a lot on let's get more women, let's get pregnant women in randomized controlled trials, clinical trials in any way. So there's a whole movement already out there that you just have to tag into, and then you're using your EPIC talk on them to say, will you please add TB to your list of concrete examples that will compel, whatever the ask is for the next step with them. Because if you thought of it, somebody else has probably thought of it, or a parallel thing that you can latch onto. If it is truly starting from scratch, that's usually where it is that you get a sample, you work with somebody to write a sample bill, and then you shop it around and try to get a lead sponsor, and then you build in the background. But it usually starts with tapping into an existing coalition. And if there is none, you build it, but that's going to be a longer term project.
So for a group like RIO's, they wanted to send that letter. I mean, would they send it to an advocacy group saying this is what we think language should have? Or here's the issue, because they're not going to know all those steps in Congress. And I haven't watched Schoolhouse Rock in a long, long time. So, but would that help? I mean, where would you go?
Yeah, I have just set up a consultation and say, here's the issue that we really care about. Here's what we want. And then can you help us map out how to get there? Like, what are the steps? I mean, some groups like ATS and they hire professional lobbyists, and then the lobbyists tell them what to do. So to the extent that I mean, I'm always all ears when I'm on a meeting with a professional lobbyist, because I'm like taking notes. Okay, this is how they do it, and this step always comes after this step.
Well, in California, so Ami Berra, we checked, he's still the representative who is still one of the co-chairs of the Congressional TB Caucus, and his co-lead is a Republican from elsewhere. But I mean, it's just something for us to know in California that the one TB working group that I've ever heard of in government is actually co-chaired right now by a representative from California.
Yeah, so you have extra leverage on the TB. It's called the TB caucus, and it's right now it just has House members. Sometimes caucuses have both House and Senate members, but right now it just has House members. And Ami Berra, from California, is the lead. And so he usually is, like, for the TB Roundtable Coalition, he's usually the first person we go to when we want to generate a Dear Colleague letter on an appropriations ask, like this #1 piece here. And then we circulate because we build knowledge and buy-in, and then leadership sees these signals. Oh, how many people signed that Dear Colleague letter? And that's an intermediate step to getting the actual appropriations. So there's so many steps. It's many, many opportunities to get what you want accomplished. And then I think I have to call, it's break time.
So thank you so much, Cynthia. So incredible and useful, and I look forward to putting that into practice immediately. Last break of the day. Come back, please, at 4. You won't want to miss it. It's updates from the field, both in terms of active and latent TB treatment here in San Francisco.
Welcome to the 5th session. And this is going to talk about TB care and prevention in San Francisco. Personally, this is one of the sessions I look forward to, because when you talk about TB, there's that tendency to think that TB is just out there somewhere. Globally, we give these numbers. But this is a sobering reminder that TB is right here with us. And today, we have presentations from, we were supposed to have Amy Tang, but unfortunately she can't come in. Luckily, Susanna, who I'll introduce next, will be able to tell us about what Amy would have told us. But Amy Tang is a primary care internist and the director of immigrant health at the Northeastern Medical Services in San Francisco Bay Area, where she oversees hepatitis B and C, and together with tuberculosis elimination programs. So if you remember earlier on, there were shown presentations, or somebody, one of the presenters worked together with the Northeast Medical Services. And for the presentation now will be given by Dr. Susanna Graves. Dr. Susanna Graves is the tuberculosis controller for San Francisco and has also been serving as acting director for the disease prevention and control branch since January 2023. Prior to her work in San Francisco, she served in various roles, including chief of TB control and refugee health for the County of San Diego, and on the faculty of University of California, San Diego, as the site director for the Global Medicine Residency in Mozambique, where her work focused on postgraduate medical education and tuberculosis prevention among hospital workers. Please welcome Susanna.
Well, thanks so much for your introduction. And yes, I will. Amy won't be able to be here today, and she asked if I could present her slides, so I hope I can do it justice. A lot of this is her work and the work of NEMS, and also some of our joint work. So the first part, I'm going to be telling you some stories today. So we'll finish the day with some storytelling. And the story, this first story I'm going to tell you is about a partnership that's been an ongoing partnership between San Francisco TB program and NEMS, which is a local federally qualified health center, to do some prevention work in single room occupancy hotel buildings in San Francisco. So a little introduction about NEMS. NEMS is a nonprofit community health center. It's a federally qualified health center that's serving medically underserved people since 1971. It serves about 70,000 patients annually across 14 clinic locations that are in San Francisco, San Mateo, and Santa Clara counties. 88% of the patients at NEMS identify as Asian, and 80% have a language other than English listed as their preferred language. 78% are Medicaid, and 6.5% are uninsured. About 1/4 are 65 and older, and you can see the clinic locations listed on the map there. And they have comprehensive primary care services, including adult medicine, pediatrics, and OB-GYN. And they also have in-house pharmacy, laboratory, and radiology services. Tuberculosis at NEMS. Tuberculosis prevention has been an aim of the immigrant health program, and one of the focuses for years, and has been something that Amy and I have worked on in recent years. And TB has been identified as an issue for patients at NEMS. In 2022, 25% of the TB cases in San Francisco identified NEMS as their provider of health services prior to or at the time of their diagnosis. 20 to 40% of NEMS adult patient population screens TB test positive. And NEMS is also a TBESC site, which the TBESC work at NEMS is being done in collaboration with UCSF, as well as the California Department of Public Health, and also San Francisco DPH. We'll come back to this map in my presentation that's coming up, but just to think a little bit about the incidence of TB in San Francisco, this is a heat map that shows incidence by neighborhood in San Francisco. This is the 5 years leading up to 2022, and I'll show the heat map for the last 5 years ending in 2023 in a moment. But you can see that there's a really wide spread of incidence in San Francisco. The incidence in some neighborhoods looks more like the national US low incidence, below 3 per 100,000. The neighborhoods you see there in light green have an incidence that's higher than the US incidence, sort of between the US and the California average incidence. The teal neighborhoods have an incidence that's higher than the California average, California being one of the higher incidence states in the US. And the neighborhoods shown in dark blue are the highest incidence neighborhoods in San Francisco, with over 20 per 100,000 incidents. The 20, for reference, 20 or 23 per 100,000 is the same as the incidence in Mexico as a country. So when you think about the incidence in these neighborhoods, you're thinking of it more in terms of an incidence that we see globally than the average overall US incidence. So TB is not affecting all communities the same way. And in San Francisco, it's very localized to by neighborhood and by where people are living. Yeah, I guess it would be nice to overlay the picture of where the NEMS clinics are with these neighborhoods. But NEMS is serving these populations that live in these neighborhoods, and the clinics are located in some of these higher incidence neighborhoods. So among almost 29,000 NEMS provider visits in San Francisco, as of January 1st, 2022, 3% reported living in an SRO building or an apartment. And of those, 66% had been tested for TB. And of those who'd been tested for TB, 26% had tested positive with either a quantiferon or a PPD. So this image was included by Amy just to give an idea, because I think most people in this room probably have never been inside an SRO or seen the inside of a room of someone who's living in an SRO. It's funny, when I was going through this slide deck with a member of our disease investigation team yesterday, and she looked at that, she said, actually, this is a really nice SRO room, because usually there'd be, there wouldn't be this like shelving and counter space here. Usually it's just the bed. So this is kind of a spacious SRO room. Sometimes there's 2 bunk beds in a room this size. So given the high rates of TB among patients at NEMS, and given the situation that we have neighborhoods with very high density and high rates of TB, and patients living in SRO buildings with very high rates of TB test positivity, this sort of set the scene for an opportunity for prevention. During the COVID-19 outbreak response, San Francisco Department of Public Health partnered with NICOS, as well as, which is a community-based organization for health in the I'm forgetting what the acronym stands for, but it is an association of healthcare organizations that serve the Chinese community in San Francisco, which includes NEMS and also SFDPH. Together, jointly conducted outreach in SRO buildings where COVID-19 outbreaks were identified, to do phone and in-person outreach to get people in for testing and offer them preventive services and PPE, and support them to maintain isolation while they recovered from illness or for quarantine. Using some of having identified where these SRO buildings are, allowed NEMS to look at their own electronic health records and cross-match those addresses with their patients, and identify by address which buildings had large proportions of patients that had been tested for TB and their rate of positivity. So, looking together at this data, we were able to see that there were SRO buildings that had high proportions of positive TB tests. And also, because NEMS had historical data about negative TB tests, we were also able to identify where there had been TB test conversions from negative to positive, indicating that there had been recent infections among residents in the building. So, looking at this information together, we jointly wanted to approach being able to do some preventive services in these buildings, because we knew that there was high risk of TB cases, and then we also could see which buildings had recent infections. So the sites that are shown with the red circle there are sites where there was at least one TB conversion between January 1st of 2019 and December 31st of 2021. We were looking for recent conversions in these buildings. So together, we prepared to do some outreach supported by community health workers from NEMS and a project associate at San Francisco DPH, along with health workers from our team as well. We developed phone scripts that would be used by community health workers at NEMS to conduct outreach to patients for whom they had phone numbers for, who lived in these SRO buildings, which have been prioritized for TB testing, these buildings that showed recent TB test conversions. We kicked it off by hosting a joint World TB Day community testing event at a location hosted by Chinatown Community Development Center, a local CBO that supports people living in SRO housing. And also Quest kicked in some free testing for uninsured people and free phlebotomy for anyone who showed up on site. And that was the initial outreach for one of these buildings that was managed by Chinatown Community Development Center. April to May, we conducted additional outreach that was either in person or mailed letters to 4 other high priority SRO buildings that we'd identified with educational materials that we developed together. And then in December of 2022, we also delivered an in-person TB educational talk with a presentation in Mandarin presented by a community health worker from San Francisco DPH, and one-on-one follow-up with in-language assistance from NEMS community health workers as well, helping people understand their risk and know where to get services for testing and treatment. So the approaches were different for different buildings, partly based on the location of the building, the resources that they had, the type of management. Some of these were private buildings, some of these were buildings that were case managed, say by Chinatown Community Development Center, or in the case of a pair of buildings in the Tenderloin through a contract with the city. So here you can see the teams doing the joint outreach and some of the educational materials. There's the letter that was sent, to the building. Here's a PowerPoint presentation that was presented by San Francisco DPH health worker, and these are the teams doing the testing on site. So in this outreach, we did manage to reach over 500 patients in 6 different buildings. I think one thing that came out of this, in addition to increased awareness for building residents about their TB risk, TB status, and symptoms to watch out for, was this case that was one of the patients at NEMS. It was a 73-year-old man who had tested negative by quantiferon in September of 2017. And after the joint outreach, patient came in for repeat testing on September 2022 and tested positive. This patient had a normal chest x-ray and got rifampin for 4 months, starting in October 2022, and got completed treatment. So there were a few other patients who were also identified with new LTBI infections, but this was a recent conversion that was identified through this testing. So in addition to the SRO outreach project, which is partly about raising community awareness about TB and TB testing resources, NEMS has a number of current initiatives related to TB, expanded screening for outreach for all non-US born NEMS patients who don't have prior TB testing on file, increasing in-house TB sputum evaluation for patients with abnormal chest imaging that is low risk, or patients with symptoms that could be related to TB. And then beyond baseline testing, there's still this question of, should SRO residents be tested routinely for TB? One thing that we found also during this outreach was because testing was offered to any resident of an SRO, including those that had negative testing in the past, there were many people who had negative testing in the past, and the repeat testing was negative as well. But it is, do we see high rates of TB test conversions among residents of SRO buildings? NEMS is looking at their data, and also since 2021, IGRA data, IGRA results, whether they're negative or positive, are now reported to the state via ELR. We'll also be able to retrospectively analyze in future years where there have been TB test conversions. Prior to 2021, the only reportable IGRA data was positive tests. So we'll be able to, looking forward, we'll be able to see conversions. And also additional initiatives at NEMS, improving LTBI treatment monitoring and completion through pharmacy support services. And a number of these are related to their TBASC projects. So sorry if I didn't do it justice, but this is Amy Tang and her team's work, and that is her contact information. Amy's not going to be able to join us for the panel at the end, but Gina Chen, who is the supervisor for the community health worker team, will be on our panel and can answer questions about the outreach project as well.
Susanna will now proceed to her talk, which is now going to look at active TB. So they're just giving us the work done on Latin speak about her work where she will be able to answer more questions confidently.
Thank you so much. So the next story that I'm going to tell is a series of stories, intertwined stories of a couple different families. And this is the story about TB care and prevention in an SRO setting, a set of SRO cases. And here again, I'm really, I did make these slides, but the work that I'm presenting is really the work of the entire San Francisco TB prevention and control section, and particularly the work of the communicable disease investigators who do the contact tracing and assist with the evaluation and management of contacts to people with active TB disease. So by way of introduction, I spoke about this a little bit earlier, but TB incidence in San Francisco is high compared to TB in California and TB in the US. Here you can see the incidence represented by the lines here. And of course, we know that reported cases went down a lot in 2020, but have been increasing since then. And that's been true for California as well as San Francisco, and the CDC will be releasing their numbers next week. But San Francisco's case incidence has been about 2 to 3 times as high as California's in recent years. Here's the same heat map that Amy had shared in her slides. This one is the one that will be released for San Francisco. Here you're getting the very first view of this map publicly. And again, in the last 5 years, Chinatown actually was the neighborhood with the highest incidence with 30 per 100,000. There are racial and ethnic disparities in San Francisco TB cases, and the most common country of birth is China by quite a lot, but Philippines and Vietnam born individuals also make a substantial part of our case load, as well as people born in Mexico. So I'm going to talk a little bit about the work of the disease investigation team. This is a really critical part of being able to stop the spread of TB. And in a very basic sense, the work of the disease investigators is to identify and find people who've been in close contact with someone with TB, to evaluate their TB risk based on exposure factors and screen for TB infection, preferably with an IGRA test, and then to accompany them through diagnosis and treatment to make sure that they get adequate diagnosis and treatment based on the results in order to control the transmission and ensure proper TB care. And that is a picture of our disease investigation team at our annual retreat last year. So investigating for recent TB transmission, this is the story of a family that lived in an SRO in a Tenderloin neighborhood. A contact investigation was conducted for family members of a patient who had started TB treatment empirically in TB clinic. This was a family of new arrivals from Guangdong, China. They arrived in late 2019, and they were living in an SRO in the Tenderloin neighborhood. I've put a picture of this pesky little virus here, just to give you some context for what was going on over this time period. In January of 2020, the father of the family was evaluated in TB clinic as part of immigration screening because he had abnormal chest imaging initially on immigration. At that time, sputum cultures, sputum PCR, and quantiferon were negative. However, shortly after his cultures finalized negative, in April of 2020, he presented with cough and upper respiratory symptoms. And because he lived in an SRO, he was admitted for a COVID evaluation. He was diagnosed and treated for community-acquired pneumonia. He had subsequent follow-up at TB clinic and follow-up regarding a nodule that had developed after the community-acquired pneumonia episode. In December of 2020, he was started on TB treatment, but developed some neurologic side effects. And after a reevaluation of his imaging and many additional sets of negative cultures, it was decided that actually the nodule was probably related to the pneumonia and not related to TB. He was reclassified as TB0 and his treatment was stopped. But in the setting of initiating his TB treatment per routine, a contact evaluation was initiated for his family. Both the mother and both children's initial TB tests were negative. However, as part of those contact investigations, we always recommend follow-up testing after 8 weeks, which was done for this family by their primary care doctor who was at NEMS. And to our surprise, 2 of the family members converted their tests from negative to positive. I'm seeing some nodding heads in the audience, and I think some folks may remember this as a case that was presented as part of the TB expert conferences that are hosted by Dr. Janice Louie on Fridays in TB clinic. So 2 of the family members had converted their test results from negative to positive over a very short time frame. Their QFTs had been negative in December of 2020, and they were now positive in February of 2021. This suggested an exposure during the November to January time period. The father of the family had a total of 9 sputa collected during that time period, and all of them were smear and culture negative. I think there were also 4 negative PCRs as well. So he was ultimately not diagnosed with TB. He was reclassified as ATS class 0. But what was going on with this family? Why did we have 2 TB test conversions in this household? So should we conduct a source case investigation? Source case investigation to look for the source of these infections. CDPH and CTCA contact investigation guidelines do recommend considering source case investigation for children with active TB disease. Well, no one in this household had active TB disease, but there's also a limited recommendation for source case investigation of associates to US-born children who are under age 2 with LTBI. Well, the child who had converted their test was 10 years old, but this was sort of outside of the scope of these guidelines because we really had very close information about when this TB test conversion happened, when these infections happen. So we decided in this case that we would pursue a source case investigation to look for, because there was documented recent transmission to 2 members of the same household. And in this case, this work had already been done as part of the initial contact investigation when the father was started on TB treatment. Our disease investigation team had gone to the home of the family and identified where they lived. And this is a photo from the hallway of the SRO building where they live, and their apartment there. You can see that there's shared kitchen and bath facilities in the middle by the stairway, and then there's the patient's room in the household where there were 2 family members with TB test conversions. This room was a room for the caregiver of the family's children. And it's a little hard to see, but in the back of the hall there's a stroller that was between the 2 rooms. Other kinds of things that disease investigators will look for when they're doing an evaluation are clues to who lives in the home or who might be visiting. Things like, do you see tiny shoes outside the front door? This would suggest that there are kids either in this home or who visit. So in this case, the closest contacts were evaluated not just with TB testing, but because we're looking for a potential source case also with chest x-rays. So the caregiver for the family's children also received a chest x-ray, which was negative. And her TB test was also negative. So both the mother and the caregiver had normal chest x-rays. The father had already been extensively evaluated for active TB disease, which he did not have. So no clear source of the infections was identified. But given the shared living facilities in an SRO, there was a lingering question: could another building neighbor have been the source? And this question at this time was one of the things that also was underpinning the collaboration between us and NEMS to think about doing outreach work in SRO buildings where there had been documented recent conversions. So the follow-up testing for this family actually had been done at NEMS, and the building that we were doing this investigation is one of those 6 buildings that was called out in the earlier slide that I showed from Amy. It was a building where there had been recent documented TB test conversions. So these are more images just to help you understand what the building looked like and what SRO buildings can look like. And these are the shared kitchen and bath facilities. Another thing that disease investigators will look at when they're assessing a space is ventilation. Most SRO buildings in San Francisco don't have any ducted or mechanical ventilation and usually rely on windows for ventilation. But as you can see, sometimes the windows are really tiny and there's almost never windows on 2 sides of a room for cross ventilation. So this case, this family, this story sat with us. And I wanted to sit with you while we think about this next case. So this next case is a 55-year-old man who also lived in the same SRO building in the Tenderloin, born in Guangdong, China. He'd been in the US since 2008, and he had a 30-pack-year smoking history. He was not routinely in care, according to his primary care doctor. He presented to his primary care doctor in June of 2022 with a productive cough for a few months and a weight loss. He weighed 85 pounds. Azithromycin was prescribed at that visit, and a chest x-ray was ordered. He completed it the next day. And well, you can see it here. But for those who are not clinicians, I will tell you that this is his trachea, meaning this is, which normally runs straight up and down, but you can see that it's pulled way over to the right side here. We call this the right. And his left lung is hyperexpanded. So there's a lot of scarring in addition to bronchiectasis and fibrosis. His right lung is being pulled over to the side by the degree of scarring and disease on that side. So the talk here is more about the overall story and not necessarily the clinical details of his case. But This is the care timeline, starting with presentation to care in June of 2022. So he had that initial chest x-ray. The provider was concerned and ordered a chest CT, which happened about 3 weeks later and is shown here, basically similar findings, extremely dense infiltrate on the right. This is the patient's heart that's pulled all the way over to the right side of his chest. And this is his left lung filling up, a lot more than half of the chest cavity here because he's being pulled over so far to the side. So he had a chest CT, which happened 3 weeks later. And at that time, he was referred to an outpatient pulmonologist. His outpatient pulmonology visit happened about 1 month later. The pulmonologist looked at the imaging, thought this looks like it definitely could be TB, and ordered sputa to be collected as an outpatient, and those resulted 4+ positive for AFB. I also wanted to just note that in the pulmonologist's note, there was a note saying the patient should not return to the office because he had not been vaccinated, presumably vaccinated for COVID-19. So he saw this pulmonologist only once. And after the smear resulted, the pulmonologist prescribed 4-drug TB initiation therapy, although at split doses, so not the normal once daily dosing. About 2 weeks later, the electronic lab report was noted for the positive smear and now growing culture with AFB by our staff. And the patient was contacted and these records were obtained. We were, of course, very concerned about the patient's condition and also the fact that his dosing was not prescribed appropriately and that he was a resident in a congregate setting, this SRO building with shared facilities. So for all these reasons, we worked on having him admitted to the hospital where he initiated a standard dose therapy. So that was his care timeline up to the point of diagnosis and initiation of appropriate treatment. But I wanted to take a step back from that to recognize this patient's health timeline. So on further evaluation, on further history gathering, he actually noted a chronic cough that began in the summer of 2020. That was followed by chest pain, feeling like something was stuck in his chest, and weight loss. So his admission weight was 84 pounds. That is a BMI of 13.6. He quit smoking in 2021 because he was worried about his health, as his respiratory health was deteriorating. He'd been a truck driver, driving to and from Los Angeles regularly, but he stopped working in January of 2022 because of his health. At that point, the only income in his family was from his wife, who worked as a caregiver. By the time we saw him, he hadn't left his home since June of 2022. And he was hospitalized in August, and he continued to be hospitalized through December of 2022 out of concern for infectiousness. So ultimately, he got 9 months of treatment, which included 4 months of an induction therapy and then transition to continuation therapy, which he got for 5 months. His culture conversion happened after 2 months, but his positive smears continued. And actually, he's continued to have positive smears on his post-treatment evaluation. So what's shown up there, that's actually his initial chest x-ray that I had already showed you. This is what his chest x-ray looks like now after he's been cured. So he's cured. He is much better than he had been. But as you can see, he's got really profound scarring in his lungs, and this is affecting him and affecting his respiratory function. So going back to the SRO, to the building, to this community that he's living in, you can see here where the family that I was discussing earlier lived, with the 2 family members who had TB test conversions live. And now you can see in the corner here, the apartment of this patient who had a cough that started in summer of 2020. These TB test conversions happened at the end of 2020 or beginning of 2021. So clearly there is more work to be done in this building. Our disease investigation team started by reaching out to the landlord to get contact information and names for people who lived in the building. And initially the building landlord was very reluctant to provide access to the building or any information. Education was provided to the landlord about, how this could benefit the people who lived there, et cetera. They were very reticent to do this. And ultimately a legal order was served to the landlord for names and contact of residents. And after that, they did provide access and ultimately were cooperative. Once our staff was able to get into the building, they actually had really great reception from the community, who helped rally other residents and gather other residents and provide information and help connect our team to the other residents who lived in the building. We also worked with our partners at NEMS to get a list of phone numbers for patients of theirs who lived in the building. So we were able to conduct phone outreach for people who weren't home when our team went to do door knock outreach in the building. So members of our team who spoke Cantonese and Mandarin went together to the building to do door knock outreach, and then follow-up letters were sent. On-site testing was scheduled, and it was done in people's rooms because the landlord was not able to provide a space for us to do testing in the building. But they were able to do the testing just in those, little rooms. And $15 gift card incentives were used to help engage people in care. Follow-up testing with primary care providers was arranged for 4 other residents who preferred getting their testing with their PMDs. There were only 2 residents who declined testing. Of the 11 neighbors who were tested as contacts, 8 tested negative. 2 had a prior diagnosis of LTBI, and they got chest x-rays, and those were both normal. They'd already completed LTBI treatment in the past. And then there was 1 who had a new positive IGRA and was also found to have a 2-centimeter chest mass. So that patient came to TB clinic and underwent evaluation with sputa, which were smear, culture, and PCR negative. And this patient is currently undergoing CT surveillance of that chest mass, a PET CT that was done to show that it was not avid and probably a hematoma, but it's under surveillance. So next, to be continued on the story for this patient. So the treatment decision for that patient is pending repeat CT. Both household contacts for this patient, the index that I'm describing, did test positive, and both were treated for LTBI. So in this setting, there are individual challenges and there are some community challenges. For this individual had 4 months of isolation, and we heard the discussion of isolation earlier today. I think this is perhaps the most difficult thing for most patients. This patient's wife brought him food in the hospital every day. But once he got out of isolation, there's also the stigma of returning to housing, and also prolonged disability, lost wages, and ongoing respiratory symptoms. I'm sure this list goes on. And then some community challenges. These are challenges that he experienced, but I think that everybody in this building was experiencing these challenges. Difficulty for public health and public services to access the building in order to conduct outreach. Also, difficulty prioritizing healthcare given the struggle to meet basic needs like housing, food, and safety. and difficulty accessing care, like advanced imaging and sputum studies, which took 2 months to get for this patient, even after he presented to care. And then also, this community provider had limited TB knowledge and also misunderstood their reporting obligation that resulted in some further delays in this patient's initiation on appropriate therapy. But there are also some resources that were afforded this individual and also that come from this community. So he was able to complete treatment in 9 months, which to me is kind of amazing, looking at his chest x-ray, that this man was cured of TB. He has no relapse to date. He also has close post-treatment follow-up with TB clinic, and he's been connected to comprehensive primary care, as well as ongoing care for underlying cardiac and now his pulmonary condition. And then resources from for the community, and also from the community, include that TB surveillance was conducted ultimately in their building, and care and prevention services were provided. Also, that we have the authority and that we have the infrastructure to be able to gain access to the building and cooperation from the manager. And also that we were able to access, we were able to utilize the capacity of primary care providers for these patients. Those patients that preferred to get testing and preventive services from their primary care providers were able to do that. And I think ultimately the tight-knit community in the SRO was really key to helping everyone on that floor engage with our staff and get preventive services. So just a few parting thoughts about this story. Contact investigation is a science, but it's also an art. Language and cultural understanding are deeply important. Location-based outreach has some advantages, but it also has some disadvantages, like privacy for the index or the family. There are available tools that can help SRO community authority figures, like the landlord, for example, understand and fulfill their obligations, while also building trust and empowering the community with knowledge at all levels. And basic human needs need to be met in order to prioritize preventive care and eliminate TB. So when I made this slide, it's hard not to put the names of every person who works in the TB prevention and control section, because really, as I went through these charts to put this story together, almost every name of every worker in our program was on the chart somewhere. But I did want to call out a few folks who worked very closely on these cases. The case managers for the 2 cases that were presented, including the one that ultimately rolled out, were Anna Lee Wong and Eva Chung. And a significant outreach assistance was provided by Chi-Wen Chen, who was a health worker too in our branch, although she's now in a different role. And Pubu Joga, who was the DCI who led the investigations for both of these cases, and really did the bulk of the work that I'm presenting and took all of the photos that you saw. So this is the whole team, the San Francisco TB prevention and control team shown here, and also our partners at MEMS who conducted the outreach, the joint outreach that was part of the initial slide set that I showed. And I think we have a few moments for discussion. Yes.
So, thank you, Susanna. I have about 10 minutes for questions and discussions. And Gina Chang is now going to join us virtually as well. Right?
Yes, and actually, I also wanted to invite Felix Crespin, who's the chief of the disease control and intervention section.
Hello.
Oh, yes. All right, I'm going to present myself. My name is Felix Crespin, and part of the tuberculosis program surveillance for the San Francisco Department of Public Health. I wear several hats, and one of these is I'm the point of contact when someone is being diagnosed with active TB. Could be outpatients providers or inpatients team call me to notify me about the new TB case. Also, another task that I do that I don't like that much is typically happens Fridays afternoon when somebody, usually hospital inpatient team, call me and say, "Oh, Felix, we have a patient here that's a big cavity and trying to leave AMA against medical advice. What are we gonna do?" And then I come up with plans with Dr. Graves and Dr. Louis and see what we can do. But usually that happens. And the other role that I do is I'm the supervisor of the communicable disease investigation. This is a big role in what we do and contact tracing. And I can probably just briefly mention some facts about SROs. Believe it or not, in San Francisco, there are about 500 SROs here. It's amazing. You can remember some pictures, some slides. There's a slide about the incidence of TB in San Francisco. There's two main parts of San Francisco. One is Chinatown, and the other one is Tenderloin. So these are the main focus of the places where we have more concentration of SROs. And the other part, the other part that I will probably mention very quickly is in the picture that everybody saw in the SRO, the family of 3 people, it's a discrepancy. I can see, and between the picture, the family, and the definition of SRO, single room occupancy. You see there are 3 people living in the single room occupancy. Sometimes that's what we found in every contact investigation. A family living in an SRO, you can see we do concentric circles, and we say, "Oh yes, good. We have one floor, 23, 22 rooms," but that doesn't mean 23 or 22 patients. That means probably by 3. So it's a huge endeavor doing any contact investigation in SRO. Usually we have like a 1 to 3 contact investigations every year. Thank you.
So that's a great lead in. Oh.
Thank you so much, Felix. Yes, we can take any questions. I don't know if we were able to get Gina. Okay, can we hear Gina?
This is a really basic question.
Yes. Hi.
Hi, Gina.
Is
Okay,
here.
so,
Yeah. Yes.
Great. Thank you so much, Gina.
A really basic question is, where do you get your funding for the incentives? And I really perked my eyes because I know I sit on the elimination committee for Massachusetts, and they're looking. So
that is a very interesting question. So the main funding for our incentives comes from CDPH, California Department of Public Health, through an annual subvention grant that we get. Historically, there was like a portion that was set aside specifically for incentives, shelter, and what's the F for? F is food, shelter, incentives, and enabler. And so we have that funding for incentives. Recently, this funding became much more difficult for us to use for gift card incentives because we've been limited to less than $600 per calendar year per patient, which when you're just trying to get people to come in for TB testing, that's plenty. $15 gift cards sufficed in this case. But for a patient where you're trying to incentivize them to take their medication, to prioritize that week after week, $600 goes by really fast. And when you're talking about a patient in isolation who isn't working, who needs to make rent, $600, it's just insufficient to really support people to be in isolation. So that's that's a specific to San Francisco County and our controller's interpretation, and it's only a recent issue, but in California, those FSIE funds are available to counties, and many counties are able to use them beyond $600 total in a calendar year to support patients.
I have a question. I like the concept of cure, but I'm not sure that exists. If you have someone that has latent TB with a negative chest X-ray, they comply with all of the prophylactic doses, there's no re-exposure, which is by itself probably problematic. Can you really say that it penetrated, and what, you have any guess what percentage of them could have a reactivation down the line?
So in a low incidence setting, treating someone completely for latent TB infection will reduce their risk of developing active TB by about 90%.
Okay,
so
still have...
in higher incidence settings, I think, you know, it's a different situation because you have a much higher risk of re-exposure. But in our setting, you know, we would expect a pretty substantial risk reduction. And also now that we've gone from using isoniazid as our, you know, workhorse LTBI treatment to using rifampin, I would expect that would be higher going forward, because we do have about on the order of 10% isoniazid resistance. So that may have been some of the historical data about, historical information about that risk reduction. We might expect more risk reduction with the rifampin-based LTBI regimens we're now using.
But that fellow with a whiteout of his right lung, I can't see that you could really feel that confident that that will never reactivate. I mean, does it really penetrate that well into the scar tissue, the granulomas,
I mean, I think that was
the cavitated lung, you know?
Well, I think, you know, that was a question that came up earlier on in his treatment, and that was why his induction phase was extended. I don't know if any of the clinicians in the room who did the care for this patient want to comment on, you know, for this patient and sort of the decision around stopping treatment after 9 months, and then this close monitoring that we're doing. Please.
We have many patients who come right out.
Unfortunately, it just reflects a delay in seeking care and a high-burden disease. We actually in San Francisco probably overtreat, frankly. So we get a lot of sputum, and that's on behalf of a really strong nursing team. And we make sure, especially if someone's not on a standard regimen, because we also are often using alternative individualized regimens because of adverse events or comorbidities that preclude using pyrazinamide or INH. We get a lot of sputum to ensure that they are clear, sometimes 10, 12, 15 sputum. We extend beyond. We follow CT scans as well as sputum and clinical symptoms. And actually, we've done pretty well, and we think our disease failure rate and occurrence is less than 1%. And that actually holds up throughout most of California. We don't do that.
There's TB still there?
You're right. There might still be TB there, but it is quiescent, at least as far as we know. I mean, all I can tell you is what our numbers are as far as disease recurrence, which is probably reflected by symptoms, right? So remember, our median age of patients is 60. Maybe if they live to 100, we might see it come back. I can't argue with that.
Thanks. And that was Dr. Janice Louie, the medical director for TB Clinic.
Hi, Susanna. It's really, and Felix, really great to hear about all these amazing activities with your outreach for SROs. I'm just thinking back to your opening scenario on how difficult that is and how challenging to find sort of two new, quantiferin positives in that family with the father kind of ruling out for TB. Did you guys consider sort of whether those were true positives or not, the quantiferon results, you don't have the quantitative results, but how did that sort of play into all of your, your analysis of that? Thanks.
Thanks for that question. I think this is a question that comes up a lot in the community, not so much in the context of disease investigation for TB, because really when we're thinking about whether or not something might be a false positive, we're thinking about what is the risk for the individual patient in front of us. I mean, when we're doing a contact investigation where we know there's been TB exposure, a positive is a positive, and we're done thinking about it. For this family, even though they were in the US at the time that this happened, we were also thinking about their context. They were living in a community of mostly non-US born people. And the caregiver was also non-US born. Everybody who lived on that floor was non-US born. And so I think we felt pretty confident that these were TB test conversions because of the community that they were living in. And again, looking in the neighborhood that they were living in, also, this is not a low incidence TB setting that they were living in. So we use, even though the father of the family ultimately ruled out for active TB disease, they still were risk screen positive for being at risk for TB infection.
Quick.
Oh, okay. Oh, too bad I have a lot of comments, but actually, yeah, thanks for the great presentation. Just a few points. Huge delay in diagnosis, but he was sick for a very, very long time. And those kids converted their tests way before he even came to your knowledge. But I was going to also just point out that, we get CT scans. I'm here with a lot of pulmonologists, but I don't know that we need to get CT scans on all these situations. In this case, perhaps just to see the extent of the damage, maybe, I don't know, but I just see that reflex CT scan happening all the time. So that's one point. And also, how long did you isolate this person for? Because you said that person remained smear positive for a long time.
Yeah. So I'm not sure that I dug so deeply into the clinical details as to why that specific CT scan was ordered, but I know that, there was discussion of whether or not surgery might be warranted, et cetera. And so I don't think it was for diagnostic purposes. But yes, we do a lot of advanced chest imaging, and I think it is helpful in being able to follow and understand the best treatment course, and also decide when treatment has been completed and be able to monitor in a setting like this. With respect to the second question you had. Isolation. Oh, yes, isolation. Yes. Well, actually, both Santari and I are serving on various components of the NTCA committees looking at the isolation guidelines revisions. And this was about isolation in a community setting, which those guidelines are going to speak to. In his case, because of his extensive burden of disease, we were following the existing current CTCA guidelines for reintroduction into a congregate setting. And so for him, because he never smear converted, he's still smear positive, we used culture conversion. In his case, I think he had an exceptional burden of disease. And I know that the new guidelines are going to have some nuance about, when to consider prolonging beyond 5 or 10 days of isolation. He may have fallen into one of those sort of exceptional categories given the extent of his burden of disease. But he was drug sensitive TB. So that was one thing that gave us a lot of confidence about the treatment that he was getting, that he was going to become non-infectious.
And how long will you follow him post-treatment?
That probably, I would think 2 years. I generally look to Dr. Louie to make those determinations. But.
He would get a year. Our standard is a year.
Okay, join me in thanking our incredible care team here. Thank you so much. Felix, Tina, really, I think this always strikes at the heart of what we do. Global is local. I know a lot of us do global TB research, but there's so much going on in our backyard right here. Now, I know we're at the end of the day. Hang with me. I promise this is worth it. Before I hand the podium back to Lisa and Payam to close us out, I have a call to action, as Cynthia would put it. So again, my name is Sophie Huddart. I'm a TB researcher here at UCSF, but more broadly here, I'm speaking as a member of the TB community here in the Bay Area. And as a TB researcher, I think like many people in this room, I knew that TB treatment was long, hard, difficult, painful, impacted the whole life of a patient. I read those papers, I wrote those papers. But what I did not realize until through events like today, we had interactions with the clinic staff where they described to us exactly what they and their patients are dealing with every single day. I did not realize how many people were struggling to get through TB treatment in my backyard, in my community in San Francisco. And so I'm so grateful for the clinic staff for coming here and so patiently and consistently explaining to us what they're dealing with. In 2023, we heard at the World TB Day, we heard from heroes in the flesh, TB nurses, about the heroic lengths that they go to make sure that their patients get through treatment and that they have their essential needs met during treatment. And they told us that they are often covering those expenses out of their own pockets. Today, we heard from Renee how even in the quote, best case scenario, isolation is so difficult on a patient and their family. We also heard so eloquently put from Susanna that so many patients, by the time they're diagnosed because of their health, they are really running through resources. And then we ask them to protect their family and their community by going through isolation. And that again causes lost income and requires additional resources that many of these families do not have. And so this made it very clear to us that there's an urgent need for responsive and flexible funding as the clinic's funding sources become fewer and further between and more mired in red tape. We needed a separate fund that could help cover these essential expenses for individuals going through TB treatment. And this is the impetus for a new organization that we are launching today. It's our birthday on World TB Day, called Together Against TB. We are founded by TB researchers for the TB community. We are an independent nonprofit. We're not associated with UCSF, even though many of us work here. We're not associated with the Center for TB. We're a real bona fide charity. We got the paperwork to prove it. And we are dedicated to supporting the mental, physical, social, and financial health of individuals impacted by TB. So as if that was enough announcement, it's our birthday, and here's what we're doing for our party, which is launching the TB Dignity Fund. This was highlighted as the most urgent need in consultation with the clinic, was a fund to support individuals in isolation during their active TB treatment to again meet those urgent, essential needs so that they can get through isolation and finish their TB treatment. The goal of this fund is to provide grocery and meal delivery, rides to medical appointments, and basic household and hygiene supplies. We'll prioritize patients who have lost income because of isolation and or have limited familial support or don't have safe ways to get themselves to and from clinic for those critical medical appointments. While these are essential expenses, they're not easy to cover from existing funding sources and public health funding available to the clinic, but they're not that expensive. They're so impactful, but these are not, multi-million-dollar expenses, right? This is groceries for the week. This is an Uber gift card. This is new socks for patients. And so there's my problem. This is our solution that we're proposing. And here is our call to action. You can donate today to this fund to help us meet the needs of patients. This is the QR code here. It will take you to a donation link. If you are in a position to be able to donate monthly, those recurring donations are essential to planning the financial sustainability of this fund going forward so that we can make that an ongoing commitment available to patients at the TB clinic. In addition to any donations, your attention and your advocacy are so valuable. So we're also asking to join our listserv here. You can sign up for a newsletter. We promise we don't email you that much, but you'll hear exactly what we're able to do with your funding, the patients we're able to help, and future opportunities to support us as we grow. I'll highlight here our board of directors. Probably have a lot of familiar names here. If you have any questions about the organization, we're all deeply, deeply passionate about this and would talk your ear off about how we can support and any questions you have about how we operate. Additionally, if you're interested in getting involved, you have donors you think we should talk to, you have an idea for a fundraiser, you want to be on our board, you can email us at togetheragainst.tb@gmail.com. Our home on the web for the time being, we will launch a website, but as I mentioned, we're brand new, is this Instagram account, Together Against TB, all excellent places to follow along. So I want to thank you in advance for your support. It sends such a powerful message to individuals that are impacted by TB and their families. As Renee said, it makes them seen. There's what they go through in order to protect their own health, their family's health, our community's health is not invisible. It also sends a powerful message to their care team that we see the work they're doing. We see the efforts that they go to get patients through TB treatment. And I want to send the message to those people that there's a whole community here that stands behind them. We have really ambitious goals to grow and meet a wide variety of needs of TB patients in the future. So we're very grateful for your support, and we hope that you'll join us on this journey. Thank you. And with that, I'm going to bring up Lisa and Payam to close out the day. Thank you so much.
I'm pointing to the back. It's been a long day. I'm going to say a few things and I'm going to let Payam close this out. But again, the 30th anniversary, our wonderful guests, still leading the way, Gisela co-founding as the lead of the San Francisco TB Control Program at the time, closing the day with the San Francisco TB Control Program, telling us more about why we should care. And I really wanted to call out both Susanna and Janice for being such wonderful partners, keeping this tradition of academia and public health going. And our California TB Control Program, you guys there hanging out in the back row, you guys, I mean you, really making all of the difference in what we bring across the region. It's a wonderful thing. And the next generation of this, the folks who are in this room, you guys make a huge difference. The FQHCs, CHIVO, more that we can do together for you to help contribute to the expertise, making what we do more relevant, it is going to make all of the difference. I want to do a shameless plug because I realize how many early stage investigators are here. So I'm in the middle of my 6-year term in the North American, so the union leadership. So I'm president for the next 2 years. And Devin is gone, but come to the union conference. I know this, the ones in your own region, because our focus is being that pipeline to Paris, baby. You start presenting. Throw your abstracts in there. Devin Jagannath was an early stage investigator winner a couple of years ago. It comes with a stipend. It comes with travel funds. Be a part of your own regional group and then get your face out there, get known, and move on to the Paris programs. So please do join up. Abstracts are closed for this year, but you can still come to the conference in Baltimore. But for next year in Vancouver, please do be a part of our community because you are, the next generation there. And we're so proud of you. So which means that I can announce the winner of the abstract. There were people in the audience and drum roll. Come on, guys. Tessa, what?
2024.
2020, the winner of 2024 abstract competition. Tessa Mochizuki. Really wonderful job. It's not easy to do, and you made it so palpable and understandable. And you're going to make a difference. So thank you for doing that.
We'll do the thanks.
The thanks.
Yeah.
We'll thank some more people. Well, I thanked Ken for coming as our keynote speaker. Still for everything. Still for everything, but really being the start of the Curry Center. Gisela being his partner in crime with this. We're so honored that you guys came and you made this happen. I certainly want to thank anybody else. There's so many, Cynthia, the afternoon crew bringing advocacy to our doorsteps, and the clinic, the clinic folks coming and making it real for us. So thank you all. The afternoon talks. What else am I supposed to say, Payam?
I think you've covered it. I think it's been another terrific World TB Day. It's hard to follow the impassioned speech that Sophie made. I guess what I'll say is that we are together against TB. That's all of us. And we will continue this journey of a fight against this horrible disease that affects people in our own local community and worldwide. I hope you enjoyed today's event. We'll have a planning committee very soon, probably formed for next year's event. And I encourage early stage investigators who were inspired by today's presentations and conversations to please reach out to Sophie and Paul and help us plan 2025. Again, I want to thank the planning committee for doing everything that you did. So that would be Paul Agongo, Sophie Huddart, Fatoumata Darbo, Chris Berger, Barbara Alonso, and Jeannie Fong. And another round of applause for them, please. It's a wrap. Thank you, everyone.